A very good morning to everyone in here, and a heart welcome to our esteemed speakers, insightful panelists, dynamic moderators, Merck Foundation alumni, distinguished representatives from renowned associations and societies, and dedicated healthcare professionals. We're all thrilled to have you here. Join us for this inspiring scientific session of the Merck Foundation Capacity Advancement Program. As we all know, our foundation aims to improve access to quality and equitable healthcare solutions in underdeserved communities, and that's done by strengthening the local capacities and enhancing clinical management processes through our various scholarship programs under the scientific session of Merck Foundation Capacity Advancement Program. I would like to introduce the moderators for the session today. Dr. Kingsley Bhaskaraj, who is the Scientific and Medical Manager, Merck Foundation. Dr. Selma Namutua, she is a Merck Foundation alumni for Namibia. Welcome, Doctor. We have Dr. Hilary Numa there. He's a Merck Foundation alumni of Liberia. And myself, Dr. Vaneshwari Bamania, I'm the Merck Foundation alumni Tanzania. We're glad to inform you that currently we're offering 44 critical and underdeserved medical specialties. And this includes programs for the Merck Foundation Capacity Advancement Program, including acute medicine, advancing practice in neonatology, advanced surgical practice, critical care, care of the older person, dermatology and clinical practice, emergency and resuscitation medicine, gastroenterology, internal medicine, infectious diseases, neuroimaging for research, neurology, neurosurgery, pediatric and child health, pediatric emergency medicine, respiratory medicine, rheumatology, stroke medicine, trauma and orthopedic medicine, and general surgery. And these programs are from the University of South Wales, Cardiff University, University of Buckingham, Edinburgh, and Queen Mary University of London, United Kingdom. You can visit our website at merckfoundation.com to find the list of all online programs. And please, you can submit your applications on or before 15 September this year. We're also excited to announce the new version of Merck Foundation app, which is now available on Google Play Store and Apple App Store. And with this app, you can receive timely updates on our various programs and initiatives. We encourage you to download it at your earliest convenience. So before we start this session, there are some housekeeping notes that I would like to point out. We would request all our speakers to kindly adhere to the allotted time. To avoid any disturbance on the ongoing session, all these online speakers are requested to kindly keep their videos and audios turned off until it's their turn. The entire scientific session would be recorded. Interpretation would be available for the entire session in French language. So you can please join us using the Zoom link and click on the interpretation button, which is right on the right side of your screens, using the translation feature. We also request all attendees to kindly note their questions down for the online speakers, and you can ask them towards the end of the session at the question and answer plan. We also encourage our online attendees to share questions in the question and answer sections, and few of them will be taken up based on the availability of the time. So I would first like to introduce our first speaker for the session today, Professor Dr. Ramesh Bhatt. He's an esteemed unit head of department of pediatrics at Manipal Academy of Higher Education in India. With over 2 decades dedicated service in educating and mentoring both undergraduate and postgraduate students, he has significantly enriched the field of pediatrics. So he has obtained a gold medal in OBGY during his MBBS, and he's also obtained a gold medal in MD Pediatrics at Bangalore University. He was awarded the best paper in hematology at the National Conference of Pediatric Hematology Oncology, chapter of the Indian Academy of Pediatrics in 2004. He's awarded a trainee scholarship fellowship in neonatology. His remarkable publication, record in prestigious national and international journal, underscores his commitment to advancing medical knowledge and excellence. So his topic of discussion today is respiratory distress in the child. So we'd warmly like to welcome Professor Dr. Ramesh Bhatt. The floor is yours. Welcome.
Good morning. I thank Dr. Kingsley Baswaraj and the Merck Foundation for this opportunity to speak today. Greetings from Manipal, India. With the permission of the moderator, I will begin my lecture on respiratory distress in children. Respiratory distress in children, this results when breathing does not match the metabolic demand for oxygen due to failure of oxygenation and or the ventilation. So it is characterized by signs of increased work of breathing in the form of tachypnea, use of accessory muscles and or chest retractions. So tachypnea is defined by the cutoff values in children. So in addition, head bobbing, nasal wearing and grunting are additional signs, especially in very young children. A respiratory rate that is inappropriately slow for the clinical condition may suggest the impending respiratory arrest, especially in young children. An abnormal pattern of respiration may also give clue towards the etiology of respiratory distress in children. So this is an example in a 3-month-old child with a increased rate, that is tachypnea, significant chest retraction, and there is intermittent grunt, suggesting that there is a impending respiratory failure. So this is another small infant with the, as we can see, the respiratory rate is so much increased with the, there is a bouts of cough. So most common reason for acute hospital admission in children is the acute respiratory distress. So it could be severe, or sometimes we may see them in the form of imminent respiratory failure. So hence, most of the times they may require non-invasive ventilation or invasive ventilation and transfer them to the pediatric intensive care unit for further management. The causes, treatments, and the prognosis vary quite widely. The important physiological abnormalities associated with respiratory distress in children are hypoxia, so decreased oxygenation in the blood, hypercarbia, increased CO2, difficulty with mechanics of respiration. It may be because of the airway obstruction, muscle weakness, or the discomfort. So disorders of control of ventilation, especially in case of trauma, especially head injury, or stimulated in case of metabolic acidosis. The another important condition which is very severe is the acute respiratory distress syndrome, ARDS, or it is called as PRDS in children. In this condition, there is diffuse alveolar injury resulting in impaired gas exchange, decreased pulmonary compliance, and increased pulmonary artery pressure. So it is a very serious condition. Results from several etiologies like the pulmonary infections, gastric content aspiration, smoke inhalation, environmental toxins, drugs, near fatal drowning, sepsis, trauma, chemotherapeutic agents, and others. So in the causes, we have many. So it could be within the respiratory system, may also be within the other systems. Etiology may not be immediately obvious at presentation. So clinical manifestation of respiratory distress depend on, in part, on the location of the disease process, even within the lungs. So hence, so when you are coming across a respiratory distress in a child, so the assessment includes the pentagon, that is consisting of airway, breathing, circulation, disability, and exposure. To give an example, child in respiratory failure, the airway may be unstable. So breathing, there may be impending respiratory failure. Circulation, there may be associated bradycardia, shock, cardiac dysfunction, wide pulse pressure. In the disability section, there may be altered sensorium because the disease is so much advanced, there may be hypoxia and altered sensorium. And in the exposure component, there may be high fever, color, or the rashes, depending upon the etiology of respiratory distress. So sometimes the respiratory distress may be life-threatening conditions. So any process that causes respiratory distress by compromising ventilation and or oxygen, so it requires early recognition and immediate as well as aggressive management sometimes. So the causes could be in the upper respiratory tract also, like the foreign body aspiration, angioedema from anaphylaxis, laryngospasm, hypocalcemia, or acute epiglottitis. These conditions may cause severe upper airway obstruction, and the stridor is the hallmark of severe partial upper airway obstruction. The common causes in children, what we see are the bronchiolitis, especially in young children, less than 2 years or so, and wheezing in the preschool child. Asthma is a significant condition worldwide, pneumonia. This is also seen in worldwide. So less common causes include interstitial lung disease, pulmonary aspiration, problems associated with the tracheostomies and the crew. Signs of impending respiratory failure warrant in most cases tracheal intubation and artificial ventilation. So management requires meticulous preparation to avoid complication during the induction of anesthesia, intubation, and ventilation. So these are some of the examples in which we came across the respiratory distress in children, the chest X-ray findings. 8-month-old baby with a left pleural effusion. There is a massive pleural effusion that was leading to severe respiratory distress in an 8-month-old infant. The 9-month-old boy with the bronchiolitis with widespread patchy hyperinflation and atelectasis, resulting in severe respiratory distress and hypoxemia, requiring the PICU admission and oxygen administration immediately. So 5-year-old girl with the dyspnea and hypoxemia. So we can see on the X-ray, there is a massive consolidation on the right side associated with the parapneumonic effusion, resulting in severe respiratory distress. The other one is the 9-year-old boy with a very short history, 3 days of fever, cough, dyspnea, and he was very tachypneic with chest retractions, and the oxygen saturation has gone down to 84% on room air. The X-ray findings were the only lobar consolidation. So another 4-year-old boy with cough, fever, and the respiratory distress, we can see the right lower lobe consolidation with parapneumonic effusion. So 2-year-old boy, it came with the recurrent respiratory distress. Once you treat and send them, again the child after some days comes back again. So here the X-ray is showing some different pathology. So they belong to the group what is called as CPAM or congenital pulmonary airway malformations. Because superadded infection may be there, you treat and send them home. Again, there is a chance for infection and they will come again. So they require some other treatment depending upon the type of CPAM in the child. So another 13-year-old girl with very sick respiratory distress, severe hypoxemia. So chest X-ray is revealing the left lower lobe consolidation and a massive empyema. That's why the child was very sick with the high temperature, hyperthermia, and significant respiratory distress, as well as hypoxemia. So she required the intercostal drain, and it has drained about 800 ml of thick pus. And the child became all right and we sent home. The asthma is a very significant condition in children. So bronchoconstriction and wheezing. So UK figures tell that asthma affects 1 in 11 children and it causes significant admission to hospitals and few deaths there also. Most of the time these deaths are preventable. So here in this condition, the variable airflow obstruction and airway hyperreactivity is the main pathology. In exacerbations, it could be infective or non-infective. So we should also consider there may be a possible viral infection causing the acute exacerbations. So management of asthma in children, British Thoracic Society guidelines includes oxygen. So method of administration of oxygen may depend on the severity. It may be a low flow nasal cannula or a face mask or a high flow nasal cannula. So nebulized beta 2 agonists, they are useful because there is a bronchoconstriction. Sometimes we may also have to add the anticholinergics if the response is poor. So corticosteroids may be required in case of severe cases. Those who are not responding to this line of management, so one may choose the magnesium sulfate, salbutamol, or aminophylline, depending upon the need. So most of the children may respond to these lines of management. So if not, so we have to optimize the management. Sometimes they may require the non-invasive ventilation. So this is controversial. Most often it may not be required. The ventilation is not easy in case of asthma children. America, especially, they use the bilevel positive airway pressure. So they found it more useful in these children with asthma. If there is a poor response, in rare circumstances, they may require intubation and mechanical ventilation. So next significant condition in children causing respiratory distress is the bronchiolitis. So most common disease of the lower respiratory tract infants in infants disease. So approximately 1 in 3 infants. So most commonly, this is caused by one single virus that is called as respiratory syncytial virus. Of course, there are many other viruses, including the influenza, parainfluenza, adenovirus, and recently there is an increasing incidences of human metapneumoviruses as well. So here, what is the pathology is the inflammation, mucus production, sloughing of the necrotic epithelial cells, resulting in obstruction of the small airways, hyperinflation, atelectasis, resulting in wheeze. So often they present with coryza followed by tachypnea, cough, crackles, and wheeze. So, and sometimes we may also see apnea, that is a cessation of respiration, especially in small infants less than 6 weeks old. So in this condition, prognosis is generally good and mortality is rare. However, in certain conditions, we must be careful. What are those conditions? So one is the prematurity, bronchopulmonary dysplasia, children with congenital heart diseases, neuromuscular diseases, immune deficiency, and those who are less than 3 months of age. So they may have serious disease. So we should evaluate properly these children. So initial treatment is just to clear the nostril if it is blocking. Use the supplemental oxygen as desired. Keep the SpO2 more than 92%. So they may require the nasogastric feeding. In severe cases, one may also require intravenous fluids. There are other therapies which are available, and some physicians are using these therapies. So chest physiotherapy, beta 2 nebulization, antibiotics, and steroids. Even in some centers of the US, they are using these sorts of strategies, but they are controversial. In a real situation, they may not be required. So depending upon the case, or if there is a associated comorbid bacterial infection, so one may have to use these antibiotics. Otherwise, in general, they may not be required. So if they do not respond to those things, if there is a progressive deterioration, so one can consider using the CPAP, continuous positive airway pressure, especially in cases of impending respiratory failure. So another option which is available is high flow oxygen therapy. So some of the studies recommend that this high flow oxygen therapy is useful, especially they may, in the RCTs, they found this is useful because they may prevent going to the severe respiratory failure. What are the signs of impending respiratory failure in these small children? Exhaustion evidenced by listless, decreased respiratory effort, and the cyanosis, impaired consciousness, SpO2 less than 92%, recurrent apnea, and worsening hypercarbia if you do a blood gas, increased CO2 retention in the blood. So this is a small infant, 50 days old, with a significant respiratory rate, more than 80 or so, with a significant chest retraction. So on the NRBM mask with the 95% of oxygen, still the level of consciousness not good. So signs of impending respiratory failure. Some of them may require intubation and mechanical ventilation for a short period of time. So next category is the preschool children. So they may have wheeze. Most cases are transient. Most episodes are managed at home or a primary care admission if child is unwell. So they will require a treatment in the form of supplemental oxygen, inhaled bronchodilators, few nebulizations may improve the condition significantly, oral corticosteroids, or if the response is poor, so inhaled corticosteroids, leukotriene antagonists, antihistaminics, and IV bronchodilators may be necessary depending upon the severity. So next condition is the pneumonia and sepsis. The incidence 14.4 per 10,000 children, all age groups. Here we have the pneumonia could be because of bacteria, viral, or sometimes maybe mixed also. In children less than 2 years of age, so the viral and bacterial ratio may be 50-50. So in older children, bacterial pneumonia becomes more common, and all of us know that it is the pneumococci, which is the most common organism causing this pneumonia. Nowadays, there is a vaccine available for this pneumonia, Streptococcus pneumoniae. So this PCV vaccine is available, so that pneumonia caused by that organism is also quite low. So in these cases, the history is very important. There may be associated fever or respiratory distress may be there. So they will require the treatment in the form of oxygen and appropriate antimicrobials, because this is most often caused by the bacteria also. Improvement is usually rapid, prognosis is generally good. So if there is a lack of improvement within 48 hours or persistent high fever, we have to reassess because there may be complications. So those complications include the lung abscesses, pleural effusion, or empyema, which can occur in less than 1% cases in overall, or in the cases who are admitted, especially in the ICU, the incidence of these complications are quite more. It may come up to 40% or so. And the common organisms in such instances are the Staphylococcus aureus and the group A Streptococcus. So we have to modify the antibiotic therapy based on these organisms or the available culture reports. The next condition is the chronic aspirations. The frequent underlying cause of recurrent pneumonia are difficult to diagnose in these cases. So undiagnosed tracheoesophageal fistula, laryngeal cleft, craniofacial abnormalities, and we commonly come across this GER, gastroesophageal reflux. This is not an infective condition, but because of the frequent aspiration, they will also have tachypnea, chest retractions, and the respiratory distress. So another important condition in children is the neuromuscular diseases leading to these chronic aspiration syndromes. So if undiagnosed, these cases, untreated, recurrent pneumonia leading to chronic lung disease, bronchiectasis, and progressive respiratory failure. So they need to be identified. So treatment includes the supplemental oxygen, appropriated targeted antimicrobials, and if possible, consider the underlying disease and have the remedial measures for those things. So respiratory distress in children could be because of the non-respiratory causes as well. So it could be the decompensated congenital heart disease likely to be a respiratory distress. A thorough assessment of all systems in all children hence is vital. So this is an example of a non-respiratory cause of acute respiratory distress. There is a significant abdominal distension with ascites. So there is a respiratory compromise. The causes may also differ depending upon the lung pathology. This is a 14-year-old boy, right lower lobe consolidation with a massive emphysema. So we can see how fast he is breathing. He is breathing at a rate of 80 per minute with a temperature of 104 degree Fahrenheit. So when we took X-ray, it was a massive empyema. About a liter of pus was drained and he became all right and sent home. So chronic lung disease could be because of obstructive, restrictive, both. It may be complicated by superimposed infection. One important condition in children is the bronchopulmonary dysplasia. So this is common in the babies who are born less than 30 weeks of gestation with a low birth weight, very low birth weight. This is a common condition in them. So why it is important is it can cause morbidity and mortality. Usually they develop the pulmonary hypertension. This is an independent risk factor for mortality in such children. So sometimes there are cases like children with the tracheostomy. So they could be because neuromuscular disease, respiratory disease, congenital malformation of the airway, lungs, or heart, craniofacial syndromes, acquired subglottic stenosis. These children, tracheostomy presenting with respiratory distress, it could be because of the airway obstruction, tracheostomy problems like a large leak, or the primary lung pathology itself. Next is the management of the pediatric respiratory distress. So as we told, the assessment is very important. Mostly it's clinical signs of impending respiratory failure, severe respiratory distress, mostly without the blood gas. This is possible. So if the facility is there, one can also obtain the blood gas. It will also help in optimizing the treatment. Should prompt an intervention. So the children may require non-invasive or invasive ventilation. So one must be careful in children with myopathy who may not demonstrate the increased work of breathing, but they may be very sick, especially the neurological conditions. So intubation, in certain cases, it may be required, should be determined on a case-to-case basis, depending upon the cause of respiratory distress, predicted airway difficulty, equipment and available personnel, and the risk of aspiration. So some of the prerequisites include the ETCO2 monitoring and preparation of emergency drugs in advance, correct dose, atropine and adrenaline. If there is a hemodynamic compromise, often this is the case. So one may need to have 10 to 20 ml per kg of fluid bolus, which is available. And we should also have a intravenous access. Sometimes it may not be available, possible in emergency situations. So one must be prepared for the intraosseous line also as an emergency measure. So intubation, certain drugs are used for induction. So especially the ketamine, fentanyl, thiopental are useful. Propofol is rarely used. So neuromuscular block will provide optimal intubating conditions. Tracheal tubes one can select. So in children, we have both the cuffed and uncuffed endotracheal tubes. So depending upon the age, especially above 8 years, the cuffed endotracheal tubes are used. The advantage is these are preferable, especially when there is high resistance of the airways. So that is especially in asthma cases. So otherwise it may give rise to leak and suboptimal mechanical ventilation. So the laryngoscope blades are also important. So straight and curved blades are available. Young children, we often use the straight blades. So beyond certain age, this curved blades are useful. So pre-oxygenation is very important, especially the children who require the endotracheal intubation. So it may be most appropriate to continue the mode of delivery of oxygen currently in place in settled children. Otherwise, if you disturb, they may go for severe hypoxemia. This is the one point to remember in child with respiratory distress requiring endotracheal intubation. So there is a concept called rapid sequence intubation. It increases the risk of hemodynamic instability and hypoxia. Risk assessment must be performed on a case-by-case basis. Some strongly recommend this. Some discourage this one. Some argue that this RSA has no place in pediatric practice. So this may be useful, especially when the children are awake and struggling. So then it may be available. In an unconscious child or a neuromuscular disease, that may not be required. So it has to be considered on a case-to-case basis. So post-intubation care requires sedation and neuromuscular block. It may be in the form of midazolam, morphine, fentanyl, or a ketamine. So propofol is avoided in some centers because of the propofol-related infusion syndrome or PRIS. And of course, in such children, the nasogastric tube insertion will help to relieve the gastric insufflation. So chest X-ray is important to know the position of the tracheal tube and also to rule out the pneumothorax. The ventilation strategy, the lung protective strategy, adequate gas exchange at the lowest pressures and volumes, and one must think of avoiding the alveolar trauma. This is very important. Next slide. So these are the common settings one can go for. Once the child in respiratory distress required intubation, so then following the intubation, so optimizing the ventilation is very important. The tidal value may be in the 5 to 7 ml per kg, plateau pressures of less than 30 centimeters water, PIP of less than 35, PEEP around 5 to 7 centimeter, I ratio of 1:2. So oxygen may be titrated so that you keep the SpO2 more than 92%, or if in the conditions pulmonary hypertension and brain injury, one may target slightly higher SpO2 of no more than 94%. The frequency depends on age and avoiding the barotrauma. Regular chest physiotherapy and suctioning are vital in children who require mechanical ventilation. So there are some disease-specific considerations. So bronchoconstriction, this may really cause trouble in ventilating a child, especially in bronchiolitis, preschool wheeze, or the chronic lung disease. So here the ketamine may be useful because it may provide some bronchodilation. So anticholinergics may decrease the airway secretions, atropine or glycopyrrolate, very important to consider. And also the cuffed tracheal tube, it will help to prevent the leak. So low ventilatory frequency, extended expiratory time, and a low extrinsic PEEP, these are helpful, especially when we are ventilating a children with asthma. So neuromuscular blocking agents and the IV bronchodilators are helpful when you are dealing with children with respiratory distress and a bronchoconstriction related lung pathology. So pneumonia and sepsis reduce the dose of inducing agent to prevent the precipitant decrease in the arterial blood pressure, very important. If there is a circulatory compromise, ensure adequate volume resuscitation, inotropic agents, and vasopressor before induction of anesthesia. Otherwise, there may be a precipitant fall in the blood pressure and the child may become very sick. So patients with a tracheostomy in respiratory distress, so assess the patency of the tracheostomy, consider positive pressure ventilation, consider upsize or change the tracheostomy tube because the requirement might have changed there. Consider their complex medical background. So respiratory distress may be because of some other reasons for which the child underwent tracheostomy. So apart from this, the child with respiratory distress, one we have intubated, so may require other strategies, especially when there is a failure of oxygenation despite best practice ventilation. In such cases, we have few modalities. One of them is high frequency oscillatory ventilation. So pediatric acute lung injury consensus conference says that when the plateau pressures required to ventilate or optimal mechanical ventilation greater than 28 centimeters of water, it may be worth considering the HFOV. There may be some benefits. The another strategy is inhaled nitric oxide. So this is helpful because quicker time to cessation of mechanical ventilation and avoidance of other interventions such as high frequency ventilation and ECMO. So it may avoid that. So this may be useful, but this was especially helpful in neonates with the respiratory distress syndrome, not become very popular in pediatric age group. So prone position, which has gained popularity during the COVID time, this also may be helpful, but one must always be careful. So potential hemodynamic effects of the prone position, catastrophic loss of secured airway when you are changing the position of the child. So one must be very careful. Predicted difficulty in securing the airway while maintaining oxygen. These are all the very, very important aspects to consider. Of course, this prone position will help to ventilate the posterior lobes of the lung much better. So it is useful, but one must be very careful about all these other parameters. The last one is the ECMO, extracorporeal membrane oxygenation, especially when there is a continued severe respiratory failure. So PF ratio less than 60 to 80, or the oxygenation index goes more than 40 despite less invasive therapies. So this is going to be useful. So presently there is no evidence of survival benefit when you consider this. This may be available only in the advanced centers. So as a last option to save the child. Thank you for patient attention.
So our second speaker this morning is Professor Dr. Chandrasekhar. He is a professor and unit head in the Department of Medicine at Kastuba Medical College, Manipal Academy of Higher Education, Manipal, India. His contributions to academic medicine and research has made a substantial impact on enhancing clinical practices and patient outcomes, especially in the area of infectious diseases. He is currently leading several ongoing research projects exploring topics such as prevalence and predictors of kidney dysfunction in patients with leptospirosis. He is also involved in a SNAP study, and he's had many national and international journal publications, research focusing on sepsis, dengue, gut microbiome's role in tuberculosis, and he's also co-authored books such as Gut Microbiome and Probiotics for TB and Pathogenesis and Pathophysiology of COVID-19. So we would like to welcome Prof. Please, the floor is yours. Come and present. Welcome.
Yeah, good morning, everybody. So I thank Merck Foundation, the organizing committee, to give me an opportunity to, give a talk on nosocomial infections in ICU. So this is I found this very interesting topic. I'm sure there are some physicians here. I am from Kasturba Medical College, Manipal Academy of Higher Education from Manipal. Now, my contents of my topic is I'll be talking about, what exactly is nosocomial infections. What is the impact of nosocomial infections in the ICU setting? The ICU specific infection rates in the developing and developed countries, types of nosocomial infections in ICU, and pathogens which are very commonly involved. Risk factors in ICU setting, pathogenesis, management, and prevention strategies. So I'll be quickly touching on these aspects. Now, these nosocomial infections are hospital-acquired infections. So these are the infections that the patients acquired during their stay in the ICU setting or in the hospital, which is not present at the time of admission to the hospital. It occurs 48 hours or more after admission to the hospital. Now, what is the impact of nosocomial infections in the ICU setting? Now, majority of the patients in the ICU settings are immunocompromised, or they are having some comorbidities, so making them more susceptible to ICU infections. And it also increases the rate of complications which contribute to higher morbidity and mortality. Most of the patients in ICU, they require a longer stay in the ICU due to additional treatment, monitoring, and supportive care. So this leads to bed shortages and can delay the care for other critically ill patients who need ICU support. Financial burden is a major problem in the resource limited settings, and managing these infections are often the cost of managing these infections are quite high. especially in the resource limited settings. So, we are all aware that, ICU is it's a high risk area for the drug resistant organisms. So that is because of the frequent use of broad spectrum antibiotics. Majority of the patients are started empirically on broad spectrum antibiotics. And if the patients are unstable, it is continued for a little longer duration of time. So that is it's one of the very important risk factor for the drug resistant organisms. So making the infections very hard to treat, increasing the length of stay in the hospital, cost as well as a mortality rate. Now, just a brief view on the global burden of nosocomial infections. So this is very significant in both the developed as well as the developing countries. Now, in the developing countries, including Africa, the infection rate in ICU is almost about 15 to 40%. So, and this is still higher in the resource limited settings because of inadequate infection control measures and because of the limited access to antibiotics and poor healthcare infrastructure. I'm sure you all agree with this, right? Okay, and some of the common organisms which are responsible for the drug resistant, some of the organisms we frequently encounter in ICU, drug resistant organisms or Acinetobacter, which is a major pathogen in ICU, especially in the developing countries, and in India, it's still a major pathogen in the ICU setting. We have a lot of problems in treating this Acinetobacter infection. And in the developed countries, we see more of a gram-positive organisms. And of course, gram-negative organisms are also going up. The rate of gram-negative organisms are going up in the developed countries as well. So according to the CDC from Europe, around 8.9% of the hospital patients in Europe experience at least one healthcare associated infection. And the significant proportion of these infections occur in ICU because of the invasive procedures and extended hospital stay. And there was a recent systematic review, which is actually published in, Intensive Care Medicine 2020. So what it says is the incidence of ICU-acquired sepsis is higher in the developing countries, particularly in Africa and Southeast Asia, contributing to increased ICU mortality rate, with some regions reporting up to 60% of the ICU deaths related to healthcare-associated infections. So managing these infections in the resource-limited settings is really challenging due to the overuse of antibiotics, inadequate infection control measures. This contributes to antimicrobial resistance. Now, these are some of the common types of nosocomial infections we come across in ICU. So first is, ventilator-associated pneumonia, catheter-associated urinary tract infections, central line-associated bloodstream infections, surgical site infections, and Clostridium difficile infections. So I'll be touching more on this ventilator-associated pneumonia, catheter-associated infection, as well as the central line-associated infections. Okay, being a physician, and just a brief on this other infection, surgical site infections and Clostridium difficile infections. Ventilator-associated pneumonia is infection of the lung tissue that develops 48 hours or more after intubation in the mechanically ventilated patients. So these infections are usually due to aspiration of secretions and colonization of the lower respiratory tract in the intubated patients. And these are some of the common organisms which are associated with the ventilator-associated pneumonia, that is Pseudomonas, Staphylococcus. In our setting, we see less of Staphylococcus infections in ventilator-associated pneumonia. Klebsiella as well as Acinetobacter, it's a major pathogen. And these are some of the risk factors: prolonged ventilation, frequent sectioning, which is actually required for the patients, but if it's not, handled properly with if it's done with aseptic precautions, it can add up to the problems and handling of the ventilator, frequent handling of the ventilator. And of course, these are more common in diabetic patients with the comorbidities and in patients with a chronic lung disease, kidney, as well as chronic kidney disease. Now, this is again a major problem in the ICUs as well as in the when the patient gets admitted in the wards. This is an infection that develops in a patient who has had an indwelling urinary catheter in place for more than 48 hours. So this is primarily due to the bacterial entry along the catheter leading to colonization as well as infection of the urinary tract. And these are some of the common pathogens we encounter. E. coli, very, very common. So Enterococcus species, not very common. Candida species, again, not very common. And Pseudomonas, again, more common. Now, again, the risk factors for this is prolonged duration of catheterization. So frequent manipulation of the catheterization as well as comorbidities. Diabetes, among diabetics, it's very common. Now, this is again, it's a major problem. Central line associated bloodstream infections in ICU. This is an infection that occurs in a patient with a central venous catheter that has been in place for more than 48 hours with no other identifiable source of infection. This is again due to entry and colonization of microorganisms on the catheter surface or at the site of insertion leading to bloodstream infections. And the major pathogens here is MRSA, as we all know, and coagulase negative staph, enterococci, as well as candida species. Risk factors again, long duration of catheter and frequent manipulation of the line. And again, in immunocompromised state, it is more common in patients with the diabetics and other comorbidities. Now, surgical site infections, it's the same definition. It occurs at or near the site of surgical incision within 30 days of the procedure or within 90 days if the prosthetic material is placed. Now, this is again because of the contamination of the surgical wound by microorganisms during surgery or post-operatively leading to infection at the site of incision or in the deeper tissues. Now, the common pathogens which are associated with the surgical site infections, again, it is MRSA, MSSA, MRSA, coagulase negative staph, E. coli, and Pseudomonas. And again, the risk factors being diabetics, it's very common, immunocompromised patients. We get a lot of rheumatological problems on steroids. So these patients, again, with, immunocompromised patients with the diabetics, vasculitic patients present with ulcers, we get these problems, they are referred to surgery. Now, again, the environmental factors are also the contributing factor. Operating room sterility, surgical team adherence to infection control practices, all these counts. These are some of the important risk factors for surgical site infections. Now, Clostridium difficile infections is infection of the colon that is caused by toxin-producing Clostridium difficile bacteria, is often because of the prolonged antibiotic exposure that leads to inflammation, and in severe cases, it causes colitis. So what happens is when the antibiotics are used for a long duration of time, it disrupts the normal gut flora and it allows the spores of the Clostridium difficile to colonize the gut, produces toxins, and they cause inflammation resulting in diarrhea and colitis. And these are some of the risk factors which I have shown here in my slide. Recent antibiotic use, especially broad spectrum antibiotics when it's used for a long duration of time, prolonged hospitalization, and old age patients are some of the risk factors, and of course, diabetics. And these are some of the commonly involved pathogens. Staph aureus, I just want to reiterate that it is more common with the CLABSI infections and surgical site infections. And we are having a lot of problems with MRSA, especially which is associated with the CLABSI infections and Enterococcus species. This is again a new problem. A lot of patients, we have this problem, especially with catheter-associated infections. So when they are put on antibiotics for a long duration of time, we see that some patients don't respond. That is because of the vancomycin resistance. Okay, they acquire when the patients are treated with multiple antibiotics. So these vancomycin, they acquire some genes, vanni and van genes from the other bacteria. Okay, and that can alter the cell wall. So it can contribute to resistance. This is again a major problem we usually seen in patients with catheter-associated infections. And Pseudomonas is again a major gram-negative pathogen. It's very difficult to treat the resistant organisms. very difficult, which I'll be, showing in my future slides. So what are the problems we encounter with the resistant organisms? And of course, I told you, Acinetobacter is a major problem, especially with VAP infections in long-term ICU patients. So frequently they are resistant to multiple antibiotics, and E. coli frequently associated with the catheter-associated infections. Again, we have seen some, antibiotics which actually don't work for these infections. Candida infections more common with the CLABSI, catheter-associated central line related associated infections, and we see a lot of these multi-drug resistant organisms in ICU. Okay, which I'll be discussing later in the few later slides. And these are some of the important factors, risk factors in the ICU setting. So whenever you start the patient empirically on antibiotics, we always keep this in mind. So what risk factors do the patient have? So depending on the risk factors, we initiate appropriate antibiotics, and again depending upon the local susceptibility pattern. Now, in immunocompromised patients, we generally start the patient on very broad spectrum antibiotics, and then we tailor the antibiotics according to the susceptibility pattern based on these culture reports. Prolonged ventilation patients, this is a major risk factor. And again, longer ICU duration, that also increases exposure to potential pathogens, increases the risk of acquiring infections like CLABSI, catheter-associated infections, as well as ventilator-associated pneumonia. And of course, the use of catheters, central lines, and ventilators, these are all, they provide a direct access for the pathogens. It increases the risk of infections. And anyway, I've told you about, surgical procedures. Patients who have undergone surgical procedures are also at an increased risk for these infections, surgical site infections. This is again a major problem in the resource limited settings. Pathogens can spread from one patient to another via contaminated surfaces, equipments, healthcare workers. So poor adherence to hand hygiene is again a risk factor. So, when the proper infection control protocols are not practiced, significantly increases the risk of infection transmission. And overcrowding. This is again a major problem in most of the academic institutions. So overcrowding in limited space can facilitate the spread of infections, especially in the resource limited settings. Now, I will not, these are, I think you're all aware of this. These are some of the modes of transmission. Inadequate hand washing that facilitates the spread of pathogens from one patient to another. ICU, in the ICUs, these pathogens can survive on the contaminated surfaces like bed railings, door knobs, medical equipments, ventilators. So these medical devices, ventilators, catheters, endoscopes, they become the source of infection if they're not properly sterilized. So in ICUs, we have a lot of problem with Acinetobacter infection. Again, this is a major problem. One of the major reason for the patients not responding to antibiotics. Some of the microorganisms, they form biofilms on the surfaces of the invasive devices. Okay, this is the reason for the patients not responding. It protects microorganisms from the host immune response, making infections very difficult to treat. Okay, biofilms is a significant cause of persistent infections in the healthcare settings because they are difficult to remove. They act as reservoirs for recurrent infections. And some of the common biofilm associated pathogens are Staph epidermidis, Candida species, Pseudomonas, as well as E. coli. And of course, before we start the patient on antibiotics, we make sure that we get a blood culture. And if a patient has urinary tract infection, we take a urine culture, blood culture. We do imaging studies prior to, putting the patient on broad spectrum antibiotics. And of course, biomarkers are frequently done in ICU. So these are the biomarkers which are frequently done in our ICU CRP and procalcitonin along with the routine investigations. Okay, and identifying specific organisms and their antibiotic sensitivity is a very key for targeted therapy. So initially, empirically, we start the patient on broad spectrum antibiotics, and then we go for a targeted therapy based on the culture sensitivity report. So in cases of ventilator-associated pneumonia, in ICUs, we start the patient initially on broad spectrum antibiotics after drawing blood culture or cultures from the appropriate sites. So these are the frequent antibiotics which are recommended and we use. Piperacillin tazobactam, meropenem, cefepime. So if the patient is hemodynamically unstable, we prefer to start the patient on meropenem, carbapenems. If the patient is not having hypotension, if the patient is hemodynamically okay, then we prefer to use piperacillin tazobactam. But in case if the resistance to carbapenem is suspected, then we, after drawing appropriate cultures, we start the patient in colistin or polymyxin. So this high dose sulbactam is started only after having the culture sensitivity report. So if MRI suspected, then we use vancomycin or linezolid. And once the culture sensitivity report is available, then we de-escalate the antibiotic. We use a specific antibiotic, we narrow down the antibiotics to minimize the drug resistance. So as I told you, this is a major problem, carbapenem resistant Acinetobacter baumannii. So in majority of the resource limited settings, this is a major problem. And I just want to tell you that even in Manipal, Kasturba Hospital, Manipal, we have a lot of problem with these Acinetobacter infections. Now, so what happens here is the mechanisms for resistance is these crab infections that produce oxide type of carbapenemases which break down these antibiotics, carbapenems. Okay, this is one mechanism, and the second mechanism is due to the efflux pumps. These are actually very important. These are present in the host cell as well as in the it's present in the organisms. Bacteria. So if there is any alteration in the efflux pumps, this can also contribute to resistance as well as porins. These are porins or protein channels. Okay, this is again present in the gram-negative bacteria. If there is any disturbances in the porin structure, can also contribute to resistance. So these are the major mechanisms which contributes to resistance in cases of the patients not responding to these usual antibiotics. Now, in these cases, once we have the culture sensitivity report, empirically, in these cases, we start the patient on polymyxins or carbapenems. In cases of urinary tract infections, we don't use polymyxins. We use colistin along with high dose. Once the culture sensitivity report is available, we prefer to use high dose sulbactam because it has an advantage of having an intrinsic activity against Acinetobacter species. So in cases of these are the combination of drugs we prefer to use, polymyxin along with high dose sulbactam. Sometimes, depending upon the affordability of the patients, we prefer to use tigecycline, or if the patients are not very affordable or based on the culture sensitivity report, we prefer to add amikacin. So this combination actually works. It works very well if the patient on diol therapy are not responding well to this infection, Acinetobacter infection. So what I'm trying to tell you here is, these are from the guidelines. I'll show you some references. So in a patient with Acinetobacter infection, we add polymyxin or colistin along with high dose sulbactam. And if the counts, we monitor with the counts or we monitor with the CRP, inflammatory marker, and we find that the counts are not improving, we find that the inflammatory markers are increasing, it's not improving, then we prefer to add another drug, that is amikacin or tigecycline. Tigecycline is very expensive. So we think twice, before putting the patients on TG. Okay, so there are some literature saying that amikacin works very well in combination with polymyxins or colistin with high dose sulbactam. There are some references which I'm going to show you. So this combination therapy enhances bacterial killing, reduces resistance development. Okay, this is one nice article which is published in Clinical Infectious Disease, May 2023. Navigating available treatment options for carbapenem-resistant Acinetobacter infection. So what it says is, this highlights that crab infections poses major challenge, particularly due to diagnostic uncertainty and suboptimal treatment options. So polymyxins, high-dose sulbactam, tigecycline, amikacin are frequently used, often in combination to maximize bacterial killing and reduce resistance. Okay, so this is one nice article. It shows that, combination therapy works well in cases of crab infections. There is one more article. There is one more, guidelines from the Infectious Disease Society of America 2024. So what it concludes is, management of crab infections requires a multifaceted approach, often involving combination therapy. So they have found, these guidelines recommend polymyxin, high-dose sulbactam with tigecycline or with amikacin. So that remains a cornerstone agents, but their use must be carefully considered due to potential for toxicity and resistance, especially this polymyxin. It has some neurological toxicities. Now, one more problem we encounter in ICU is CRE, that is carbapenem-resistant Enterobacteriaceae. So this is again a major problem. So apart from crab infections, this is one more infection which we come across very frequently in ICUs. So these are Klebsiella, E. coli, as well as Enterobacter species. And these are resistant to carbapenems due to the production of enzymes, carbapenemases. So these break down carbapenems, like, other resistant mechanisms due to porin loss. Okay, so I told you porin is a protein structure. It's a protein channel. So if there is any problem with the porin channels, it can contribute to resistance. This is again one more contributing factor for resistance in cases of CRE. So how do we manage the CRE infections? The CRE infections are slightly different. So generally, there are something, I think can I go back to, how do I go back to the previous slide? See this, the most common carbapenemases are KPCs, NDM, and OXA48. Okay, these strains are resistant to the usual antibiotics. Okay, so I want to reiterate again that the most common carbapenemases are KPCs, NDM, and OXA48. So we have a lot of problems with KPCs and OXA48. So this problem is there in most of the resource limited settings. So they may not respond to usual antibiotics. So I just want you to remember this: KPCs, NDM, and OXA48. Okay, for CRE infections. Now the management is slightly different here. So in cases of CRE strains, especially KPCs, this combination works very well. Ceftazidime, avibactam with high dose astrionum. This is a drug which we usually use in cases of KPC producing organisms. Okay. Now there is one more new combination of antibiotic which is available in India. To use this antibiotic, we need to get a clearance from the Infection Control Committee. So there is a combination of meropenem with vaborbactam. This is also useful for the KPC producing organisms. It's quite expensive. So this combination is also available. And but otherwise, for most of these NDM and OXA48 strains, we prefer to use polymyxins with high dose sulbactam. Okay, with amikacin or without amikacin. Tigecycline is not good for bloodstream infections due to very low serum concentrations. It is suitable only for intra-abdominal infections. So I want to tell you again that tigecycline we prefer to use only for intra-abdominal infections. If we find CR infections, okay, with the intra-abdominal source, we prefer to use tigecycline. So we don't use amikacin. Okay. So if a patient has renal failure, acute kidney injury, or in patients with a chronic kidney disease, we prefer to use tigecycline over amikacin as a third drug. And in these patients, we prefer to use polymyxin instead of colistin. Colistin, high dose sulbactam, along with tigecycline. Now, fosfomycin is preferably used in patients with a lower urinary tract infections caused by CRE. Okay, for the upper urinary tract infections, it doesn't work well. Now, this is one nice article which is published in BMJ. Efficacy and safety of ceftazidime avibactam versus polymyxins in the treatment of carbapenem-resistant enterobacteriaceae infection. There is a nice systematic review and meta-analysis. What it concludes is ceftazidime avibactam is more effective and safer than polymyxins for the treatment of CRE infections, especially for the bloodstream infections. Okay, so this is what we follow in our hospital ICU setting. Okay, now regarding this management of catheter-associated urinary tract infections, we empirically start the patient on broad-spectrum antibiotics to take care of E. coli, Klebsiella, as well as Proteus mirabilis. So we use piperacillin tazobactam. If the patient is hemodynamically stable, if he is admitted in the ward, we prefer to use ceftriaxone. If the patient is admitted in ICU, we prefer to use broader spectrum antibiotic. For the resistant organisms, we use carbapenems. And once the culture sensitivity report is available, or if the patient is hemodynamically unstable on broad spectrum antibiotics, we go for colistin or polymyxin B or ceftazidime avibactam, depending upon whether it is KPC producing strains or OXA 48 strains or NDM strains. Okay, now similarly for Pseudomonas, we go for piperacillin tazobactam or polymyxin. So for the resistant organisms, we prefer to use polymyxins or colistin. Okay, and of course, for enterococcus infections, we use linezolid. Daptomycin is very expensive. Okay, if a patient has renal failure, then this is a better choice, daptomycin. And for the central line-related associated infections, for CLABSI, we empirically start the patient on vancomycin. And for the gram-negative organisms, we prefer to use piperacillin tazobactam or meropenem. And once the culture sensitivity report is available for MRSA and coagulase negative staph, we continue with vancomycin or linezolid for MRSA infections. And daptomycin is used only if the patient has impaired renal function or if a vancomycin failure is suspected. Okay, and yeah, similarly for Pseudomonas or other multi-drug resistant organisms, we prefer to use meropenem, carbapenems or piperacillin tazobactam. And for CRE infections, we go for colistin or ceftazidime avibactam. For fungal infections, empirically we use fluconazole. So, but as per guidelines, IDSA guidelines, we are we are supposed to use echinocandins. And again, in resource limited settings, using echinocandins is a real challenge because of the affordability. Okay, and then de-escalate once the sensitivity report is available. Okay, so I still feel fluconazole works very well. But in neutropenic patients, you need to empirically start them on echinocandins. Okay, neutropenic patients, neutropenic sepsis, they have to be started on echinocandins. Fluconazole may not work in these patients. So these are some of the preventive strategies we need to follow. So whenever the patient gets admitted in ICU, so this VAP bundle has to be practiced. Raise the head of the bed to a 30 to 45 degree angle to reduce the risk of aspiration. Perform regular oral hygiene using antiseptic solutions. Interrupt daily sedation. Okay, this is very important to assess the patient's condition for extubation. And of course, avoid unnecessary catheterization. Okay, so remove the catheters as early as possible once the patient is stable, and ensure proper aseptic precautions during catheter insertion and maintenance, and remove the catheters when no longer it is needed. Okay, and for CLAPSy prevention, strict hand hygiene has to be practiced. Masks, wearing caps, gowns, gloves, and all these things needs to be practiced in ICU. Chlorhexidine, I'm sure majority of the ICUs practice this for skin antisepsis prior to catheter insertion. Now, this is a major, challenge, and most of the hospitals have implemented this antibiotic stewardship programs. So this is aimed at preventing antibiotic misuse, reducing the risk of developing multi-drug resistant organisms. So once you have the culture sensitivity report, you should, try to, go for a targeted therapy and limit its use for a longer duration of time. As per the guidelines, severe infections we prefer to use for about 14 days, 10 to 14 days, and in uncomplicated infections, we limit its use for about 7 days, 7 to 10 days, depending upon the patient's clinical condition. Okay, and regular cleaning of high-touch surfaces and equipments in the ICU is very important. And of course, training programs to ensure complex with the infection, with the infection prevention guidelines are very important. Now, this is just a few examples I just wanted to show you. A 65-year-old male with a chronic obstructive pulmonary disease gets admitted to ICU for respiratory failure and is put on mechanical ventilation. So after 10 days of intubation, patient develops fever, increased respiratory secretions and worsening oxygenation, and sputum culture grows Pseudomonas aeruginosa. So the key issues here is failure to implement VAP prevention bundles. So, the patient's head has to be elevated head of bed, oral hygiene, daily sedation interruption is very important. So what is the outcome? Prolonged ICU stay, antibiotic treatment with the piperacillin tazobactam. Patient eventually recovers, but he experiences delayed weaning from the ventilator. So these are the key points. So the other thing is regarding this catheter-associated urinary tract infection by E. coli, a 72-year-old female with a diabetes gets admitted for septic shock secondary to pyelonephritis, required for Foley's catheter for urinary tract monitoring. So after about 7 days of catheterization, patient develops fever and new onset confusion, and subsequently when the urine culture is sent, it shows it grows E. coli. So what is the key issue here? Is prolonged catheterization without daily checks. And the outcome is patient gets treated with antibiotics, carbapenem, due to ESBL producing, and the catheter is removed. Patient recovers, but the infection has prolonged our ICU stay. So the other thing is, a 45-year-old man gets admitted with pancreatitis, requires central line catheterization for the fluid management and parenteral nutrition. So on day 8, patient develops high-grade fever and hypotension. His blood cultures sent, it grows methicillin-resistant Staphylococcus aureus. Okay, so the key issue here is inconsistent hand hygiene and lack of sterile barrier precautions during central line insertion. So what is the outcome in these patients? So the central line was removed, patient was started on vancomycin. There is a gradual recovery, but however, bacteremia has caused additional complications, including acute kidney injury. So that prolongs hospitalization. So these are some of the examples. So anyway, I want to skip this. Again, Clostridium difficile infection following broad spectrum antibiotic use. A 60-year-old male gets admitted to ICU for sepsis. Gets initially treated with broad spectrum antibiotics. After 14 days of treatment, patient develops diarrhea and abdominal pain. Test confirms Clostridium difficile toxin. So the key issue here is unmonitored use of antibiotics. Antibiotics are used for a long duration of time. So that caused gut flora disruption. So what was the outcome? Patient got treated with oral vancomycin, and there was unnecessary antibiotics. Okay, so that was discontinued. developed significant dehydration, electrolyte imbalance, prolonged ICU stay. So these are some of the things, which we need to keep in mind whenever we're treating the patients in ICU. So in conclusion, I just want to, tell you that it's nosocomial infections, especially VAP infections and CLAPS infections, are a major threat to the patient outcomes worldwide, globally. So it's a major burden in the resource limited settings where infection control is challenging. So multi-drug resistant organisms are, they are coming up more and more in ICUs, especially in the resource limited settings. So I want to reiterate that environmental contamination is very important. Environmental contamination is a major risk factor, which makes the treatment very difficult. So, practice hand hygiene, bundle care approaches, antibiotic stewardship, maintain a clean environment. So all these things are very crucial for reducing the, ICU related infections. So preventing nosocomial infections through rigorous infection control measures is more effective than treating them. So train the healthcare workers.
So our third speaker this morning is Professor Hamisi Malebo. He is a chief research scientist at the National Institute for Medical Research, NIMRI, in Tanzania. Currently, he serves as the executive secretary of the UNESCO National Commission of Tanzania, as the chairperson of the International Traditional and Alternative Health Practice Council. He specializes in drug discovery, infectious diseases, and environmental health. So his topic for discussion today is understanding mpox, which is comprehensive safety measures, detailed symptom identification, and current treatment protocols. Welcome, Prof.
Then I will go directly to the topic, which is understanding mpox, and we'll talk on safety measures, symptoms, and also partly on current treatment protocols. When we talk of mpox, actually mpox is a viral zoonotic disease. It is rare, and it is caused by a group of virus called orthopox virus, formerly monkeypox virus, because this name has been changed. The name monkeypox was created before WHO published a new system for best practices in naming diseases in 2015. Now, scientists have pushed on the change of the name because monkey seems to be coupled on a disease which are not supposed to be associated, because it is caused by another group of organisms. Monkey itself is just a victim. Infected persons with the monkeypox often get a rash along with other symptoms. And the rash will go through several stages, including scabs before healing. I've tried to show the relationship here that monkeypox is a rare zoonotic viral disease belonging to the orthopox virus in the genus Poxviridae, Orthopox virus is a genus and Poxviridae is the family. When we talk of infection with the mpox, it started in 1958, whereby a group of captive monkeys were being used for research in Denmark. Then some monkeys developed symptoms of these diseases, and in that colony, scientists were able to identify the disease, and they called it monkeypox in 1958, and it was just in monkeys. In humans, the first case was observed in 1970 in Democratic Republic of Congo in a 9-year boy. And I have talked about monkeys. They are not the exactly culprits to be blamed for the disease, because the reservoirs have been found. Quite a number of other wild animals, including rodents, are the reservoirs of monkeypox disease. So small wild animals in West and Central Africa, they have been shown to be the reservoirs of the virus. So the monkey is also just a victim of the infection. Direct and close contact with infected animals, fluids or waste, or getting bitten or scratched by these wild animals, that is where the disease is initially transmitted from animals to human beings. And during activities like hunting, trapping, or processing infected wild animals in areas where mpox is endemic, that is where also there is a contact between human being and the infection. Thank you very much. When it comes to signs and symptoms and the mode of transmission, I've tried to compare monkeypox, chickenpox, and smallpox. All of them, they are caused by different types of viruses. They are caused by different types of viruses, but symptoms are very close and sometimes they are confusing. With the mpox, fever is one of the symptoms, and fever is not specific. Even with the chickenpox and smallpox, fever is among of the symptoms. Past-filled boils, first appearing on face on mpox, but with the chickenpox, there is itchy rash, first appearing on the chest, back, and face. Still confusing because also it overlaps with what happens with the mpox. Also with the smallpox, red spots on tongue, past-filled boils on face, arms, and legs. So you could see here symptoms are overlapping. Appearance of the disease, the incubation period also overlaps. With mpox, 5 to 21 days, chickenpox, 10 to 21 days, and smallpox is 7 to 19 days. The length of the illness with mpox is 2 to 4 weeks, but chickenpox is 4 to 7 days, and also with the smallpox is up to 5 weeks. Fatality, chickenpox is rare. Smallpox was extremely dangerous. Up to 30% of the cases died. But with mpox, 1 to 10% fatality of this infection. Vaccines available for chickenpox, smallpox have been also suggested to work. But smallpox vaccine have been suggested to work well for mpox. I've tried to show that the reservoirs and the route of transmission is from animals. And once a human being has been infected, then direct contact whereby a human being with rashes, with the filled with the fluids, the lesions, once they have ruptured, they release large number of infectious viruses. Then direct contact can transmit the infection. Prolonged contact, also sexual contact, is part of the transmission route. So when we look at the risk factors and the vulnerable population, direct contact with mpox rash, scabs, body fluids from a person with mpox, that is among of the risk factors. But touching objects, touch surfaces, like we are touching this table. My colleague who presented the first, in the first part, if he has monkeypox and he has touched this table, and I'm also touching this table, it means if he has left some infections on this table, I will pick the infection. And that happens with the door handles, water taps, with all touch surfaces in the community. But also it can happen with the fabrics, clothing, bedding, towels, and surfaces that have been used by someone with the mpox. Another risk factor is the contact with the respiratory secretions or sexual contact with an infected person. Traveling or traveled to a country with confirmed cases of mpox where mpox activity has been ongoing, because you have higher chances to come into contact with the infected surfaces. So that becomes a risk factor. Had a contact with a dead or live animal or exotic pet that exists in Africa, or used a product derived from such animal, example, meat, creams, lotion, powders, etc. When we talk of Africa, whereby infection is prevalent. Now, looking at the vulnerable population, young children are vulnerable to this infection due to immature immunity. Malnourished children or affected by other illnesses are the most vulnerable to catching and dying from mpox. Immunocompromised people and those with chronic illnesses, elderly persons aged above 50 years might experience more severe mpox disease because of a higher prevalence of comorbidities in this age group. At the risk population, home pet raisers and healthcare workers. I think we know why healthcare workers are at higher risk of all these infections, because everybody feeling unwell will visit a healthcare facility. So the first contact is a healthcare worker than another member of the community. Looking at the distribution of mpox. Mpox is a localized disease, and it seems to be endemic in Central Africa and West Africa. The current epidemic is sweeping in the Democratic Republic of Congo, and that has been the epicenter of mpox. And that is where large number of cases have been reported. But we are also seeing genetic there is a genetic picture that the strain, which is in Central Africa and Democratic Republic of Congo, Gabon, Republic of Congo, and Central African Republic, is a bit different. The clades are not the same as what is happening in West Africa. So there is a locality for clade 1 and clade 2. And you could see clade 1 is endemic in Central Africa. And clade 2 is endemic in West Africa. I think some genetic studies need to be done. What happened? Was it a mutation? Or maybe clade 2 is natural to West Africa and not as a result of mutation from clade 1. When we consider the East African situation at the moment, some cases are happening in Eastern Africa. Some cases have been reported in Burundi. That is where a large number of cases have already been reported. In South Africa, in Uganda, Rwanda, and Kenya. When it comes to vaccines, we have talked about the protection with the smallpox vaccine is possible. Though monkeypox typically resolves on its own within 2 to 4 weeks without any treatment in majority of the cases. For severe cases, there is no established cure or treatment regimen known at the moment for severe cases. Several new therapies are being developed or are undergoing clinical trials. Treatment options, just to manage symptoms and prevent future outbreaks. This includes the use of antivirals and vaccinia immunoglobulin. Smallpox vaccine has been approved by the European Union, United States, Canada, and others. And also Japan and Russia also have approved some vaccines for use against for prevention against the mpox. How can we avoid mpox? If we can avoid the contact with objects and the materials that a person with mpox has used or touched, that is where we are coming to the water, sanitation, and hygiene strategy. These, at the moment, are the only strategies which can keep the community safe from mpox. So do not share eating utensils or cups with a person with mpox. Do not handle or touch the bedding, towels, or clothing of a person with mpox with bare hands. If you or someone live with a person having mpox, follow steps for cleaning and disinfecting the home. I also, apart from mpox, I tried to put some slides on Marburg. Marburg is a viral disease which produces severe and often fatal illness with fever, rash, diarrhea, vomiting, and gastrointestinal bleeding. Marburg virus is a hemorrhagic fever virus of the Filoviridae family of viruses. And Marburg virus causes Marburg virus disease in primates. And this, in primates also, it is a form of viral hemorrhagic fever. Marburg is transmitted to humans through contact with infected green monkeys. That is where is the initial contact. Humans get the infection from monkeys, and also the World Health Organization rates it as a risk group 4. It means it is a high risk. Historically, Marburg virus was first detected in 1967 in a laboratory in Germany, whereby 2 large outbreaks in Marburg. In the town of Marburg, hence the name was given Marburg. Initially, Marburg hemorrhagic fever and Marburg viral disease. So 32 cases. 1 case was diagnosed retrospectively, where infected Marburg virus by laboratory workers, followed by other medical personnel, then their family members, and 7 of whom died. The outbreak was linked to exposure of the first infected case to African green monkey, Celopithecus ethiopis, or their tissues which were imported from Uganda during that research, because they were doing poliomyelitis vaccine research. Again, we are seeing contact with wild animals, transmission initially to a human being, then transmission by contact from one human being to the other. I've tried to use this map to show the distribution of Marburg virus. This has gone viral across the globe. Almost all continents have been touched with the infection and the different levels of outbreak. Again, improving water sanitation and hygiene strategies can keep the world population safe from Marburg viral disease. The last part is on Ebola. Ebola is also caused by a group of viruses, and these are the ortho Ebola viruses. Formerly, they were called the Ebola virus. These viruses, they are also known to cause serious illness, and without treatment, Ebola is fatal. Far different from Mpox, whereby people can survive without a treatment, but with Ebola, no, it is almost 100% fatal. Also, Ebola viruses were discovered in 1976 in the Democratic Republic of Congo, and they are found primarily in sub-Saharan Africa. There are 4 types of these viruses. There is the Ebola virus, the original species, the ortho Ebola virus is Irensi, which was discovered in Democratic Republic of Congo, which causes the Ebola virus disease. There is the Sudan virus, species ortho Ebola virus is Sudanese. There is the Thai virus, ortho Ebola virus Thaiense, and the Bundibugyo virus, which is ortho Ebola virus Bundibugyo. Signs and symptoms of the disease we found that people with Ebola disease may experience dry symptoms. In dry symptoms, which they occur early in the course of illness, this include fever, aches, pains, and fatigue. But also, the patient can experience the so-called wet symptoms, which include the diarrhea, vomiting, and unexplained bleeding, the hemorrhage part. Transmission and control of viral infections. The Marburg virus is transmitted to people from fruit bats and spread among humans through human-to-human transmission. Contact with wild animals, especially populations living closer to forests. They are in close contact with birds, with monkeys. That is where initial transmission to humans can take place. And then from the infected human, transmission into the community from human to human can occur. Ebola virus also starts with a close contact with infected animals, including chimpanzees, fruit bats, and forest antelope. From there, then direct transmission through infected blood, body fluids, skin of patients, or those who have died with Ebola. Then transmission can be maintained in the community. So transmission of Marburg and Ebola virus between people, after the initial spillover event, the virus can be transmitted now from person to person. The infection can result from contact with blood or other body fluids, feces, vomitus, urine, saliva, respiratory secretions with high virus concentration. How can the community be prevented from catching this kind of infections? Community engagement is key to successfully controlling any outbreaks. Outbreak control derives using a range of interventions such as case management, surveillance and contact tracing, good laboratory services, infection prevention and control in healthcare facilities, safe and dignified burials, and social mobilization. I have just outlined some control measures for risk reduction in bullet form. The first one is reducing the risk of bird to human transmission. Because birds have been associated with the transmission of viral infections, so reducing human-bird contact. And not only human-bird contact, human-wildlife, wild animals contact can also reduce risk for transmission of viral infections. The second part is on reducing the risk of human-to-human transmission in the community. Just in the community, we need to use water sanitation and hygiene strategies, which can create a barrier of transmission from one person to the other. And where communities are affected, efforts should be ensured that the population is well informed. Everybody in the community should be informed and then encouraged to practice control measures. And the last is on the outbreak containment measures, which include safe and dignified burial of the deceased. Thank you for listening.
So our fourth speaker this morning is Dr. Steve Biko. He's the head of internal medicine at Kakamega County Hospital, and he's a proud Merck Foundation alumnus, having earned an online MSc in respiratory medicine from the University of South Wales, UK. He has a strong belief in knowledge, dissemination, and continuous improvement, and he has successfully supervised numerous medical doctors over the past decade. His mission is to enhance access to lung health for underdeserved populations in Western Kenya. His topic for discussion today is role of bronchoscopy in the management of obstructive versus restrictive lung disease in Africa. Welcome, Doctor.
So thank you very much for this opportunity to present on this particular topic. It's a fairly broad topic, but nonetheless, I'll try to dissect it. And at the end of the presentation, it is my hope that we will be able to at least appreciate that we need to introduce bronchoscopy as a service point in the care of our respiratory patients in Africa. So I'll begin with a simple introduction. So basically, bronchoscopy is just a procedure that directly visualizes the lumen and the mucosa of the trachea. So the whole respiratory tree up to around level 4. I'll give some briefing on the anatomy. But you introduce a tube with a camera and you visualize the whole pathway from up to down. Yeah, so I'll also just briefly highlight something on the history of bronchoscopy. Among the pioneer people who have been recognized in this field are Horace Green, who between 1802 and 1866 used a sponge, and he introduced this medicated sponge into the larynx and trachea of patients who had diphtheria at that particular point. So that's the diagram in the middle there. Then Joseph Odwyer in 1882 again introduced a tube to release lower airway adhesions due to diphtheria, and also to try and use the same to remove foreign bodies. Diagram on the upper part. Then Gustav Killmann from Germany actually developed an illuminated scope and used it again to assess the upper airways. Chevalier Jackson in the US used modifications of the Killmann devices to actually survey and remove foreign bodies from the airways. And more phenomenally, and what brings us to the current field now is this scientist, doctor from Japan, Shigedo Ikeda, who in 1966 actually, working together with Olympus, designed or helped with the design and manufacture of that scope, what we call now the flexible bronchoscope. So I'll just mention this, but I'll revisit it later. So, when I was looking at this topic, I was trying to bring it into the context of Africa. So we don't have a lot of publications arising from this particular topic in Africa. So I did a PubMed search, just as outlined. And when you put the word flexible bronchoscopy, you get 3,562 results. But when you add the word Africa, it comes to 43. Then when you add the word restrictive, it comes down. Obstructive, again, globally, it comes to that. But when you permutate it that way and add Africa, it comes to 12. So we don't have so much published information. Although we know that it's a practice that is going on. It's being done at certain public facilities, and is also being done in private facilities. Though we have not actually published much on the same. So there are no policy guidelines on this particular subject matter. And we don't have any meta-analysis or systemic reviews on the African position. Even in India, it's just recently, I think 2021, when they came up with their guidelines on flexible bronchoscopy. And this one's cut across. You look at even the European and American guidelines, they're close to the same. So most likely we will adopt the same as we move on. So this is just the anatomy of the whole respiratory tree. And what we are interested in are actually the bronchopulmonary segments, which are these areas here. So there are autonomous regions, both anatomical and functional, that support breathing. And the autonomy actually enables them to localize even disease at a particular point. So they are labeled as follows. So we have 10 bronchopulmonary segments on the right, but the numbers vary because there are anatomical variations, and then 8 to 9 on the left. I don't want to go through just the naming. That one can be found in other sources. Now, the other important thing that we need to note is that there are changes in the tracheal length according to gender and age. Now, as one grows, the trachea lengthens, and then when you reach around 14 to 20 years, it starts lengthening at a slower rate. And in women, by around 20, it's around 11.8 centimeters. And in men, it comes to around 13. So on average, the tracheal length of an adult is around between 11 to 13 centimeters. And then the diameter is also important. By the time you reach around 18 to 20 years, in men, it is between 1.3 to 2.5 millimeters, depending. And in women, between 1 to 21, again, depending on several factors. And then the right bronchus and the left bronchus is longer than the right, but the diameter of the right is much bigger, or slightly bigger than the left. Now, these dimensions are actually important because when you do certain modalities for bronchoscopy, then you need to have them in mind. For example, if you're scoping someone who is in an ICU, who is intubated, you are scoping inside an endotracheal tube. Yeah. So you need to know, how you'll fit here. Because remember, someone who's being mechanically ventilated, you want to introduce something else that will reduce the caliber of that vessel. And this particular thing will again interfere with the mechanics of breathing per se. So just highlighting the same thing, the trachea basically has got rings. The posterior aspect of it has got a fibromuscular wall. And then it branches into the right and left bronchus, and we have the carina there. So the carinal angle actually is important. The carina has got several associations. It has many things, the outer and other things, nodes, mediastinal structures passing behind. And these are important later on as you start looking at specific disease entities. So this is just a highlight of how a bronchoscope looks like. And it basically has got 3 parts. So we have the insertion tube at the end, the one with the working tip. And the working tip has got a working channel, and then it has got a camera and a light source, 1 or 2 light sources. Then it has got a control unit, that's in the middle, where you have the up-down controls, and then you have a suction channel. And then it has got an umbilicus, just like any endoscope, that now has the cables for the light source and image processing, and then the connectors to the image processor. Then on the left, we have some of the forceps that we use, alligator and cup forceps, and then the various sizes of the scopes. So conventional scopes in terms of size usually range from between 7 to 9 millimeters. The bigger ones are usually used for interventional procedures because the working channel is a bit bigger. And then the smaller ones are used largely for diagnostics. Then we have ultra-thin scopes nowadays. that enable you to go even up to around level 5 bronchi. You know, there's much smaller airways. So the bronchoscopic modalities, other than flexible bronchoscopy, we have endobronchial ultrasound, whereby you have an ultrasound module, either linear or radial, that is attached to the end of the scope. Some of them are passed through the working channel, and insert them with a balloon, and you're able to actually do an ultrasound, of the whole bronchial tree as you move down. The essence of that largely is to try and look at extraluminal anatomies and try to use the same to biopsy over the same. Then we have a navigational bronchoscopy, whereby an individual is placed on an electromagnetic board on the background of a previously mapped chest or lung anatomy. And then it uses AI to try and show you how to move on. Ultra thin, that is just the size. Then confocal bronchoscopy, this one use lenses that actually are more like magnifying glasses. So you do like what we'd call like microscopy in real time. Then fluorescence bronchoscopy, whereby you introduce dyes, and this one's, light up to do the scoping. Then rigid bronchoscopy, which has been there for a long time, is actually still used even right now, especially when you want to intervene. It's used to introduce instruments largely, and even to remove foreign bodies. Then virtual bronchoscopy is more of a CT scan based procedure, whereby CT scan takes images of the whole chest, and then you sit down on a computer console and just navigate through. Very useful, especially for planning purposes, and even in terms of telemedicine. These are things that I think will come in. Then robotics have also come in, whereby what the human does can actually be done by robots. And I think there are 2 published AI models of robots that can do this. So the indications of bronchoscopy. So I've gone back to a paper of 1978 by Landa, whereby he classified the indications into 2. That was the diagnostic indications and the therapeutic indications. So for diagnostics, there are many. So cough, hemoptysis, wheeze, atelectasis, and the list goes on. And then therapeutic, the commonest, of course, is removal of foreign bodies, accumulated secretions, atelectasis, lung abscesses, tumor biopsies. So that was in 1978. Then 2023, again, in this book by Diaz and Rodriguez, it's almost the same thing, similar classifications. They add more things to the same. So things like, basically it's the same thing. And even when it comes to the therapeutic indications, almost the same indications. Only that now we do them better because of the introduced modalities like EBAS. So this is, again, just a similar thing, just highlighting some of the therapeutic indications. And some of the practical ones are things like difficult airway intubations, which have actually been done, lung lavages, both therapeutic and diagnostic, looking at things like handling hemoptysis when you want to achieve tamponade, foreign body removal, laser and electrocoagulation, cryotherapies. Now, much of this actually is being done. Like in Kenya, we do quite a number of this, but at the main referral hospital. Where I am, we are more still on the diagnostics, not on the therapeutics. Yeah, but the capacity is there. In India, I think they do all of them, maybe even robotics. But it's an evolving field. So this just the same thing that I'm talking about. So I'll just outline the procedure in a nutshell. Will not go into too much of what we do, but basically, like any interventional procedure, you must prepare, you must ensure patient comfort using anesthesia, then of course the technique itself, and then there's the post-procedure considerations. So when you're doing your preparation, the thing is, first of all, to look at the indication. Is there an indication for the procedure? Are there procedure contraindications? So the patient goes through some kind of preparation. Then the airway, of course, is assessed, just globally. And the easiest assessment, of course, just a visual assessment, and then you score using the Malampati score. Then you obtain consent from the individual. Actually, consent is the most important step. Then in terms of anesthesia, we use topical agents, lidocaine, of varying percentages, but of course, getting the percentages is difficult. So, for example, if you want to do local anesthesia in the nose, because the entry point is usually through either the nose or the mouth. So what you can do is to start with 2% lidocaine for the nose, or you can even just go to 1% lidocaine solution, and you use it to anesthetize the nasal passage plus the cricothyroid areas, the larynx and its associated structures. Then for patient comfort, we actually introduce just moderate sedation. So there are several ways of looking at it. You can work with an anesthetist, or you can work, with a nurse, you and a nurse and maybe another doctor. So when you're not working with an anesthetist, then you try to avoid propofol. I think a professor had also said the same, because one, it has got a very narrow therapeutic window. Then number two, it has got significant cardiorespiratory compromise. So if you're not an expert, you avoid that. But that for non-experts or proceduralists like us, midazolam 1 milligram per kilogram body weight is good enough as a single agent, but better if added with fentanyl, because fentanyl as an opioid also reduces the tendency to cough. Then the other thing that you must look at is how much lidocaine you're using. You want to limit it to 8.2 milligrams per kilogram body weight. That is for lower airway, administration. Or you limit yourself to 20 mils of the same, because it also has its own side effects. Yeah, the earliest will be tinnitus, and then you can have neurological sequelae from the same also, and also cardiovascular sequelae from the same. So just as I said, the technique, you enter through the nose or the mouth, and when the trachea is well prepared, you go in, introducing, what we call on-the-go sedation. So you just administer your lidocaine up to the carina, where you are gonna give your lidocaine, give it a minute or two, then choose the direction that you want to go to. So most of the time we start with the normal side, finish with the abnormal side. So as you move, of course, you examine the mucosa, airway patency, anatomical variations, and bronchial lesions, foreign bodies, and bleeding. Then post-procedure, you monitor the patient for at least 1 hour until they get a full cardiorespiratory, resolution. So the cons for bronchoscopy are as follows. One, and the most important, is lack of informed consent. If you don't have consent, don't proceed with the procedure. Others, especially the almost absolute ones, include severe refractory hypoxemia, equipment malfunction, poor patient preparation, malignant cardiac arrhythmias, severe bleeding and diastasis, and that is uncorrectable before the procedure. Then relative ones, so things like superior vena cava syndrome, renal insufficiency, high risk of bleeding, especially if you want to do an intervention and your platelets are less than 50. But if it's just diagnostic or you do things like lavages, even platelets of less than 20,000 are allowable. But of course, depending on the expertise of the team at hand. Then unstable or severe obstructive airway diseases, severe pulmonary hypertension, pregnancy, large anterior mediastinal masses, raised ICP, among others. So the complications are not many, and actually the complication rates in most centers tend to be less than 1% across board. What is documented in more established centers are values of less than 0.1%. So some of the complications include things like mild transient hypotension and hypoxemia related to the sedation, mild bleeding and hemoptysis, especially when you take like a biopsy. You can actually introduce a pneumothorax as a complication of the same. Things like nasal discomfort and sore throats. Less common are bronchospasms. Those are mitigated actually through good patient preparation, epistaxis, methemoglobinemia due to overdosing the lignocaine, tinnitus, laryngeal edema, cardiac arrhythmias, infections, and vasovagal syncope. So now, this is just a chart that it's from the chronic respiratory disease collaborators, and it just shows us the burden of chronic respiratory disease over a period of between 1990 to 2017. So it was largely divided into these 5 super regions. So Central Europe, Latin America, North Africa, Middle East, South Asia, Southeast Asia, and Sub-Saharan Africa. So the reason why I put it up was actually just to try and highlight the burden of chronic lung disease, and then try to tease this into both obstructive and restrictive pathologies. Then we see how or where bronchoscopy can fit in. So this is a magnification of the last part on Sub-Saharan Africa. And actually, if you do a comparison, you note that the percentages of even all chronic respiratory diseases, COPD, asthma, interstitial lung disease, pneumoconiosis, is actually very low. But this is not actually a true representation of the facts on the ground. Because remember, for example, we look at disease entities like TB. 23% of the TB world burden actually is reported to be in Africa. And the population estimates as at 2023 indicated that about 15 to 18% of the world population was in Africa. So this is not very true. And the reason why it's not true is because of underreporting. Yeah. Many countries are not reporting. So it looks like there is no problem, but there is a problem. So this is just the same thing, highlighting the same kind of predicament. Again, you come to lung cancer and you come to Africa, you find that our incidences are actually very low. But it's not true, because when you are seeing the patients, there are many, but again, the kind of reporting structures are not very, very, very accurate. So you can actually underscore the value of some interventions like bronchoscopy to try and diagnose the same. Things like post-TB lung disease, which actually cuts across, it goes either way. It can give you a restrictive lung disease, it can give you an obstructive lung disease. Again, fairly underreported. And post-TB lung disease, just as I said, it will cut across, it will affect your airways, it will affect the parenchyma, it will affect your vasculature, pulmonary vasculature. And these are things that, bronchoscopy would actually assist, in terms of making relevant diagnosis. So I'll just briefly highlight what a restrictive and obstructive lung disease are. So obstructive basically is any disease process that limits the airway flow due to partial or complete obstruction of your airways. While a restrictive pathology basically reduces expansion of the lung parenchyma and is accompanied by a decrease in the total lung capacity. So they are defined as indicated. The FEV1 FVC ratio will be lower in an obstructive pathology and will be normal in a restrictive pathology. But when you look at the lung volumes, the FVC, it's going to be reduced in a restrictive picture and normal in an obstructive picture. Although sometimes both these entities can coexist. So restrictive pathologies actually are many. They are heterogeneous. They can be both inside the lung, they can be outside the lung. When they're intrinsic, they are due to a destruction of the lung parenchyma, and when they are outside, they may be due to neuromuscular function disorders, like paralysis of the respiratory system or things like that. Now, the intrinsic ones have actually a role for bronchoscopy, because that's an area that you can reach. And the examples that are common in Africa include the interstitial lung diseases, which are underreported, pulmonary fibrosis, sarcoidosis, hypersensitivity pneumonitis, the pneumoconiosis and occupational lung diseases, post-TB lung disease, and lung cancer. Then we come to the obstructive diseases that are common. Asthma, very common, across board, COPD, bronchiectasis, post-TB lung disease, foreign bodies and masses, and even lung cancer. Now, the good thing with all this is that they are all amenable to assessment and evaluation by bronchoscopy. And these are some of the things that we can do. You can inspect the airways, you can do a bronchoalveolar lavage, both diagnostic and therapeutic. You can do bronchial washes, bronchial brushings, transbronchial lung biopsies, and bronchial biopsies. There are places where they can do even bronchial thermoplasties for resistant asthma, like in South Africa, there are reported cases for the same. And then also things like guides to one lung ventilation can actually be done. And this is largely used by cardiothoracics when they want to focus on just one lung. So the access to bronchoscopy actually is varied across countries. But studies like this one by Ngaka in 2024 indicated that the services are concentrated more in urban areas and in tertiary institutions. There's limited access in rural areas, and then few pulmonologists and cardiothoracic surgeons across board. And then, of course, cost is another thing. Then late referrals and diagnostic delays are also there. So the other big challenge that we are seeing actually is to do with the training. Because, for example, myself, I did the respiratory medicine pathway through the Merck scholarship. And, these are things, they come as add-ons. They don't come in, directly through the training itself. So we were fortunate, that we have a vibrant respiratory society in Kenya. And through their collaborations, we have been undergoing trainings and workshops, largely with the American universities, to try and introduce the services into the country. But there are a lot of training gaps, and the limitations actually arise because lack of experienced operators and trainers, improper understanding of the dynamics, few training centers in Africa. I think the places where we have this South Africa and North Africa, in Egypt, and now we are trying to set up one in Kenya. Then, of course, high costs of training. And on the left is actually what you need to be, these are from the American Thoracic Society. For example, if you are to be declared as proficient in flexible bronchoscopy, you need to do 100. Getting that 100 is very difficult, even if you go just through the papers as they are. And then you need 25, to do 25 per annum to maintain yourself. So the way forward for us actually is one, in Africa, we still have a lot of uncharted waters on bronchoscopy and related fields. So we need to do more and start doing more real-time research, other than reporting on the work, we start reporting on procedures, difficulties and modifications that we can bring in. Then we have disposable bronchoscopes now. Still a little bit costly, but their aim is actually to bring down the costs. So that's one thing that we can think about. Then virtual bronchoscopy is also another thing that we can introduce. The CT scanners, like in Kenya, there are many. Almost everywhere you'll get a CT scanner through government initiatives and private initiatives. Then telemedicine and remote mentoring programs for the same would actually assist. Then increasing the availability of advanced techniques like EBAS to aid with complex cases. And then also slowly introducing minimally invasive biopsy procedures. For example, for lung cancer, instead of doing the percutaneous CT-guided procedures, bronchoscopies actually can give you a fairly comfortable way of getting samples and making the diagnostics. Then molecular and genomic diagnostic improvements. I think that new markers that are coming up that can actually help to give better results on bronchoalveolar lavage and biopsy specimens. Yeah. Then, of course, setting up local guidelines and standards on the same. So maybe just as a parting shot, it's just as I was mentioning, the uptake of bronchoscopy and publications in Africa is fairly on the low side. And, going through the papers that are there, I didn't want to discuss them because their designs were so varied that it was difficult to even tabulate them in a way that you can give a proper analysis. But like in 1989, there was a study in Nigeria where they looked at 6 years experience on bronchoscopy, and they had 83 patients, and the disease profile was across board. Now, there's a colleague of mine who were with in the Merck program, Adioti and Ekule, who actually in 2017 did a professionals assessment where he looked at 250 doctors and just tried to look at what they understood about bronchoscopy. Now, out of these 250, about 91% of them had an idea about what was required, but only 8% of them had actually ever been exposed to a bronchoscope. At that time, that was in 2017. Then another Nigerian study again, over a 5-year period, they had 163 patients in a particular institution. Again, it doesn't meet the threshold even for training. So, it cuts across, and there are many studies. Even in Kenyatta, in Kenya, we did about a 4-year cohort study, and what the number of bronchoscopies that were assessed were around 282. Still not enough. Yeah, and then of course in that paper they are talking about limitations in terms of documentation and other things. So we have a long way. This is just an icebreaker. There's a lot more. Myself, I have started doing them. Still diagnostic. Maybe when I come next time, I'll have done 1 or 2 interventions. Yeah, so this is our team, the training team. That's at the Nairobi Surgical Skill Center. I think Dr. Wanini was there. You were there? Yeah, we have been walking this journey with her. Yeah, she's there. Yeah, so that was the second workshop that we did. And it still continues. I hope that in future they'll open doors even, to invite more and more participants from even other countries. It's something that we can actually do. And special thanks to our Respiratory Society of Kenya, our county government of Kakamega for availing the scope. Is a difficult thing to get, and the government of Japan who actually gave us the scope. And then Merck Foundation for the training, and to all of you for listening. Thank you very much.
Our 5th speaker for today is Dr. Erasto Silvanus. He is an emergency medicine specialist and also the head of emergency medical services, the Ministry of Health in Tanzania. Additionally, he serves as the Regional Health Affairs Coordinator for the Southern African Development Community, which we call SADC, desk. Dr. Erasto has played a pivotal role in establishing emergency medicine departments across the nation and implementing critical capacity building programs in emergency and critical care. His topic of discussion today is advancing emergency medical services, bringing emergency care to the community.
All right. So, good afternoon again. 5 years ago, I was still working at the police department. And this time was around 9 p.m. It was around 9 p.m. Arrived a man holding a child about 3 years, I think, 3 or 4 years, coming in, sweating, and was without shoes. Asked, "Doctor, please help my daughter." And he was having the child in his arms. And I picked the baby to the bed, examination bed. And the baby was quiet, was not breathing. There was no pulse. There was no heartbeat. And there was no any sign that the baby was alive. And I looked in the pupils, they were fully dilated, unresponsive. And I looked at the father. The father was there, like he knew what was there, but he couldn't believe because his tears were already going down on the floor. And the message, or the only statement he gave, he said, they were happy playing. He said that. And I asked, what do you mean they were happy? He said, they are twins. And they were okay until 1 hour ago. Like a few weeks later, another incident happened when I was on call, as on shift. It was around 4, almost 5 a.m. in the morning. The night was very busy, but it was around getting better. Then here comes a couple, one in front and the other one behind. The one in front was the father holding a baby. So it would be less than a year, maybe 11 or 10 months. Running in again. It was, but the mother was a little bit distant, like maybe 10 meters away. She was not very close. She was very worried. So the father entered the emergency room, holding the baby himself, asked the same, please help my daughter. If you can do anything, please help us. I took the baby again to the examination bed. The baby was not breathing and was almost cold. And now the mother was coming close. After we had done what we always do, and we were sure there were no signs of life. And I asked, when did you notice that the baby was not moving? Since we woke up. And I told them, I'm so sorry that we can't do much. We are a little bit late. And the woman who was there, who was the mother now, jumped to his husband, grabbed him by his chest and beat him a lot, painfully. And she uttered these words that I still remember. I want my daughter back. I want my daughter back. I still remember her voice, and I still remember even the clothes that she was wearing. You see, these are two stories. That the first one were twins.
very healthy twins, were playing at home. It was around 7 when the father said, around 7 they were eating with their a maid. The mother was not home, only the father was, and it was in his bedroom. They were eating rice while playing. And then all of a sudden he says, this maid knocked on his door. Come out, come out, come. There's an emergency. He came out, found the one of the twins was struggling. No sound, but was struggling. Was not able to breathe, was not able to cry. He did not know what to do. He remembered that there was a nurse nearby, like in their neighbor. He just grabbed the baby, ran to the nurse that he knew as a neighbor. He started knocking on the door. Few minutes, no one is coming. He just almost broke the door because he thought maybe they were busy out inside, but they didn't. He noticed maybe they're not home. He had no phone because he left it in his bedroom. He went back to his house with the baby, remember? And he had no shoes. Went back to his home, took the phone, tried to call her. Where are you? But the lady was not picking up. We later learned she's a nurse that was also on the night shift that day. So maybe she was busy already. She couldn't pick up the phone. And then he had no car. Tried to call anybody. One of his friends picked and he said, I'm coming right over. So he came in 20 minutes. After that, he picked the baby. But then the child was almost, I don't know, but he started losing hope after that. But he said, we were still having some hope. Let's go to the hospital. So they drove to the hospital. They arrived around 9 p.m. So by then, we couldn't save the child. It was long gone. So this baby died of choking. The other one was about this one I told you about, the less than a year, maybe 11 months. This is a story of, it was a baby girl, was having fevers and cough for like 2 days. And then the mother, that day of incident, talked to the husband. I think we should go to the hospital. It was around 8 p.m. Let's go to the hospital. I think the baby's not doing well. They were giving cough syrups and other medications, I don't know, for fever, I think. So because they were living a little bit far from the hospital and they did not have a car, and they discussed, it was night, and he's already at least is using some medications, the cough syrup. Probably you can go tomorrow in the morning. Yeah, and if you go now, it is already night. Doctors won't be there, won't find pediatricians. Probably the lab won't be able to diagnose anything. Probably, and it's very hard to get a car now. So the husband suggested would go in the morning, only to be woken up by the wife at 3, that I don't think our baby is doing well. So he woke up, the baby was lethargic, was not moving. That's when they picked. They ran with the baby and they stopped any car that ran across there. And they got one. That's when they arrived in the emergency room. And this baby seems died of pneumonia. That was delayed to be treated. So these stories gave me an imagination when I was preparing this presentation, that what if this father, the first one, knew what to do when something like that happened? What if he knew there was some technique, simple technique, that he would have used, would have saved his twin? What if he knew that there was a quick way of calling and get help very fast and be carried to the hospital? Maybe would still have that twin today. I was thinking, this other kid, this less of the one baby, if their parents knew that some medical conditions are time sensitive, some medical conditions don't wait, that whenever you see an issue, find a solution. I wish she knew that, oh, I wish there was a quick way to transport kids like this one to the facility without fear of, will I find doctors? Without fear that, are they going to be able to take care of my kid at this time? Will the lab be open? Will the specialist be around? Without that fear that they would go immediately. I was imagining if right now for us, if we have ambulances everywhere, when we have issues, they will be there for us to transport us to the facility where we get a definitive care. I was thinking, if in congregations like this, in meetings like this, if you have a medical emergency, you are sure someone will pick you and take you to the facility fast enough to be saved. In motor traffic crashes, where limbs will be broken, people will be bleeding, some just need repositioning to breathe, you know? If someone will be there just to remove something out of your nose to breathe, somebody that would get there just to stop the bleeding and make you survive. If there was someone who would pick you and send you to the facility, I was thinking if we could have that. That's why I prepared this presentation, that we need to consider our pre-hospital medicine, the emergency medical services, because it is simple. It is just this one. Just delivering medical care beyond the hospital walls. Giving support before, just somewhere where it happens. Start something where an emergency happens. Not to wait until you are in the walls of the emergency hospital, emergency room, or in the theater, things like that. So for the next few minutes, we are going to see some of the public health issues that we are facing that can really be impacted hugely if we have good structures of pre-hospital medicine, good structures of emergency medical services. So I'm going to talk about the road traffic crashes that are rampant in our region. Talk about the maternal mortality. Talk about child mortality. And then other emergencies, the strokes, you know, the MIs, etc. And any other emergencies that will happen, there's asthmas, other respiratory infections, or allergies. Let's start with one, the road traffic crashes. You remember, or you might know, that road traffic accident is also one of the killers across the world. More than 1 million are dying every year, but more are injured. It's non-fatal, but they are severely injured, and they could be permanently disabled. You know how many they are? More than 50 million every year. And do you know how old they are? Less than 30 years. And where do you think majority are? Lower and middle income countries. That's a nice way of saying, that's a diplomatic way of saying Africa. Yeah? And some Asia, and in Asia. And this is the population that we are here. Okay? Now, it doesn't only make us suffer from losing our relatives and ourselves, but even we lose financially. More than 3% of GDPs are lost in the care, whether with worst outcome or best outcomes, but we lose that. And the Sustainable Development Goals, one of the agenda on health, agenda number 3, we have a few of our targets. Motor traffic crashes reduction is one of them. And the call is to reduce by 50% by 2030, right? And that was 1 million. We need at least to have less than 500,000 deaths. Now, if this is an old graph, but I checked it is almost the same until now. That regardless of reduction of the maternal or the mortalities, but Africa still has 4 times mortalities compared to Europe, but it has 10 times less vehicles, motors than Europe. Yeah. It means the fewer cars that we are having are giving us a lot of trouble. We should be walking. Right. So something has to be done. In Tanzania, for example, more than 60% is the over mortality that we are having from the motor crashes are from motorcycles. Either motorcycle to motorcycle, motorcycle with the pedestrian, or motorcycle. There must be a motorcycle somewhere there. Yeah. Yeah, this is an example. So in the recommended safety system, we need to focus on these 5 things: safer people, safer vehicles, safer speeds, safer roads. But if we fail in all of those, at least we should have post-crash care, which is very, very good. Yeah. Like, how can you fail in all those? If we can't have safer roads that allows for motorcycles to, to run, and the pedestrians to also walk, have their own lanes, their own pavements to walk, to do exercises. About cars, strict laws for speeds, etc. Safer vehicles that can really stop when you want them to stop, not only honking. Yeah. The cars that have seat belts, just in case you have an avoidable accident, you can save some people. Of course, safer people who can drive when they are capable of driving, not they are just moving car movers. Someone was saying there is a difference between car movers and drivers. And who are you? Are you a car driver? Are you a driver or a car? Right. So we need to strengthen in our part. We can advocate for all those, and we can really put our feet down to make sure we have a post-crash care, which is very good, right? That's one part. Another part is the maternal mortality. You understand, women are dying when they are blessing the world. Can you imagine that? You are bringing a baby and you die of it. A blessing turning into a curse, or like becoming a punishment. This is not acceptable, right? But we are losing 800 women every day, not per year, every day, from preventable, or let's say pregnancy-related and childbirth complications. We lose them. They are us, they are sisters and mothers, they are neighbors. And for the past 20 years, of course, from the advocacy that have been going on, we should reduce this maternal mortality. It's not acceptable. It's not acceptable. People have really done their part. For 20 years, we have reduced the global maternal mortality by 34% average globally. And some countries have done better. And in this example, Tanzania has also done a great job. For the past 20 years, actually for the past 10 years, we have reduced by 84%. Tupige makofi. Can we clap for Tanzania? Tanzanians have really tried. Now they are at 104 per 100,000 live births. But we need to get to, by 2030, to below 70, right? And someone was saying was challenging. And what do you mean by like at least 70 by 100,000? And who are those 70? Who are you choosing to be on that side to continue dying? Yeah. Why don't you say 0? Why are you even choosing 2? Are you choosing your family to remain in that 2 so that they can continue dying while we continue preparing ourselves? That is a challenge that actually we shouldn't. These are the practical terms, but they are not politically correct. They are not socially correct, right? We shouldn't have any number left for allowable deaths because they are giving birth in God's sake, right? So we need to get to 70 by 2030. That's the agreement, the United Nations agreement. And at least every country to make sure we don't have more than 140 maternal mortality, 140 deaths per 100,000 live births. And it is possible, you know? So if you ask why is this number still lingering, everything goes down to barriers limiting to access to quality health services. Barriers to access to quality health services. And in the model of the delays, they say main are the delays. Delays are the main culprits. The delay of seeking care, delay of reaching the facility, and delay of providing care when they are in the hospital. So like you are beaten in all threes. If your husband delays, says, I will go in the morning. If you survive that, there won't be a car to take you. And if you survive, you have a car, you arrive to the facility, the doctor is at home. He's on call, but he's at home. A car has to be sent to him to come. Or you get to the facility, they didn't test their oxygen if it is still in. It is still in the cylinder or it is in the system. Oxygen is not there. But you are in the facility. Like they don't have a glucometer. They can't test whether you are hypoglycemic or not. And when they say, okay, let's just do empirically. Can we try 50% or 10%? There's no drip. Or they say, but we had it. Let's check in the store. The storekeeper has gone with the key at home. So we are confronted at all angles. But this is possible to change this. But I will tell you where we want to anchor our efforts. Okay? So we can delete all this, or we can change the delays in all three if we follow me to the end of the presentation. You remember 104? This was what? Where? Yes. So this 104 is a magical number that it tells you the efforts that have been done by the teams in Tanzania. 84% reduction in 5 years. It means they've worked so much. Okay? It is a multi-sectoral issue. It means the women themselves have said, enough is enough. What can we do? Let's do our part. They tried to do their part. And the transportation system tried to do their part. The doctors and nurses, they tried to do their part. We have done this, but we can do more. If we can do this in 5 years, it means we can do more in the coming ones, right? Now that we know it works, we can do more. Now, the part of the child mortality. The world is still having this burden. More than 10 million children die. That, of course, that was let's say 20 years ago. 20 years ago, 10 million were dying, the under 5s. And then from this pressure and from this advocacy, now we are around almost 5 million are still dying. Children under 5 with different diseases. Most of them are very preventable. In Tanzania, in this attempt, we tried, the under 5 mortality went back to 43 from 147. And the neonatal one from 40 to 24. If you look at this graph, it's not very convincing, is it? This one. It's like we haven't done a lot. It's not statistically significant. But it's something that can be done there to take us to, the neonatal mortality has to go down by 2030 to 12, right? We can do that. And under 5 to 20, 22 or something, we can do that. Right now, the global average is 37, but we can get down to 20s. And that the question still comes, who are those 20? Which family are you considering to continue dying before you say nobody should die? Okay, that should be a question for all of you. Every time you put a number, this is allowable statistics, fine, but ask who are remaining in this number. Shouldn't be you, certainly shouldn't be anybody, right? Yeah, so that's our target. Our internal target should be that, but our realistic target can be this one. Now, I'm not sure how to remove that because there were some things that were those things up there, but let's go. In the overall common causes of mortality in Tanzania, this one was on Tanzania, on the right side, the global, the everything put together. In Tanzania, you see in top 10, strokes, ischemic heart diseases, road injuries are within. They are having that mortality in 100,000 population. 18.7 in 100 population die of road injuries. Ischemic heart disease, 26.8. Strokes, 29. But if you take, it is a similar picture if you take a global mortality causes. The global mortality causes are these ones. Look here. The road, 5 to 14 years, and 15, 25, 9 years. These are the top 2 causes of deaths. And if you're a little bit older, you can jump out of the car. Somehow, you become number 3 when you are 30 to 44. But still, this number for the 30 to 44, you a little bit escape trauma, but ischemic heart diseases, violence, give us these high numbers. They are top 5 to top 7. This means these are the things that happen without planning, right? And we need to transport them quickly to the facility for care. What about the age of 49 to 60 or other ages? There is more than 17.7 people die of cardiovascular disease globally. Almost 18 million, they die. And 45 up to beyond 45 are ischemic heart disease and cerebrovascular disease. It means in short terms, strokes, heart attacks. Yeah? Very few of other diseases. The non-communicable diseases can. So let's go to one study, the systemic review that was done in 2023, last year. Reviewed a lot of studies, more than 4,000, checked that would show pre-hospital emergency care in the low and the middle income countries, just to see how is the pre-hospital system in lower and the middle income country. Because they found fewer papers that met their inclusion criteria, that those papers showed that the pre-hospital system in the lower and middle income countries is still fragmented, uncoordinated, lacking trained medical personnel and first responders, inadequate basic materials for care, and substandard infrastructure. And we know that structured pre-hospital care improves outcomes for trauma and injuries. Many studies have been done in different places have shown this. You know how much percent? It's more than 40% can be of preventable deaths can be reduced by having proper emergency care, pre-hospital care. And we did a study ourselves here in Tanzania, just 2 years after introduction of a fully functional emergency department at the National Hospital, Muhimbili. The overall mortality, remember, overall mortality of the hospital went down by 40%. Yeah, it means many of the diseases could be taken care of if we had very pre-care, like early interventions, stabilization, resuscitation, before you take them for surgery, before you take them for other definitive care. What about if we can take this understanding to the numbers I showed, these numbers? See how many deaths are going to be reduced globally. That is my call. That's what I want us to go out thinking. If we can strengthen this part, we can save not less than 40% of the deaths that we are seeing. And mostly the cerebrovascular of all kinds. Yeah. All the respiratories, all the injuries, the self-in of response time. It's already 30 minutes past. Okay. Response time. The English Medicine Journal of Medicine summarized that response time is very important. And they said 92% of the people could be found alive if you can reach them within 1 hour. And if you delay between 1 hour and 3 hours, it will drop by half. You will only find them 47 alive. And if you delay from 3 hours to 6 hours, only a quarter of them will be alive. This means the response time has to be within an hour, right? Every time you are told about an emergency, make sure, don't tell them, I'm coming. Don't tell them, I'll be right back. Okay? So that's my call to all of us. So if we can have a system where someone would call an ambulance, there is an emergency, someone calls. In Tanzania, we have 115. An ambulance is dispatched. It gets to the scene. They assess. They do some of the doables. They stabilize patients. They transfer while stabilizing, while troubleshooting, and they prepare the receiving facility. Like we are coming with a woman who has this and this age, and we think the main complication is this one. We think will benefit if the hospital prepares for this and this and this. So the hospital will prepare. We have a doctor there. If they see this needs blood, they will have a blood waiting, not right there. And then you say, oh, we don't have a B positive. We don't have whatever. It takes time. So this system will help us a lot to prepare the facility, but we do justice to the patient or the victim who is already in the transportation. They will start doing the things that can be done. So golden hour is what traumatologists call this golden hour. The emergency physician call this golden hour. But what do cardiologists say? They say heart, the time is the muscle. And the neurologists say time is brain. Whatever slogan you use, time is of essence. Now, to establish emergency medical services, you need a few of these things I'm going to mention. I'm not going to dwell here, but all these are things that can be done if we have emergency governance, very good system of financing, public access, that they can access the care. They know the number to call. Pre-hospital providers are ready, they are trained. And the operations, we have SOPs, we have everything that to guide them. And if we do quality assurance, we do research, sustainable resources, etc., we'll save more than 50% of the current people that we are saving or we are losing. So Tanzania started, but they focus on mama. You remember the story of a mama? Have you heard of the story of a mama, Prof? It's just a name. M is mama. So it is a mama program to save a woman in very limited resources with whatever you have. Mama is actually for mother. Sorry. I'm sorry. He didn't get it. He was just looking at me. I said, okay. But mom, okay, but mama, I think is cut across there. Thank you. I was very worried. Right. So we started this one, transporting mothers, using whatever transportation there is. We used the community drivers. That could not do anything during transportation in case something happens. We used some ambulances that were available. Some did not have equipments. Remember, the study showed those with the ambulances have no basic equipments. Like if you want to do anything, you can't, you know. But we could have, we saved some mothers. More than 100,000 women were saved. Yeah, like we are transported in different scenarios. And we saw those life-threatening conditions, more than 4,000. And we said, maybe, so these are the women we have saved. If we're just using this simple system, what if we have a very good system, a very coordinated system with proper ambulances, specialized ambulances, specialized teams that would do some of the basic things to stabilize patients, to prepare the facilities, the receiving facility, to prepare the theaters, to prepare the bronchoscopies. How about that? I think we can do better than this. So just to conclude my session, it is possible to reduce mortalities in those areas. Very possible to reduce significantly before 2030. And we understand that in Africa, we are still behind. Only a quarter, or I think a third of countries have emergency medical services of some sort. They are not proper, all of them, but so of some sort, you know? And, you know, it's 19% are government run. Most of them are, yeah, could be in Dar es Salaam alone, not in other cities, could be somewhere, but at least there. But we need to have good systems for emergency medical services. So we need to do some more initiatives involving public and private. We need to use data-driven innovations in the field to know where needs what service, to place ambulances strategically, to place these responders strategically. We should use those data to place our care. And we should collaborate in training and mentorships. Should have more of the ambulance providers, more of the traumatologists, more of other emergency physicians, etc., paramedics in general. And this one is more important, increasing political will. How many are in the policy level here? No? Yeah, somehow. Yeah, please, when you go back, and the rest of us who have somehow, you have ability to penetrate those who can make decisions. tell them to increase the political will to advance emergency care. The deliberate efforts to increase emergency departments, equip them to link with the pre-hospital care. In Tanzania, we are thankful for the current government. We have increased ambulances in 2 years. New ambulances, more than 603. New ones. In emergency departments, new ones, more than 123. New ones, only in public, let alone the private, are also doing their best. But this is a political will. If we do that, come again in 5 years, ask me this question. How much are you putting on the ones that should continue dying? I'm sure there will be a good number, a little bit better, not like this. So my call to all of us is that care should not start in the emergency room. Please, care should start where there is an emergency. Wherever it is, care should start there. So we need to collaborate, all of us. Make sure we train the community to support some basic things. If someone is in shock, someone is bleeding, they should be doing something as they call for proper teams to come. We should do something because otherwise we'll be too late. Thank you very much.
Good afternoon. Once again, I thanks Dr. Kingsley, Merck Foundation. Greetings from Manipal, India. With the permission from the moderators, I will start this session. Snapshot at pediatric emergency, interesting case presentation. So emergency means all of us know that there may be a variety of cases. I am going to discuss 6 cases in this scenario. The first one, 35-day-old female infant, firstborn to non-consanguineously married couple, presents to triage with vomiting, lethargy, poor feeding of 3 days duration. Vomiting is non-bilious immediately after the feed. There is no fever. Diagnosed at the local hospital as congenital hypertrophic pyloric stenosis, because this is one of the common conditions which presents with the vomiting in the early part of the life, newborn period or slightly later. So actually they considered that is the thing, and ultrasound was little in favor of this condition, and they referred to the pediatric surgery, and the child ends up in pediatric triage. So initially this was treated with the antiemetic, domperidone, antibiotics at the local hospital. This child was born normal by lower segment cesarean section with a good birth weight, and there is no history of asphyxia or other neonatal morbidity. So examination also, the weight was normal. Striking thing which is abnormal is the pulse, as you can see, or a heart rate, 170 per minute. Respiratory rate is also quite high. Cardiovascular system, there was a gallop rhythm. And per abdominal examination, there was liver 6 centimeter below the right costal margin, no splenomegaly, other systems are normal. So when we did, as the child was very sick, in the ICU, we did the blood gas, which shows the acidosis, metabolic acidosis. CBC, creatinine, electrolytes, chlorides, all these things were normal. Ammonia, 147, elevated, because normal is up to 70. So glucose, slightly on the lower side, 52 milligram per deciliter. Lactate is quite high, 98. So lactate pyruvate ratio 163, urine ketones negative. So generally in the early part of the life, if they present with the vomiting persistent, as it may suggest towards the inborn errors of metabolism, so sometimes we consider it as a differential diagnosis, especially when there is no fever and sepsis is not a differential diagnosis. So we will consider this one. So echocardiography was done, which showed a severe concentric left ventricular hypertrophy, thickened IAS, and the right ventricle wall thickened, moderate to severe mitral regurgitation, moderate pulmonary artery hypertension, right atrium ventricle pulmonary artery dilated. So normal LV function, the impression given by the cardiologist is infiltrative cardiomyopathy or a storage disorder. So USG abdomen is normal. Blood samples for further investigation, we sent for tandem mass spectroscopy and the urine for gas chromatography and mass spectrometry. In the meanwhile, we treated this child with the IV fluids, 10% dextrose, anti-failure measures, and some vitamins. The hepatomegaly decreased by next 96 hours. Breastfeeding was established, vomiting subsided, discharged by day 8 as the baby was all right. So follow-up, asymptomatic, feeding well at 1 month, no vomiting, hepatomegaly of 3 centimeter, weight gain normal. So one may wonder, so what is this condition? Subsequent course investigation reports, GCMS urine, normal organic acid profile, because organic acidemia becomes one of the differentials in this kind of scenario. So tandem mass spectroscopy, high total carnitine, free carnitine, and free acyl carnitine ratio, and normal levels of amino acids. So amino acidopathy is ruled out here. So acyl carnitine profile further identifies elevated free carnitine C0 and C16 to 18. That's the long chain fatty acid defects. The ratio of 367, that is very much elevated. Normal is 100 here. Suggestive of carnitine palmitoyl transferase 1 deficiency. So on therapy, child was having no symptoms, no further admissions. Echocardiography was normal by 1 year of life. Growth and development normal at 2, 3, and 5 years of age. This child also came for follow-up recently. Child is doing well, no other morbidities. The cardiomyopathy has completely regressed. The message here is, this is an autosomal recessive disorder causing a long chain fatty acid oxidation defect. So metabolic decomposition episodes are accompanied by hypoglycemia, hypatomegaly, seizures, renal tubular acidosis, hyperammonemia. We have seen this hypoglycemia and hyperammonemia in this particular child. So long-term problems include psychomotor retardation, seizures, encephalopathy, dystonia, muscle weakness, autism, speech disorder, neuropathy, and attention deficit hyperactivity disorder. So cardiomyopathy is a rare manifestation which can resolve with treatment, as it happened in this case. So parents may also wonder, the baby was normal throughout the pregnancy, born normally, no neonatal morbidity. So they may require some counseling, as this condition requires some dietetic modification and also avoiding of the hypoglycemia. That means frequent feeding is necessary. Most often that is the only treatment which is required, plus minus some carnitine supplementation. The children will do well, as happened in this case. A 42 days old child was brought with multiple episodes of vomiting since 3 days. So after taking feeds, non-projectile, non-bilious, firstborn of non-consanguineous marriage, birth history normal. The striking abnormality what we have seen is a febrile state. So this child had the heart rate of 300 with signs of congestive cardiac failure. So emergency ECG was suggestive of supraventricular tachycardia with the heart rate of 300 per minute. So IV adenosine is the drug of choice here. It was given rapid push and the cardiac rhythm was reverted to normal. So anyway, the children presenting with the supraventricular tachycardia, sometimes there will be underlying cardiac abnormality. This child also had the same thing. It had cardiac corrected TGA with mild left Epstein anomaly, moderate to severe left AV value regurgitation, small ASD, intact IVS, no PAH, and a fair systolic right ventricular function. Chest X-ray showed ventricular enlargement. So blood gas, there was some acidosis, metabolic acidosis, remaining parameters were normal. So there was only underlying congenital heart disease which has given rise to this supraventricular tachycardia in this child. But this child had once settled with the normal cardiac rhythm, but the SVT has recurred, so requiring the amiodarone infusion in the subsequent course. And then it also required flecainide for the persistent supraventricular tachycardia. Once it is settled, the child was started on tube feeds. Amiodarone infusion was tapered and stopped, continued on flecainide maintenance therapy. So direct breastfeeding was initiated, shifted to ward on day 10, discharged on day 14, no recurrence on flecainide therapy. So SVT in children, narrow complex tachycardia. In younger children, the AVRT, atrioventricular re-entry, including the WPUW syndrome is common. in older children or adolescents, AVNRT may be common. So this SVT typically presents as a fixed rate heart rate tachycardia with usually the rate more than 220 per minute. So onset and offset are often abrupt. So P waves are either not visible or seen after the QRS complexes. So what is to remember is the emergency treatment, oxygen IV line, and the first line of therapy may be DC shock to consider 1 joule per kg in children. If not responding, then we can increase the dose to 2 joule per kg. So of course, the adenosine is another drug. So it may be used as the dose mentioned here. Initially maybe 0.1 milligram per kg. If not responding within 2 minutes, one can go to 0.2 milligram per kg. And next, if not responding, 0.3 mg per kg, one can also use. So there are other treatments available for this SVT treatment like vagal maneuvers. So hemodynamically stable child and infant, one can use this maneuver, but not to perform eyeball pressure or the carotid sinus massage. And facial immersion is also one of the therapies, but this should not be used for infants in hemodynamic compromise and shock. Otherwise, this is also one modality of treatment. Going to the third case, 2-month-old child was brought with inability to gain weight and persistent vomiting since the last 2 months. So examination revealed the weight was 2.7 kg. This child was born with 3.2 kg. That means usually there will be weight gain. This child did not gain the weight because of the persistent vomiting. And of course, the weight has further decreased. And the heart rate 120 normal, rest of the parameters are normal. On examination, there was signs of malnutrition like marasmus with the pallor. Remaining examination was normal. CBC revealed moderate anemia, leukocytosis with the neutrophilic predominance. That means there is some associated infection with the underlying condition. The characteristic abnormality noted in this child was hyponatremia. Serum sodium was much below the normal level of 130 or 135. In this child, 120. Hyperkalemia, serum potassium more than 7, and severe metabolic acidosis with the elevated lactate and lactate pyruvate ratio. The serum cortisol was normal. A diagnosis of salt wasting congenital adrenal hyperplasia was considered in this child, and we did send the 17-hydroxyprogesterone level. This is the, if it is abnormal, it points towards the commonest congenital adrenal hyperplasia with the classical 21-hydroxylase deficiency as it occurred in this case. So it was very much elevated compared to the normal levels of 10 to 20 nanogram per ml. So in this child, the hyponatremia, hyperkalemia, persistent vomiting, loss of weight, malnutrition with the elevated levels of 17-hydroxyprogesterone, all were pointing towards the diagnosis of salt wasting type of congenital adrenal hyperplasia. The commonest cause is 21-hydroxylase deficiency. Sodium and bicarb corrections with the IV fluids were given. Hyperkalemia was corrected by K-xylate enema and other measures. In this case, so the children always require the fludrocord and hydrocord supplements. So repeat sodium and potassium normalized after 36 to 48 hours. There was associated urinary tract infection with the E. coli. That is why the child had an elevated leukocyte count and neutrophilic predominance. That was also treated. The vomiting subsided, weight gain observed, discharged after 7 days. So genetic test was planned for this child. Salt wasting CH is the severe form of classic 21-hydroxylase deficiency. So incidence in the newborn screening registries 1 in 14,000 to 1 in 18,000 births. So presents often with the features of dehydration, overfeeding, diarrhea, vomiting, low BP, low sodium levels, low blood glucose, metabolic acidosis, weight loss, and shock. Serum 17-hydroxyprogesterone tests remain the gold standard for confirming the diagnosis of congenital adrenal hyperplasia. So treatment involves the glucocorticoid and the mineralocorticoid replacement, especially in the classic forms, and the parents require psychosocial support because they may wonder what is this condition, when it resolves, how to rear the child further and all. So if it is a virilizing type, then also the parents need appropriate counseling. And of course, the follow-up is required because if there is any intercurrent illness, child might deteriorate further also. So frequent monitoring of serum electrolytes are required. And of course, the salt supplementation also may be required in this type of cases. So moving on to the next case, little older child. This is a 12-year-old girl presents with triage with the weakness since 4 days, severe breathlessness since 1 day. On inquiry, parents reported there is polyuria, polydipsia since 1 month, history of having sweets at school 2 days ago, no history of fever, cough, vomiting, or abdominal pain. She was obese, heart rate was elevated, respiratory rate was 60, so blood pressure normal. So she had typical the Kussmaul or acidotic breathing, sunken eyes, dry tongue, suggesting that there is a dehydration. No pallor, edema, icterus, or lymphadenopathy. So respiration, intermittent grunting, and some kind of gasping respiration was observed in this patient, and she was drowsy and lethargic. The blood gas revealed severe metabolic acidosis in the form of pH 6.9 with a bicarb level of 5.3. CBC suggested there is elevated total leukocyte count. That means some occult infection may be there at that point of time. And the characteristic other abnormalities are the blood glucose level, which was 554 milligram per deciliter. There is a definite hyperglycemia. Glycolated hemoglobin was 14.4%, very high, elevated urine sugar. There is glycosuria, urine ketones 3+, suggesting there is ketonuria, and the C-peptide levels are low. So this suggests that there is a type 1 diabetes mellitus in this child. Chest X-ray was normal. So there was no respiratory cause for the breathing difficulty or the gasp, intermittent grunt and respiratory distress. So characteristic abnormality here was hyperglycemia, glycosuria, ketonuria, severe metabolic acidosis, elevated HbA1c levels. A diagnosis is confirmed that it is a case of severe diabetic ketoacidosis, which is the commonest mode of presentation of type 1 diabetes mellitus in children. So unlike adults, most of the cases are picked up by the diabetic ketoacidosis for the first time. So this child was given IVNS, normal saline bolus over 1 hour, followed by insulin infusion, intravenous 0.1 unit per kg per hour. Dehydration was corrected by the International Society of Pediatric and Adolescent Diabetes regimen. IV antibiotics were added because we thought there was some occult infection. She had some perineal infection as well. So this ISPAD regimen gives a correct idea of rehydration of this children. Type 1 diabetes mellitus often have severe dehydration that needs to be corrected. So initially people have suggested that 24-hour correction, but over the days people have learned that slow correction is much better. So most of these regimens suggest that the correction will go on over 48 hours. Subsequently, with the therapy, that is hydration and insulin infusion, as we can see here, the blood pH from 6.9 corrected to 7.29 at 4 hours, 7.35 at 24 hours, and remains stable at 48 hours of life. In the meantime, the blood glucose level has also come down, the bicarb level has gone up. Hydration is corrected, and the ketonuria, ketonemia, acidosis corrected, and we have achieved the normoglycemia. So normoglycemia, blood gas became normal, urine sugar ketones negative, respiration became normal, the conscious level has improved to normal level. So IV fluids were stopped, insulin infusion also stopped, regular insulin was started at this point of time, 1 unit per kg per day, subcutaneous divided 6th hourly and monitored. Subsequently, insulin was switched to basal bolus regimen, the current day standard therapy, so which includes the glargine and that is the basal, and the bolus will be with the regular insulin. So this is not enough because the parents thought that what is this new condition? So far the child was all right. Suddenly something doctor is telling that diabetes, which is a disease in adults. So the child as well as the parents require a lot of counseling, education regarding the diabetic diet, GRBS monitoring, and the sick day management, information to the school and other things. And the parents, and if the child is adolescent, they need to know how to take this insulin injection safely, what are the sites available, all these things. In the subsequent 2 years, there was no DKA, reasonable glycemic control was achieved in this case. So DKA severity by the degree of acidosis. So all of us know that if it is mild, venous pH of 7.3, moderate 7.2 and less, severe less than 7.1 with the corresponding bicarb level. So this child had a severe diabetic ketoacidosis with a type 1 diabetes mellitus, with a very serious condition when the child landed up in the emergency department, but recovered and went home well. So this is the updated management. It shows that the regular insulin infusions, which may be in the form of 0.05 to 0.1 unit per kg per hour, and subsequent monitoring. And one must always remember that after some 1 to 2 hours, the potassium supplements may be required, and the slow correction is better, so it will avoid the complication, cerebral edema and seizures. Slow correction over 48 hours is the best one. So moving on to the next case is a 2-month-old female infant, first born to non-consanguineously married couple, presents to triage with vomiting, hurried breathing, noisy breathing, low-grade fever 3 days, irritability, refusal to feed by 1 day, treated with antibiotics, nebulization at local hospital. So brought with 1 episode of seizures few hours ago. So birth history was normal, nothing was contributing. So this child is becoming sick first time at the age of 2 months. So examination, the crying infant with the respiratory rate 48 per minute. So most of the rest things are otherwise normal. So investigations revealed metabolic acidosis, pH of 7.29, bicarb levels are low, elevated lactate, and the liver transaminases were high, CPK levels slightly elevated, X-ray chest and echo were normal, treated with the antibiotics, oxygen, IV fluids, ABG normal at 18 hours of life, lactate levels have significantly decreased, breastfeeding was shorted and shifted to mother's side in the ward. So we also consider that it's probably a transient infection-induced problem. But subsequently, 3 days later on breastfeeding, excessive cry, 2 episodes of seizure, sudden onset of tachypnea. When we repeated the blood gas, it was showing a severe metabolic acidosis in the form of pH 6.8 with a very low bicarb levels. So urine ketone sugars negative. So we thought it could be a case of organic acidemia. So we thought we sent this tandem mass spectroscopy and gas chromatography and mass spectroscopy samples. And again, we have treated with the IV fluids, bicarbonate, ABG normalized, direct breastfeeding again restarted. Child was well for next 1 week, discharge, follow-up after 15 days and 1 month, normal, no recurrence of symptoms. Here, the advanced tests like the TMS revealed elevated glycine, and the urine GCMS showed characteristic features of propionic acidemia. That means it is a case of inborn errors of metabolism with the propionic acidemia on protein diet or the breastfeeding. This child is becoming recurrently symptomatic. So most of these babies are born as normal. Subsequently, they deteriorate. So inborn errors of metabolism, why to know? Some people may believe that these are the conditions. Some people may believe that this kind of condition do not exist. But we come across many cases of this inborn errors of metabolism. Most often they may be pushed away, saying that it may be some infection-induced condition, treated, child became all right and sent. They will come back with recurrent symptoms. That's why we should know this. IM affect energy production or affect the synthesis or a degradation of specific molecules, compounds, or both. So variability of symptoms, organ involvement, and a clinical course lead to diagnostic challenges. They may mimic the infection, severe sepsis, and other significant cardiac problems and alike conditions. Considerably impact the quality of life and quite often shorten the lifespan of expectancy. In this field, there is an increase in understanding, technology advancement in the diagnostic and emerging therapeutic strategies. So early diagnosis is very important to prevent the severe clinical symptoms, thus reducing the mortality and the morbidity. So common presentations include an apparently healthy child present acutely with a short history of illness, which is worsening progressively, as we have seen in that 2-month-old child. Sometimes symptoms could be as mild as lethargy, vomiting, or sometimes as severe as encephalopathy and status epilepticus. The common clinical presentations include acute and recurrent episodes of vomiting, respiratory distress, etc., chronic and progressive symptoms, organ-specific manifestations, either single or a multiple organ involvement. The presence of consanguinity, the suspicion of an inborn error of metabolism becomes stronger. But in the absence of this, one cannot discard the diagnosis of inborn errors of metabolism. So if you see, individually, these cases are rare, but collectively numerous, as the general incidence 1 in 800 to 1 in 2000 live births. So it is quite significant problem. So in India also the estimated prevalence 1 in 2,500 newborns. So for this reason, there is a screening program in the neonatal period. So it will screen some of the major metabolic errors. So it may identify 80 to 50 different diseases. So, but we may have more than 500 disorders. So we need to remember that neonatal screening itself is not enough. So newborn screening program, if it does not identify any condition, it does not mean that there are no such conditions, because it's limited. Only few important serious conditions are screened by the newborn screening program or the universal newborn screening program. So these are the 5 groups: energy metabolism disorders, intoxication syndrome, lipid storage disorders, or the metal storage diseases, and the neurotransmitter metabolism defects. So they are actually a very large group of disorders. But the incidence of individual diseases are quite rare. The key question for a clinician when dealing with the suspected metabolic disorder case is what test to order and how to proceed. Because sometimes they come as a very sick presentation, you may not have a time to do a diagnosis. So that is why sometimes it has been told that, so if you cannot save the child in such scenario, it is better to collect the samples and keep and see. So that may help counseling the parents, or if it's the first child to the parents, it may help to counsel the subsequent pregnancies. Important to know the basic and advanced metabolic tests that can be ordered in appropriate setting. A high index of suspicion can lead to early diagnosis. So early diagnosis minimizes the morbidity as well as the mortality. A biochemical test may show normal metabolic levels, as they are not always deranged. In such cases, metabolic tests should be repeated during acute sickness. Early and accurate treatment often leads to fruitful outcome, as we have seen in some of these cases. A molecular genetic test would help counsel needy young couples for future pregnancy or births. Patients with milder mutations and subtle biochemical phenotypes may be missed by the cutoff values used in the screening tests. So they may tell that the tests are normal, no such conditions, but that may not be the true scenario. A normal newborn screen should not exclude these disorders when clinical presentation is suggestive of inborn errors of metabolism. So we may have to do the tests again to find out the disorders. Thank you for patient listening.
Speaking about the acid-base balance, the pH interpretation, it's something that orthopods quite often forget about. They can't interpret it most of the time. So thank you very much. Now on the podium, I would like to invite Professor Chandrasekhar. He is coming to speak about something that is very common, that may affect us directly or indirectly. Most of the time, we think we know the management and how to. So, Professor Chandrasekhar, I would like to call you upon to come give us an insight on HIV and AIDS management and preventive measures.
Oh, good afternoon, everybody. Let's move on to quickly about the management of HIV and preventive strategies. So these are my contents of my topic. So before I talk about the management of HIV infection, I just want to, briefly touch on the HIV replication, and then talk just few slides on all these contents, whatever I've showed here. Now, we all know that HIV is a progressive retroviral infection that affects the immune system. So it progresses from primary infection to a prolonged asymptomatic phase, eventually results in severe immune deficiency. So in the advanced stages, the immune system becomes significantly compromised, making the individual highly susceptible to opportunistic infections and other complications. Now, this AIDS, it represents the late stage of HIV infection with significant deterioration in the immune system. So according to the current definition, we make a diagnosis of AIDS in an HIV-infected individuals when the CD4 count is less than 200, or if they're present with opportunistic infections, one of the opportunistic infections. That is, so what we come across very frequently is PCP, cryptococcal meningitis, and toxoplasmosis. So in our center, we see a lot of these cases. So whenever a patient comes with a very low CD4 count, these are the differentials we think of. Now, just a brief on the global impact of HIV. As of 2023, approximately 38.4 million people are living with HIV worldwide, and about 1.5 million new HIV infections occur every year. So around 650,000 HIV related deaths occur in 2022. And yeah, this I got it from the internet. So it says that sub-Saharan Africa remains the most affected region, accounting for nearly 2/3 of the global HIV population. So significant progress has been made in decreasing the new infections due to better prevention and treatment efforts. So currently around 28 million people are receiving ART. So okay, this is as of I got this from the fact sheets. So you can see that. So sub-Saharan Africa is the most affected region. Okay. So just an overview. Briefly, I just want to, before I talk about the drugs that are used in HIV. So what happens here is the life cycle is to understand how the drug works, the drugs that are used in HIV, how it works, you should know the life cycle. So what happens here is, so this HIV starts its infection by attaching to a specific receptor, that is CD4 receptors, and the co-receptor, that is CCR5 and CXCR4, which is present in the host cell surface. So via GP120, it's a surface protein, it attaches to these receptors and co-receptors. So once, so after attachment, this viral envelope, it fuses with the host cell membrane. So after attachment, the viral envelope fuses with the host cell membrane, and the viral envelope, it allows the viral RNA and the enzyme reverse transcriptase to enter the host cell cytoplasm. Okay. So now these contents are there inside the host cell cytoplasm. So what happens in the host cell cytoplasm is this genomic RNA, that's a single-stranded RNA, is transcribed into double-stranded DNA with the help of an enzyme, reverse transcriptase. So we have some drugs which are acting at this level, which acts on the reverse transcriptase. Okay. Okay. Now, this double-stranded DNA from the host cell cytoplasm, it's transported to the host cell nucleus, gets integrated into proviral DNA. And this proviral DNA gets transcribed into messenger RNA, that is mRNA. This mRNA is translated into viral proteins with the help of an enzyme, protease. So we have some protease inhibitors also for the treatment of HIV. Now, these viral proteins are very important for assembling the new viral particles at the cell membrane. So once the viral particles are assembled near the cell membrane, these newly formed viral particles, they bud out from the host cell, they are from the host cells, okay, giving rise to new viruses. Okay, so this whole process facilitates the replication of virus and the spread of virus within the host. So giving rise to the progression of HIV infection and AIDS if it is not effectively treated. So this is very important to understand the drugs, how it works. So each of these life cycle, there are various drugs. There are various drugs which are available, which is acting at each step of this life cycle. Okay, these are some of the drugs which are available. Nucleoside reverse transcriptase inhibitors and non-nucleoside reverse transcriptase inhibitors. So among the nucleoside, so I just want to tell you that tenofovir is a nucleotide reverse transcriptase inhibitor. So all the other drugs are nucleoside reverse transcriptase inhibitors. Okay. Now there is a slight difference in the nucleoside reverse transcriptase inhibitors and non-nucleoside reverse transcriptase inhibitors in that inhibitors work is this acts on it has specifically attacks on some target site on the reverse transcriptase enzyme. So thereby it prevents the conversion of this single-stranded RNA into double-stranded DNA. It has specifically acts on the target site on the reverse transcriptase. Whereas this one, it doesn't do that. Nucleoside reverse transcriptase inhibitors. So in terms of mechanism of action, it's slightly different. Okay. Now, I forgot to mention about nucleotide reverse transcriptase inhibitor, tenofovir. Tenofovir is actually a nucleotide reverse transcriptase inhibitors, but in terms of mechanism of action, it is almost same. So what happens is during the process of getting incorporated from single-stranded RNA into double-stranded DNA, some nucleotides are added. Okay. So this prevents that nucleotides so that the virus does not replicate. There is no incorporation of the single-stranded RNA into double-stranded DNA. So in that way it works. So in terms of mechanism of action, it's slightly different. Okay. I'm sure you understood what I was trying to tell. Yeah, this protease inhibitors, yes, we know at what level it works. So from the messenger RNA, it gets translated into viral proteins. So this prevents the formation of those new viral proteins. Okay, so protease inhibitors. So just to tell you, the drugs what we use very frequently among the nucleoside reverse transcriptase inhibitors are lamivudine, emtricitabine, and in some cases, I mean, after drug resistance testing, if we find that if the patients are resistant to this emtricitabine or lamivudine, in those cases, we prefer to use abacavir. So non-nucleoside reverse transcriptase inhibitors frequently used is efavirenz. Nowadays we are not using nevirapine. And among the protease inhibitors, very frequently used is atazanavir, darunavir are also sometimes we use, and the lopinavir. It is used along with the booster, that is ritonavir. These are called as boosted PI, protease inhibitors. Okay, and these are the, recent advances. Now, as per WHO recommendation and CDC guidelines, all the treatment-naive patients should be started on integrase-based therapy. Okay, which I'm going to discuss in the future slides. So here it acts on the integrase enzyme, prevents the virus from getting integrated into proviral DNA. Okay, so there are some fusion inhibitors. We don't use that. Enfuvirtide, CCR5 antagonist, Maraviroc. We don't use it. It's available as injectable. And attachment inhibitors, it's not available. Fostemsavir and post-attachment inhibitors are ibalizumab. So which is again not used. Now, what is this goal of HIV management? So our primary goal is to reduce the viral load, HIV RNA levels to undetectable levels, preferably less than 50 copies per ml. Okay, so why is it important? It helps prevent the HIV progression and reduces the risk of developing complications as well as opportunistic infections. So So how do we monitor these patients is by doing the CD4 count is very crucial for the healthy immune system. So by maintaining a strong immune system, individuals are less likely to develop opportunistic infections. So, and it also improves the quality of life. So the ultimate goal of treatment, HIV management, is to, effective HIV management enhances the life expectancy, and minimizing the side effects of ART and managing comorbidities helps lead healthier lives. So this should be ultimate goal of HIV management. Just a few things about the importance of ART in managing HIV infection. We all know that it has to be taken lifelong, reduce the HIV levels. We do viral load, reduce HIV RNA levels in the blood to undetectable levels to reduce the risk of opportunistic infections and other complications. So when the viral load is undetectable, there is no risk of transmitting HIV, helps restore and maintain the immune system by preserving the CD4 T cells. It also increases the life expectancy. So this is the importance of ART in managing HIV infection. Now, when to initiate ART? So regardless of the CD4 count, if a patient is detected to have HIV by the standard laboratory test, patient should be initiated on antiretroviral therapy, regardless of the CD4 count. So the only individuals in whom the benefits of ART is not proven is there is a small proportion of patients, less than 1% of untreated patients with a preserved CD4 count. CD4 count is on the higher side and undetectable HIV RNA levels. These are called as HIV controllers. Okay, so you must be wondering, how do we know in that case, how does this, the routine laboratory test pick up this, whether the patient is HIV positive or not? Nowadays, these 4th generation ELISA kits, they usually pick up because some amount of antibodies are produced, right? So there's some immune system produces some amount of antibodies. So these 4th generation ELISA kits are very sensitive. They pick up this most of the times. So these are called as HIV controllers. So in treatment naive patients, so newly diagnosed patients with HIV infection, we start them on a combination of 2 nucleoside reverse transcriptase inhibitors plus either a non-nucleoside reverse transcriptase inhibitor, PI, or INSTI. But most of the times in treatment naive patients, as per WHO recommendation and CDC, we use INSTI integrase inhibitors containing regimen. So the preferred regimen is bictegravir, emtricitabine, and tenofovir, or dolutegravir, tenofovir, and emtricitabine, or tenofovir, lamivudine, and dolutegravir. So what we use very frequently in our place is dolutegravir based therapy, TLD regimen. So this drug is available in all the centers, in all the government centers, in all the ART centers. So we have ART centers in all the districts. Okay, so this is what is a regimen we use in all the treatment naive patients. So dolutegravir based therapy, it's available as a TLD regimen. Now these are highly effective in achieving viral suppression in the majority of patients. Now the second line regimens are used only when the first line regimen fails due to drug resistance or intolerance. So in those cases, we use protease inhibitors, boosted PI, boosted protease inhibitors, plus a combination of nucleoside reverse transcriptase inhibitor and INSTI. Okay, protease inhibitor, boosted PI, plus a combination of NRTI. So NRTI we frequently use is lamivudine, because the chances of developing cross resistance is less likely when we use lamivudine. It doesn't confer resistance to other drugs. And instigaravir. So this is highly effective in patients with a resistance to first-line therapy. Now, this is a very nice article which is published in Lancet 2020. So regarding this fixed dose combination of bictegravir, emtricitabine and tenofovir versus dolutegravir containing regimen for the initial treatment of HIV infection. So before 2020, we used to use your dolutegravir based therapy. But now what the WHO recommends is bictegravir based therapy. Bictegravir, emtricitabine and tenofovir is non-inferior to dolutegravir containing regimen for the initial treatment of HIV. So in our place, we still continue to use dolutegravir based therapy. It's a government program. So it's initiated by the government. Now, so what is the significance of adherence to ART? This is very essential for maintaining the viral loads at undetectable levels. So if the adherence is inadequate, it can lead to viral replication, drug resistance, and treatment failure. So, and the other thing is the risk of transmission also becomes very low. So adherence ultimately it reduces the risk of developing opportunistic infections. So some of the common barriers to adherence. So some of the drugs which are used for the treatment of HIV has some side effects. So patients actually they stop taking medications because of these side effects, or they are not very compliant with the medications because of the side effects. So education is very important. Educating the patients is very important regarding the adherence to treatment. And stigma and discrimination again stop the individuals from seeking treatment or taking medications in public. So these are some of the common barriers to adherence. Now the patients are monitored during ART therapy. So how do we monitor them? So we do HIV RNA levels. As per WHO guidelines, it has to be done in all the patients at baseline and regularly during therapy. This is a most reliable indicator to know whether the patient is responding to ART or not. So the goal of ART is to suppress the viral load to below the quantifiable limits of assay detection, that is less than 20 to 40 copies per ml. So how frequently should it be monitored? How frequently are we supposed to do this HIV testing? HIV RNA testing. So this should be performed approximately 4 weeks after initiating ART. Then every 8 weeks until the levels fall below the assay's limit of detection. So once the viral suppression is achieved, then it can be done 8 to 12 weeks after ART initiation. So once the viral load is below the level of detection, it can be performed every 3 months. If the viral load remains suppressed for 1 year, then it can be done every 6 months. But we repeat, in most of the developing countries, we do it yearly. Okay, 6 months to 1 year. Yeah, 6 months to 1 year. Okay. So what is the expected virological response? So once the patients are initiated on ART, so what is that we expect? So once the patients are initiated on ART, we expect a 2 log or more decline in the viral load by 2 to 4 weeks of treatment. So there is something called as a viral blips. It's called as a low level viremia. That is, it's defined as a low levels of detectable HIV RNA levels between 20 and 200 copies per ml. So this is very important. We need to see whether the patient is adherent to treatment or not before we diagnose a low level viremia or viral blips. So but it doesn't mean that even if it is present, if the copies are around 200, if it's less than 200, say if it is around 150, 160, it doesn't mean that it is virological failure. It does not require any change in therapy. So make sure that the patient is adherent to therapy. So there is something called as a virological failure. So this occurs when a patient is not able to achieve a viral load of less than 200 copies within 24 weeks of initiating ART. Or if they have a sustained recurrence of viremia to more than 200 copies per ml after viral suppression. So this is virological failure. So if the patient is unable to achieve a viral load of less than 200 within 24 weeks, then it is called as virological failure. Now this is one part, that is viral load testing. And the second thing is CD4 count. Simultaneously, we will monitor the CD4 count as well. So we take a baseline CD4 count in patients with a low baseline CD4 count, that is less than 300. If it is less than 300, it may be done every 3 months after initiating therapy. So continue to monitor the CD4 count every 3 to 6 months until the CD4 count is more than 300. So if the CD4 count remains more than 300 on ART regimen, at least for 1 year, then it can be monitored annually until the CD4 count is more than 500. This is again from the WHO guidelines. Now, these are some of the common opportunistic infections which are encountered. This with respect to the CD4 T cell count. So we know that the most common opportunistic infections we encounter in India is tuberculosis. This can occur at any CD4 count. Even if the CD4 count is more than 500, we have seen some patients developing tuberculosis. I'm sure that it's the same even in other countries, right? Okay, so see, these are some of the common infections. So bacterial infections are again common in patients with the CD4 count of more than 200. So no routine prophylaxis required in these patients. So once the CD4 count is less than 200, so these are common opportunistic infections we encounter, that is PCP, cryptosporidiosis, candidiasis. So most of these patients with the CD4 count of less than 200, we initiate on PCP prophylaxis. We put them on cotrimazole, trimethoprim, sulfamethoxazole, single dose. Yeah. So if the patients are allergic to cotrimazole, they are initiated on dapsone. There's a small risk of hemolysis in all these patients. So we have had some problems. So if the patients don't tolerate dapsone, then there's nothing left. If the CD4 count is less than 200, so these are the opportunistic infections we encounter. So what the WHO recommends is these patients with the CD4 count of less than 100 should be initiated on TMPSMX, cotrimoxazole, anyway that takes care of PCP as well. And cryptococcal meningitis, the recent guideline says that fluconazole should be considered in patients with a CD4 count of less than 100. And if the CD4 count is less than 50, we give MAC prophylaxis. That is Mycobacterium avium complex prophylaxis are given. And in all these patients, ophthalmological evaluation is very, very important. They should undergo routine ophthalmological evaluation to detect early CMA retinitis. So this is a prophylaxis which is recommended in cases of MAC infections. That is azithromycin. We usually initiate at a dose of 1.2 grams. It's available as 500 milligrams. So 1.2 grams we advise. Every week it is given. So vaccinations, yes, it is recommended for influenza. Okay, pneumococcal vaccine, as somebody suggested. So we give this PCV followed by PPSV 23 and hepatitis B, hepatitis A vaccine and human papilloma virus. This screening is cervical cancer screening is routinely done in female patients with HIV infection. We have picked up a lot of cervical malignancies. So the most effective way is to prevent opportunistic infections by initiating ART therapy to undetectable levels and have a higher CD4 count. Now, this is, it's kind of little complex. So what is this drug resistance? Now, when the HIV mutates, it does not respond to our routine antiretroviral agents. So it leads to treatment failure. It causes a viral load to increase and the CD4 count drops. So what is the test we do? We do this, the genotyping, which is done in most of the centers, right? So in our center, it is done. So this identifies mutations in the virus that causes resistance to specific drugs. And it provides specific information on the specific mutations in the HIV virus that are associated with resistance to antiretroviral drugs. Phenotyping, it's more of, we don't do it in our center. It's more of for the research purpose. And some of the strategies to manage these resistant strains is, once the resistance is detected, we adjust the regimen to include active drugs from the other classes of ART. So make sure that the patients are adherent to ART to prevent the development of further resistance once they're initiated on the drugs that are resistant to the first line drugs. So these are kind of little boring. I will not go into too much details of this. So I just want you to understand about the preventive strategies. Behavioral strategies are very important, and biomedical strategies. Just I want to highlight just few things, important things here. Now regarding these behavioral prevention strategies, safe sex practices are advised. These are very effective in preventing HIV transmission. Sex education programs in schools should be initiated, and communities raise awareness about HIV transmission and importance of regular testing. And providing needle exchange programs is very, very important to reduce the transmission of HIV among the people who inject drugs, and promote safe injection practices and access to sterile syringes, and encourage reducing these multiple sexual partnerships, and the disclosure of HIV status to the sexual partner should be encouraged for informed decision making. So now these are the two things I want to just focus on: pre-exposure prophylaxis and post-exposure prophylaxis. Now, who are the eligible candidates for pre-exposure prophylaxis? So these are the individuals who are at high risk of HIV infection. So people with HIV positive sexual partners, individuals with multiple sexual partners, people who inject drugs and share needles or equipments, and individuals who have been diagnosed with sexually transmitted infections in the past 6 months are the eligible candidates for pre-exposure prophylaxis. So what is recommended from the CDC and WHO is tenofovir, emtricitabine. This is taken as a once daily oral pill, and it is usually given for about 28 days. This is given for about 28 days. But prior to initiating pre-exposure prophylaxis, individuals should be tested for HIV to confirm the negative status. So this testing has to be done every 3 months to make sure that the report comes out to be negative. And this is highly effective in preventing HIV when it is taken consistently. So this, once it is taken, it reaches a protective levels usually by 7 days. Usually by 7 days, and this has to be continued for 28 days. It has to be continued for 28 days. Okay, so what does this say? Daily use can reduce the risk of getting HIV from sexual contact by about 99%. That's really good. And from the injection drug use by at least 74%. So I think it's, it's very important to, understand about the pre-exposure prophylaxis. Now, coming on to the post-exposure prophylaxis, this should be recommended to those who are exposed to HIV through occupational exposure, needle stick injuries, or non-occupational rule sexual contact. And this should be initiated as early as possible, preferably within 72 hours of exposure. And usually this post-exposure prophylaxis is given for about 28 days. And baseline HIV testing has to be done prior to initiating this post-exposure prophylaxis, and follow-up testing should be done at 4 to 6 weeks, then 3 months, and 6 months after exposure. So I want to reiterate again, it is repeated. Follow-up testing has to be done at 4 to 6 weeks, 3 months, and 6 months after exposure. So this is a current recommended regimens from the WHO. I'm sure most of the institutions are following the same thing. So for the adults and adolescents, three drug combination is recommended: tenofovir, emtricitabine, plus we prefer to use dolutegravir over raltegravir. Okay, so dolutegravir is given once daily. So this is a preferred regimen. Now the alternate regimen, rarely we go for the alternate regimens. So in cases where the first line medications cannot be used because of drug intolerance, we use alternate regimens. So in that case, we use zidovudine with lamivudine combined with a third agent, that is boosted lopinavir, or we go for the other protease inhibitors, we use atazanavir, or even darunavir can be used. So we have easy access to darunavir. We don't prefer to use lopinavir. So anyway, I've spoken about this viral suppression. So just one line I want to tell you here this. So the ultimate goal of HIV treatment is to suppress the virus. Okay, so reducing the amount of HIV in the body is to very low levels, to less than 200 copies. So, but I mean, this is about viral suppression. So this is achieved through consistent use of ART. So when someone achieves a viral suppression, immune system is well protected, prevents the risk of getting opportunistic infections. Now there is the other thing is undetectable. Goal of HIV treatment subsequently ultimately should be undetectable viral load. So preferably it should be less than aim for less than 20 copies, 20 to 40 copies per ml. Okay, so that it cannot be, sometimes it cannot be detected by the standard test. We get, we'll end up missing. So sometimes we repeat the test after about 4 to 6 weeks, and then again at 3 months. Now, so what is the importance of routine HIV testing? Is identifying HIV infection allows allows for the early detection and prompt initiation of ART, improves the health outcomes as well as reduces the risk of transmission of infection. So these are the tests which are done, rapid test and ELISA. So what we do is a 4th generation ELISA we use. Okay, and routine testing we do for at-risk populations, people with multiple sexual partners, individuals who inject drugs, and pregnant women to prevent mother-to-child transmission. So this is about pre-test and post-test counseling. I will not get into these details. So this is again an important topic. Preventing mother-to-child transmission, it's a very important topic. So this occurs when an HIV positive mother passes a virus to her baby during pregnancy, childbirth, or breastfeeding. So antiretroviral therapy should be initiated to all the HIV positive mothers, irrespective of the CD4 count, as early as possible. And this help and suppress the viral load in the mother to reduce the risk of transmission HIV to the baby. Okay, now cesarean section is recommended to reduce the risk of transmission during the childbirth. That is again depending upon the viral load. Okay, if the viral load is on the higher side, so cesarean section is recommended. If the viral load is fully suppressed, then they can actually go for vaginal delivery, normal vaginal delivery. The risk of transmission is very, very low. So after birth, the newborn should be initiated on ART for about 4 to 6 weeks to reduce the risk of infection. And breastfeeding, it's if the safe alternatives like formula, if it is available, avoid breastfeeding as much as possible to prevent postnatal transmission, though the risk is very low. Okay, but in the settings where the formula is not safe or feasible, breastfeeding combined with ART is recommended to minimize the risk. This is again from the World Health Organization guidelines. So this is about what is the role of community organizations in HIV prevention. So I want to reiterate again, raise awareness, educate the public about HIV prevention, transmission, treatment options. Okay, we have a wonderful treatment options. The risk of getting opportunistic infections are also very low. HIV transmission is very low. So provide emotional, psychosocial, psychological and social support to the individuals living with HIV to reduce the stigma and discrimination. So education, outreach programs, these are very important. This is a role of community organizations in HIV prevention. Now, this is again a major problem. So what is the impact of stigma on HIV prevention and treatment? What are the barriers to testing and treatment? Why the patients don't get tested? That is because of the fear of stigma. This is a problem even in India. In India, all the developing countries, there is a fear because of the fear of stigma and discrimination prevents many individuals from getting tested. Some individuals might actually postpone or completely avoid getting tested for HIV or seek treatment because they're afraid of being judged, rejected, or stigma because of the social stigma. Okay, stigma can lead to isolation, depression, anxiety, which can again affect the health, overall well-being of HIV-infected individuals. So these are the strategies for reducing stigma. Again, educate, train the healthcare providers. Community engagement is very important. And of course, policy and legal protections are in place, right? Okay, these are some of the future directions in HIV prevention. Vaccine development, nothing much has happened. There are some trials which are going on. Okay, this can offer long-term protection against HIV. So there are recent advances in mRNA technology, which is used in COVID-19 vaccines. They have some potentials in HIV vaccine trials. So despite ongoing challenges, early stage clinical trials have shown some promising results in creating effective immune response. But the major challenge here is because of the genetic diversity of HIV strains and because of the rapidity they mutate, it makes the vaccine development very complex. This is again, it's a good thing in long-acting injectables are available. We have this cabotegravir. So this is, it's a long-acting injectable. It can be given intramuscularly. It can be given every 1 to 2 weeks. Significantly improves adherence and it is also very convenient. So this is actually published in Lancet in 2021. Okay. So cabotegravir is available. It's a long-acting injectable. It can be given intramuscularly. It can be given every 1 to 2 months. Thank you.
Thank you so much, Professor. So next up and waiting online is Dr. Andorra Webster is a pediatric emergency medicine consultant at the University Hospital of Wales in Cardiff, where she serves as an educational lead. She has a background in pediatrics and specialization in pediatric emergency medicine. And she has an extensive experience also in major pediatric trauma centers in the UK and Sydney, Australia, as well as delivering ETAT in Malawi. So I'm handing over to Dr. Webster, who is going to present to us on neurocritical care in neonates and children. Thank you.
Hi there. I believe my presentation has already been recorded, so I will let you go on and play the recording. Hi, my name is Dr. Andorra Webster, and I'm a paediatric emergency medicine consultant in the University Hospital of Wales, Cardiff, in the United Kingdom. It's a huge pleasure to be talking to you today about neurocritical care in the paediatric emergency medicine setting. Having heard how many it was a bit of a really pre-recorded session, although I would much say the weather here is pretty bleak and winter and it's a bit cold. Anyway, I wanted to start by giving you a little bit of information about where it is I work. So I work in Cardiff, the capital of Wales, and I put a map there on the top right hand corner of the United Kingdom. You can see Wales in red. It's a relatively small country, and probably most famous for its passion for rugby. It's a very beautiful country. It's got a long public coastline. It's very rural and lots of mountainous areas, and it attracts walkers throughout the season. And so we see a huge range of trauma that comes to Cardiff, major trauma centre for the South West Wales. It's co-located emergency department, so we see both adults and children. And within the paediatric emergency department, we have a combination of RChem trainees, so adult emergency medicine doctors that are sub-specialised in paediatrics, and paediatricians who have done some additional training in paediatric emergency medicine. And we find that the combination of having both put together is really great for skill sharing, particularly in high acuity pathology. We're a relatively busy centre, so we see 35,000 children per year, mostly minor injury, minor illness and trauma. We are not a single point of entry, so children that have been seen by the GPs go directly to the children's hospital. And we became a paediatric major trauma centre, and we see about 120 major traumas a year. Many of them are primary transfers from the roadside, but we also take secondary tertiary transfers from other local hospitals. And a little bit about me. So I'm a paediatrician by background. So I did most of my training in Bristol, which is a large children's hospital, inner city hospital with its own emergency department, along with cardiothoracic and neurosurgical services. I then took some extra time out and went to Sydney, where I worked in another large children's hospital with a paediatric emergency department, and also very busy PICU, which did critical care for cardiac surgery, neurosurgical interventions. And then for my specific training, I went to Birmingham, which is smack bang in the middle of England, very busy in a city hospital, but seeing an array of pathology and some really interesting rare disorders. It's a liver centre, and it has a population of children with metabolic disorders as well. That kind of summarises my training and essentially my experience in trauma, which has given me such a passion for paediatric emergency medicine. So my disclaimer is that I have no conflicts of interest or affiliation to care. I've been asked to talk to you today about time-critical neurological presentations. I have 40 minutes, so not so long, and definitely not long enough to go into everything in a lot of detail. However, there's 3 areas I'd really like to focus on, and that's how we consider the differential diagnosis in the acute setting, our management priorities so that we can make sure patients are getting the right treatment, and a little bit about Penn research at the end. So paediatric emergency medicine is a relatively young speciality, and I think high quality research is difficult in any acute specialty, but particularly so in paediatrics. And there's recently been a push to really work on our methods of capturing and recruiting patients into studies, and recently had a fantastic study, which I'll tell you a bit more at the end, but infants neurological presentations. So first of all, I wanted to ask the question, what is a time-critical neurological presentation? So it can be really difficult working in the paediatric setting when we see so many children with undifferentiated, quite generalised symptoms. We see a lot of unsettled children, vomiting, altered feeding, and these can all individually be symptoms of neurology, but as we know, they can be symptoms of very minor pathology as well. So having thought about it a bit more, I feel are particularly concerning and highlight the need for some time-critical assessment on new or progressive focal neurology. So we do see a range of children who have got known focal neurology. We see a lot of squints, and children that have already had a diagnosis of cerebral palsy and have some weakness, etc. What I find particularly useful in these children who present is to try and get a video from parents, pictures from a mobile phone if you can, to try and make a comparison regarding what you're seeing today or what you're hearing if it's speech, and what is their baseline. Another presentation I always find very concerning is acute severe headache. And I think irrespective of whether you're an adult or a child, that's always a concerning presentation. but in the pediatric population who are non-verbal, it can be particularly challenging to identify that as a symptom. And even children who are young and verbal can struggle to articulate a headache. It's not a part of their vocabulary that they commonly use. And so you have to look for features of headache and signs of headache. So head banging can be one, rocking, irritability, and just altered feeding, an array really of features that can suggest that the child's uncomfortable and unable to settle. Acute confusion and altered behaviour. So I think it's important to remember that due to children's developmental stages, they often have that phase when they're younger where they're very keen to hand to mouth objects. So it's easy for children, if they come across medications or toxins, to put them into their mouths without there being any clear history of that happening. And then with adolescents, we see more risk-taking behaviour. And we have to think about intentional use of drugs, as well as other reasons why patients may be acutely confused. And then thinking about a reduced GCS, if it's in the context of trauma, or an alteration to a patient's level of alertness when it's atraumatic, and thinking about whether we can identify why that has happened and whether we feel this is something that can be observed or whether it needs immediate intervention. So I think a really basic rule is just to keep it simple. When you see patients presenting and there's concerns about their neurology, it can be very tempting, particularly if you're from a paediatric background, to think about all those unusual signs and symptoms that we learned about, all of the different conditions that are rare and wonderful. However, I think when you're working in the acute environment, it's really helpful just to have very broad categories that you work to help you initiate efficient therapy. So I tend to think of infective causes first. We see a lot of children who have temperatures. In the UK, most children are vaccinated with quite a comprehensive vaccine schedule. So it's quite rare to see bacterial infections, but we do see a huge amount of viral infections presented to the hospital. Trauma, there's normally a good history for trauma, but always suspect it even if there isn't. Vascular pathology, now again, that's quite rare in paediatric patients. However, in the acutely collapsed patient where there's a concern about neurology, it is not uncommon to identify that a child's had an AVM, so congenital vascular malformation, and it should always be in the back of our minds. Biochemical, thinking about what the child's ingested, any access to medications, and that kind of runs alongside toxins really. Are there any concerns, any exposures to things that might have changed their homeostasis? So a common saying that I was taught when I was at medical school, I'm sure lots of you have heard it before, when you hear hooves, look for a horse and not a zebra, and definitely not for a unicorn. Common things are common. Although I do appreciate that there's probably people signing in from different places around the world where seeing a zebra wouldn't be quite so unusual, but it's definitely unusual here in the UK. So common things are common. Think common, and you can always develop those thoughts later. But start with your sensible and systematic approach of managing patients. Now, I think it's important to say as a disclaimer to that lots of people, particularly people who are experienced in paediatrics, will have seen many children coming through the department and will have a feeling, a gestalt, that something's different or something's not quite right. And I think it's really important not to ignore that. Our job is very much about observation and pattern recognition. And if you see something and it doesn't fit or you feel uncomfortable, I think it's really useful to try and pinpoint specifically what feels uncomfortable and also try and vocalize that with your team and bounce that idea and just work out if there's something that takes you down a different avenue that you just need to be pursuing. So I wanted to run through a few cases that will help us think a little bit more about the neurological presentations that we frequently see coming through the emergency department. So the first case is a 3-year-old female. She's had 2 days history of coryza. She didn't want any breakfast today and she's quiet. Her mother reports that she noticed her lying on the sofa, shaking all 4 limbs with her eyes rolling backwards. The episode lasted for approximately 3 minutes and then ceased and she slept afterwards. On examination, her airways are own and there's no concerns about stertor. Chest is equal, there's no crackles or wheeze, and she's saturating with 98% in air. Cat refill is less than 2 seconds centrally. She's got normal heart sounds and she's got relatively normal vital signs of her age. And from a D perspective, on the AVPU score, she is responsive to voice. Her pupils are equal and reactive. She has a sugar of 5.6 and it's noted that her temperature is raised at 38.9. On undressing her and having a good look, she's got no rashes, but she is snotty as per the history. So the question raised here really is, in a patient that's presented in this situation, how quickly do we need to intervene, or do we not need to intervene at all? Is this someone that we can observe? This leads on to a bit of information about febrile convulsions. So the history that we've got there from that presentation is a classical febrile convulsion. And as I said earlier, because we do see a lot of patients that are fully vaccinated, it tends to be that these children have got an intercurrent viral illness, often through nursery and siblings, etc. Febrile convulsions are common, so about 2 to 5% of children under 5 years of age, with a peak at about 2 years of age. And when we see these children in the emergency department, there's 2 priorities really. First of all, it's to try and identify the focus of the fever. So if you've got a child who's got a clear focus, that they're very snotty, that's fine. We can feel rest assured that we know why they're febrile. However, if we don't, and there's a question about underlying cause, it's always good to rule out a urine infection, as we would treat that with a course of antibiotics. And also to think about other causes, specifically central nervous system infection. So any history of kind of a slow onset of symptoms prior to the seizure. So, neck stiffness, photophobia, increasingly sleepy over a period of time. They would all be things that would raise my alarm bells of thinking of, central nervous system infection. And the other thing that we like to do in the emergency department with these children is categorise them into simple or complex febrile convulsions. And the reason we do that is we know that children who have had a complex febrile convulsion are at a slightly increased risk of developing epilepsy. And we also know that all children who've had a febrile convulsion, simple or complex, are more likely to have a febrile convulsion in the future. So when we divide them into these 2 categories, it's a relatively simple process really. To be a simple febrile convulsion, you need to fit into the correct age range. So that's 6 months to 5 years, or we have to say 6 months to 6 years. Children tend to only have 1 seizure per illness episode. So if they've had more than 1 seizure in 24 hours, or they have more than 1 seizure episode in that illness, then that would be unusual. It should be a generalized tonic-clonic seizure, so it should affect both sides of the body. The seizure duration should be less than 15 minutes if it's self-terminated. And we should find that when children have had a little sleep and their post-ictal period has passed, they return to their normal neurological baseline, so they're back to their normal self. So classically, these children have a cold, spike a temperature, have this sort of episode of witness seizure, often present, they have a long old sleep in the department, and then they're up and about running around, and we can all feel quite reassured that they're back to their normal self. And we don't do any investigations for these children, we don't do any blood tests, and we don't do any imaging. And I've attached a QR code there, which is a link to the NICE guidance, which has got a bit more information about the management of febrile convulsions. The next case is an 8-year-old male. He's riding his bike wearing a hat, and he has a witness collision with a car in which he's described to have bullseyed the windscreen, which I'm sure most of you are familiar with, but that suggests a high impact head injury and shattering of the windscreen. There's a reported loss of consciousness for a minute, and he's had 2 vomits since it happened, 30 minutes apart. And we tend to say that if vomiting happens more than 15 minutes apart, then we consider that 2 separate episodes. He's walked into the emergency department. On examination, he's moving his neck. There's no concerns about his airway. His chest is clear with no surgical practice. There's no concerns from a cardiovascular point of view. He's got no bruising or distension to the abdomen. And neurologically, his GCS is 14. So he's E4, V4, M6, which means he's dropped 1 point on his voice. Pupils are equal and reactive. There's no body swelling or evidence of external evidence of head injury, and no other injuries are identified. So we know this boy has got a GCS of 14. He's dropped 1, as we say, on voice, so he's probably disorientated or confused. Again, the question is, do we need to put this boy through the scanner now? If so, are we just scanning his head? Are we scanning his neck? Or can we observe him and give him a little bit of time? And so head injuries in children is a hugely discussed area of paediatric emergency medicine. And some of the points I really wanted to focus on are that always consider an associated neck injury, as with the adult population, and have a think about whether they've got a distracting injury or whether they are neurologically not at their baseline and therefore not reliably able to exclude a neck injury. Whether we can get a good history from a witness, videos, photographs, etc. And one of the things we do notice a lot more nowadays is that due to the use of video doorbells, a lot of families are able to access video footage of events that have happened from looking at neighbours or their own doorbells, and that can be really useful. Thinking about infants who present with head injuries, so they often present with really vague symptoms, and we should always be thinking about head injuries in children if they're presenting with symptoms that could be neurological, particularly as some of these children can be safeguarding and may just present with a history of ears, pallor, altered feeding, high-pitched cry. And some work has been done recently looking at what we call stealth trauma. So children who present as an alternative presentation are identified to be a head injury, often safeguarding cases. And it's been identified that there's often missed associated injuries because they don't have the full primary survey, which they otherwise would have got if they'd come in as a trauma call. So there's been a lot of work on trying to identify which children should get a CT scan and which children shouldn't. And it was quite well reported that there was variation between practice, particularly internationally. And so a study was undertaken in Australia a few years back now, the APHER study. And I've linked a QR code here to an article reviewing the study, which I think is really helpful. It's a big study and we don't have time to go into it in detail. It looked at 20,000 children and came up with a flow chart looking at which children we could observe and which children we needed to think about scanning. And it focuses not only on classical acute presentations of head injuries, but also children that present 72 hours or more after a head injury, those with a known VP shunt, and those with a clotting disorder or who are on anticoagulants. It's a really useful article and it really helps to highlight what the risk factors are in children, particularly how we now recognise that vomiting in children is a lot more of a concerning feature when children are older than when they're younger. And finally, a 13-year-old female. So the history for her is that her mum has noticed some slurred speech for the last hour. She reports a headache, although she's got no history of any trauma, and she's taken an oral contraception for menorrhagia. So on examination, her airway is fine, her chest is clear with normal saturations. Cardiovascularly, her examination is unremarkable. Her heart rate is 124 and her blood pressure is 132/76. She is alert, pupils equal and reactive, but she is noted to have a left-sided motor weakness, which is new, and she doesn't have any rashes. So this case takes us on to talking about paediatric stroke and the challenges in early diagnosis, particularly as we often think of stroke mimic pathology, so children that have got a migraine, Todd's paresis. And we know that pediatric stroke is rare, but it's actually more common than brain tumours. And 70% of the survivors have a significant disability, and delayed diagnosis is common. So causes are varied, with 50% being due to arteriopathies, 25% cardiac. But what we do know is that urgent imaging is the key. So the Royal College of Peace and Child Health have recently done a lot of work in developing a stroke pathway. I've put a link to the document here. It's quite a lengthy document, which is about 200 pages, that talks in a lot of detail about paediatric specific symptoms with stroke. And there's also a summarised summary point, as well as the flowchart that I've attached here. I realise it's not a great visibility because it's quite small text, but it talks through the initial stages of identifying patients who we think are at a high risk of stroke, and then how we then liaise with the correct teams to make sure that we can get early CTA and CT. So moving on to management prioritisation, I've put down that it's as simple as ABC, because I think it's hugely important to highlight the benefit of having a shared mental model and taking a systematic, structured approach. So in the UK, we tend to use APLS as our life support manual, and many of the department will have been on the APLS course, and therefore we tend to work off the same hymn sheet when we're managing patients who come through the resus department. I know that there's also ETAP Plus, which I'm sure many of you are already familiar with, which the college has developed, which is a modified version of APLS, which is relevant to knowing the low resource setting. So first of all, I think whenever you have a situation where you think there's going to be high acuity, preparation is key. And if you get the opportunity, and if you're given time to prepare, that is a luxury that should really be utilised. And evidence suggests that 10 minutes is perfect in terms of the amount of time that you put out the call to ask for help. It gives people time to get down to the department, have a conversation and do some preparation without causing huge amounts of disruption to the hospital or the other area in which you may be working. And the way that I like to do this is I like to work from the 4 S's, which is the right stuff, the right staff in the right space with the right systems. And that can be applied to whatever pathology you're expecting if you've got a good idea of what's on its way in. So in the sense of the neurocritical presentation, I'd be thinking for staff, making sure we've got our doses ready of the right intubation drugs that we would want to use. Particularly if we know the child's age, we can calculate their weight and make sure that that's not delayed. The right staff, making sure that the neurosurgeons are aware, thinking about whether we need extra radiology capacity, the space. Are we in the most appropriate space that we have? And in the hospital where I work, we only have 1 resus space, and making sure that we make that available if we need to. And the correct system. So is a CT scanner empty? It's a busy hospital where I work, and there's often adult patients going through the scanner. So I always like to give them a heads up to say, can you make sure it's empty in 10 minutes time? Are neurosurgical theatres open? Do they have capacity? Just thinking about all the things that we may need as we go through the case. And I always like to think of my role as a trauma team leader or as a team leader in a non-traumatic high acuity case as being the conductor. I think it's really important to stand at the bottom of the bed and take an overview. And the things I think my role in that situation, and I think most of my colleagues would agree, it's to get feedback. So it's to make sure that your clinical team know what information you need and relay that information back to you. So that's often done in the form of the primary survey or the primary assessment, making sure you're really clear on what information you want. And then setting goals, like we talked about earlier, a shared mental model. The 30 minutes is the gold standard to try and get a patient through the scanner if they're going to need a scan. So setting the time and declaring the emergency. You know, it's midday and I would like this patient through the scanner by hour. And everyone knows what we're working towards and can start to mitigate any challenges that may stop that from happening. Good communication, so talking to the rest of the hospital, talking to other teams, do we need to make sure that PICU are making the bed if that's where the child's likely to go? Do we need to ask the neurosurgeons to come down to the department if we think that this patient's going to go straight to theatre? And making sure to the best of our ability, and it's not always possible, but making sure that we can make this a streamlined conveyor belt. So ideally this patient will present to us, have their assessment, identify any reversible, life-threatening problems, get them to the scanner if that's where they need to be, and then onwards to their definitive place of treatment, whether that's theatre, intensive care, or the ward. But to have that streamlined one-way flow is always ideal when we can. And I guess the question is, why are we doing it like this? Why does it matter? Why does this have to be time critical? And the answer is, prevention of secondary brain injury. We know that the primary brain injury, so the impact and the damage caused at the time of the initial insult, is irreversible and outside of our control. But our role within the paediatric emergency department is to do our best to make sure that we minimise secondary brain injury by creating the best environment to allow those brain cells to not have any further compromise, so being perfused with oxygenated blood. And this takes us back a little bit to the days of medical school. I'm sure you can all remember the Monroe-Kelly doctrine, but I just wanted to highlight, what's actually happening when we're thinking about this neuroprotection for patients. So up until the age of a year, most children have got an open anterior fontanelle, and after that it tends to close. Once our fontanelle is closed, our brain is essentially housed in a closed box, as we all know, and there's a balance there between our blood, brain and CSF. And I'm sure you're all familiar with this image, which shows that the presence of a space-occupying lesion, be that a tumour, blood, swelling, can cause an initial increase in pressure, which can be compensated. And we see that by a reduction in your CSF and a change in your blood volume. And then if that doesn't cease, or we don't manage to intervene, that space occupying lesion can continue to expand, and we will see a compromise, and that's a decompensated raised intracranial pressure, which has got often findings that we see on the CT scan, but suggests that the brain is really being compromised. And I remember a neurosurgeon saying to me once, think of this situation as the brain being like the heart of a heart attack. You really need to be thinking that this is every second counts. This is brain tissue that's really threatened. So I wanted to talk to you about what we can do in the emergency department to undertake neuroprotection, so this kind of prevention of secondary brain injury. And it's a huge topic, and I can't cover it in extreme detail in the presentation today, but I wanted to give a pragmatic approach I tend to take from the bottom of the bed. So I always like to think of the patient from head to toe and work through what the things I can do immediately to try and improve this patient's brain perfusion. So first of all, we try and put the head up to 30 degrees, the head of the bed up to 30 degrees if able. But I think it's really important to highlight that you can only do that if you can tilt the bed in its entirety if the patient's immobilized. So we would never move the head of the bed if it meant compromising immobilization of the C-spine. Remove any restrictive neckwear, if that's jewelry, clothing, a collar. So we don't use collars in children, we tend to block children. And make sure the head's in the midline if you can, just to try and minimize any obstruction to venous drainage. Oxygenate the patient to 98%, and there's some evidence to suggest that there can be damage from free radicals, oxygen-free radicals. So we avoid oxygenating to 100% and try and stick to 98 where able. Maintain a normal PCO2. And I know historically there was lots of conversations about autoregulation and what was the right PCO2. But the consensus is at the moment that low normal is the place we want to be. Maintaining blood pressure. And so we know that our cerebral perfusion pressure is our mean arterial blood pressure minus our ICP, our intracranial pressure. So if our intracranial pressure has raised, we know that it's going to mean our cerebral perfusion pressure is lower and that we need to increase our blood pressure. The practicalities of that are difficult because blood pressure cuffs are notoriously not reliable and you have to have the right size, etc. And until you get a line into a patient, it could be quite difficult to reliably monitor the blood pressure. But with that in mind, I think it's really important to look at the clinical signs. So good volume radial pulse, nice and warm and well perfused, production of urine, and making sure that there's an emphasis on getting a line in early. And that's normally done in the intensive care environment. And reducing the metabolic demand where able, so that we can reduce the amount of oxygenation and glucose consumption of the cells, and thinking about maintaining a sodium more than 145 to try and reduce cerebral edema, maintaining normal glucose, normal temperature. There's no evidence that therapeutic hypothermia is beneficial for children, so we try and keep low normal, and consideration of anti-epileptics to try and address subclinical seizures, which increase the metabolic demand of the brain cells. And that's something that can be discussed with the neurosurgeons. So practically, how do we do that? That's a long list to do, often with a small team in a very busy environment. So I think the practicalities of that are, think of early intubation. If you've got the patient intubated safely, you can manage their oxygenation, their CO2, you can get lines in for blood pressure, you reduce their metabolic demand. So that's a huge step in managing to target several of those objectives. Thinking about the blood pressure, as we said before, once that line's in and you can monitor a blood pressure, you're in a much better position. But up until that point, making sure that you're mindfully trying to keep their cuff pressure normal or higher. And thinking about considering hypertonic saline. And as I said, once you've got that gas, you'll have glucose, which you can look at, and a sodium. And we really want to keep children's sodiums above 145 if they're thinking they've got a significant head injury, to try and minimise cerebral edema. And we can do that with a bolus, normally 3 mL per kilo of 2.7% hypertonic saline. And then there's the question about tranexamic acid in the context of trauma, or if the patient's had a bleed and you can see that there's free blood on their scan. So as I was talking about earlier, it can be quite difficult to get research in paediatrics, let alone paediatric emergency medicine. And a lot of what we do is extrapolated from the adult population. And there have been some studies looking at TXA in isolated head injuries. There was the CRASH-3 study, which was an adult study, and that looked at mortality. And the outcomes of that study was that there was no improvement in 28-day mortality for for adults having TXA. However, there was a significant improvement in those with a mild to moderate head injury, and those are people with a GCS of 9 or above. It was also found that there was no harm caused to those that received the TXA. So in summary, the TXA resulted in better outcomes in those with mild to moderate and didn't cause any harm. There was the PATCH study, which was also in the adult population, and that didn't just look at mortality, that looked at the life, a quality life score. And the findings were that although mortality was improved with the use of TXA, there was no significant improvement in quality of life. And some pediatric studies. So PEDTRACS was a study in the military environment, and this study gave TXA to those with significant injuries, and the outcome was that children who had TXA had better outcomes, even though they were the cohort of patients that had the more significant injuries initially, and there was no harm identified in that patient group. And finally, MATIC, which was a prospective observational study looking at TXA in children with life-threatening bleeding, and their outcomes were better than the treatment group as well. So the consensus is that TXA is not harmful, and although we haven't answered the specific question about whether it can be used in the paediatric population for isolated head injuries, we do use it. And I've put the QR code here for a really nice article reviewing that exact question. So in summary, I think it's really important to think about how you manage these patients in terms of management priority and thinking about what's in your toolbox. So a lot of things are very apparent, that maybe a patient's going to need to go through a scanner, maybe we need to cover them with antibiotics because we think they've maybe got signs of meningoencephalitis. But always think of the other things that we've got in our toolbox which may be useful. Does this patient warrant antivirals? We've given TXA, but do we want to think about giving anti-epileptics? Is that a conversation we need to have? And I often find in stressful situations, it can be useful just to have a think, what's in my toolbox? Is there anything else that maybe I should be considering? And finally, a little bit on pediatric emergency medicine research. So I mentioned earlier that there's been some advancement in study designs recently. And we have PERUKI in the UK, which is the Pediatric Emergency Research in the UK and Ireland group. And they've set about prioritising top future pediatric trials, which we think will be the most useful as an addition. And one of the studies that came out of a previous prioritisation task was the ECLIPSE study, which I've put a link to here. Now, the ECLIPSE looked at second-line treatment in status epilepticus. Previously, we used phenytoin, and ECLIPSE was the first study to use deferred consent. So children were randomised to 2 different agents, and they were consented to the study post-randomisation. And it was a study that identified that there was non-inferiority when using Keppra, which is levetiracetam, instead of phenytoin. And at the time that we were doing ECLIPSE in the UK, so PERUKI were doing the ECLIPSE study, PREDICT, which is the Australasian PEM research group, were doing a very similar study called CONCEPT, and their findings were very similar as well. So the outcome of this kind of advancement in the knowledge base was that our APLS algorithm, which I've cut and pasted on the right there, has been updated and changed, and that the second line agent is now Keppra. So I guess the point I was trying to raise there is that as things develop, as PEM becomes a more advanced speciality in terms of its age, I think we'll see more research, and that will guide us to make sure that we're doing the right thing for the paediatric population, and we'll use less data which is extrapolated from the adult population. So these are my references. And I just wanted to finish with a picture of the team here in Cardiff, and just to highlight, it's so important when working in a high acuity environment to look after yourself and look after your team, be supportive, and don't underestimate the importance of working with a good team. It's definitely a huge benefit. Very happy to answer any questions if you have any. Thank you very much.
So after a series of official speakers coming and giving presentations, now we are thrilled to sit down and have a panel discussion. So our topic of discussion today is advancing pediatric toxicology expertise, which is intended in developing healthcare capacity to combat poisonings children across Asia. So this session gathers Merck Foundation alumni from different countries who are working either in emergency, usually with children, to talk about the topic we have just discussed. Each presenter will get about 2, maximum 5 minutes. So I would like to then call on the up here on the seats, Dr. Lorraine Njother. Dr. Lorraine Njother is a senior specialist pediatric and also the head of department, and she works at the Pediatric and Child Health under the Ministry of Health and Social Namibia. Dr. Njother, you are welcome. I would also like to call upon Dr. Puniam Subrian Kulan, who's an emergency physician at the AG Jito Hospital under the Ministry of Health and Wellness, Mauritius. After that, I'm calling on a doctor friend of mine, Dr. Maj Naina Angela Pakulan. You are welcome, doctor. She is head of department and emergency room consultant at St. Matthews Medical Hospital in the Philippines. We have up next is Dr. Emmanuel Steve Blankson, who's an emergency physician under Ghana Health Services in Ghana. You're welcome, sir. This one is my commander in arms during medical fights when we are trying to improve what we have learned with the sponsorship of Merck Foundation in our countries, is Dr. Modubela Jallo. He is a research clinician at the Medical Research Council Unit, all the way from the Gambia. You are welcome, Dr. Jallo. Second last panelist will be Dr. Eileen Kamilembe Barongo. As a consultant pediatrician with the Ministry of Health from Tanzania. Dr. Barongo. Okay, Dr. Barongo will be joining us soon. And the last panelist is Dr. Awanshiri Kimonia B, medical doctor from Cameroon Baptist Convention Health Services. As you've heard, she is from Cameroon. Okay, we'll just for Dr. Barongo to get here. Ladies and gentlemen, without further ado, we are starting our panel discussion. As we have said, this is a discussion on toxicology and how we can combat child poisoning in Africa and Asia. As we all know, child poisoning is quite common amongst us, very difficult to diagnose. And these specialists here in the field are going to help us on how to pick up this. It hails all the way from snake bites, organophosphate poisoning, alcohol ingestion, and the more that we'll discuss. So my first question will go to Dr. Lorenzo there. What can you say are the most common types of poisoning affecting children in Africa? You can even give us an overview of Namibia.
Hi, good afternoon. I guess I'll go for an overview of what we see in our setting. Mostly what we see in our setting is based on the usual toddler, their mouthing behavior and what they put in their mouth. And as you know, in our setting, we have pharmaceuticals, like when you give adult medication, it comes in the form that is a pill form. They don't get the container that is supposed to be child protective. They get a pill count. So what happens is the parents walk around and run around with this type of pill counts in their wallets, in their purses or wherever in the house. And then you have your usual toddlers moving about, and sometimes it's from behavior, from seeing the mother taking the pills. Like the one time we had a 4-year-old who took 2 carbamazepine, which was 500 milligram tablet. For the weight, it was obviously an overdose. And that came from, she felt that she had pain in the throat. And then she see her mother taking white tablets for pain in the throat, for any pain. So she just assumed, I can take any 2 tablets. And she took 2 of carbamazepine, and unfortunately was out for 2 days in an ICU because 500 plus 500, there's 1,000 milligram divided by the weight. In pediatric, is always by the weight. Yeah, so that came to an overdose. And then the other common thing is genuinely just mistakes by the parents. And what would happen is, like, a mother will feel like, my 5-month-old has a fever. And traditionally how they treat the fever, they will take an aspirin and they put it up the bum. And unfortunately, at times the person will take a 500 milligram tablet of aspirin and put it up the bum. If you take the weight of a 5-month-old, will probably be 4 kilograms, and it's an overdose. If you divide 500 by the weight, it's an overdose. So that's the one type of, and we see that quite frequently, because putting aspirin up the bum to bring down a fever is a common occurrence. It's something that they do commonly. And then the other one that we find is there's a traditional brew, Ombike. If I can find the brewer of Ombike, Ombike contains 70% of alcohol. So these little buggers will see this clear fluid in a bottle. They are thirsty, they drink it. And they come with sugars of 0.1, 0.2, completely knocked out. And yeah, and some of them will present with convulsion. 2 weeks ago, we had one of them, I think it was a 5-year-old, demised because of taking in the obike. So it's a type of traditional brew of alcohol. So what happened is the child drank the obike, he became sleepy, he went to sleep. Nobody knew that this child took this. And in the end, it ended up being they found the child in the morning convulsing. So by then the sugar, it was maybe many hours later, more than 12 hours later, the sugars have dropped to 0. So this child was now convulsing of hypoglycemia. And then the biggest issue we have is the vast distances in the country. This was like about 6 hours away from us. And to get the child to us, to our emergency, to our ICU, also took a while, because the pre-hospital care by us is also not the best. So unfortunately, that one demised upon arrival to us because of the alcohol intake. And then you get your organophosphates that comes in pesticides. In our country, they don't say they are using the pesticide, they are not supposed to use it, but then the children present with a toxidrome of organophosphates. So those are mostly the biggest issues that we have. And most of the time, the 2-year-old cannot tell you that I have drank what. They come to you unconscious. So it's the high index of suspicion that will help you. It's picking up the vital signs. And it's always keeping in mind what could be the cause, and then obviously adding the clinical signs. And based on the toxidromes, toxidromes are the syndromes of the different toxicology effect. I think at that point I can.
Okay. Thank you very much, Dr. Njothe. If I can pick something up, you said it's medication poisoning, it's organophosphates, then obviously the alcohol. And most of the time it's a result of negligence from us as the parents. Dr. Angela, I would like to ask, what is the most common poisoning in Asia?
Okay, I can only speak for the Philippines, but but based on research, because I've already found some details, we have a lot of studies coming from Malaysia. That's dated in 2022. And we also have a lot of study from the Philippines, basically in Luzon, in Baguio Hospital. So let me go to Malaysia and then I'll go to the Philippines. In Malaysia, pesticides poisoning are most common. And it's because of improper labeling and storage and disposal. And then the next would be anticoagulant rodenticides, rodents, and then food poisoning, and then bites from and venomations, snake bites. Okay, so that covers it for Malaysia, but they have a lot of studies, and mostly it's because of those. And then in the Philippines, so in the Philippines, we have 3 major masses of lands. So the first would be Luzon, Visayas, and Mindanao. Luzon and Mindanao, there are large, huge masses of land, but in Visayas, these are smaller islands. And these islands, you can drive about 2, 3, 4, 5 kilometers away and you're near the sea, and you can actually bathe in those seas. So as you can see, there will be a lot of sea creatures that can be venomous, can be poisonous to some. So it's different in Visayas. But in Luzon, where there's a mass of land, we have cities where poisoning that's common would be neglect from medications. And then we also have organophosphates poisoning and contaminated food from refrigeration, loss of electricity, and the food will stay in the refrigerator and they would stay there for a long time. And the children, because it's accessible, they can easily open it. They will just eat what's in the refrigerator without you knowing them. And then the next would be, well, if you go to Baguio, and some of you have gone to Baguio, Baguio is a mountainous place. We have lots of trees there. There has been a recent study, well, not so recent, it's 5 years old, wherein they found a group of students from Baguio University that have been ingesting shrubs. So they call it the Jatropha poisoning. It's a shrub and it actually tastes good because I tasted one when I was little. And I didn't think, I was just trying to research on it and I saw that, oh, I know this. This was in my backyard and it's a small fruit. It's like a beans. It's like a bean. And then you eat the fruit. It tastes good. It tastes good.
Okay.
So these shrubs, they're actually ingested by kids who play by the road and they don't know better. And even maybe, I don't know, the 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 officials in our government, the healthcare workers, they didn't even know until this research came out. So you
Okay.
can eat a lot of things, berries that seem to be safe because you don't have an immediate reaction to it. What happens is they came in, a group of children would come in with abdominal pain and diarrhea. Well, I think what's lucky is in our healthcare system, there will be small clinics manned by our midwives and some nurses, and those lucky areas with doctors, they would be able to give hydration supplements and just observation.
Okay.
So
Okay, Dr. Angela. You had 2 minutes to talk
I'm
about
sorry.
this common, poisonings in children. I thank you though, because what I could gather is that you have the organophosphates, but mostly you have these toxins from plants. And it all boils down still, an area of a bit of negligence from our side. I could be wrong, but this is what I'm picking up from what we are saying right now. Dr. Lorraine, you have spoken about a child who had taken Ombike at one point and nobody knew that this child has taken Ombike, and that is because the symptoms usually are not direct forward and saying, if this person has this or that, then they probably took this. May you please then do us the pleasure of just explaining to us what are the most likely symptoms. We all come from low to middle income countries here. So in most cases, we don't have what should be at our disposal for diagnosis of this poisonings. So what can I, in a low economic setting, use to have high suspicion in the back of my mind that this is probably poisoning?
Oh, I thought the panel is a bit long and the questions will go before they come back to me.
They
but
will
yeah.
get their affections.
But anyways, so like I said, it's a high index of suspicion because half the times the parents don't know what the child have taken or whether the child have ingested anything. And it's not mostly because of negligence. It's running after a toddler and having 3 or 4 under 5 years at the same time. So you can hardly keep track of them. But basically, like I said, it's a high index of suspicion, a good history, and in trying to be a detective to try and find out what is in the household that this child could have taken. And when it comes to the medication, is usually tricyclic antidepressant and the salicylates, paracetamols, and also your beta blockers that we give freely to the adults to treat their condition. These are the things that the kids will end up taking. And Ombike is alcohol. It's a 70% alcohol solution. And in children, it causes hypoglycemia. So, and then the hypoglycemia will either lead to convulsion or depressed level of consciousness. So they had a convulsion, they had a depressed level of consciousness. So with your investigative skills and trying to find out, and we don't have a toxicology panel. And even if we had laboratory that can do toxicology for us, the results are never on time. You will get your choline esterase results 2-3 weeks after the child have come and gone. And that is the classical thing that we have. I don't know whether it's the same in other countries, but in Namibia, yeah, it's what we get. So what we usually do is you examine the patient, you look at the vitals. Is my heart rate racing? Do I have depressed level of consciousness? Do I have depressed respiratory? is there a possibility that this can be an opiate? So depending on the syndrome or the constellation of symptoms that the child present and what you are picking up clinically, based on that, you start treatment. And most of the time is supportive treatment, airway. Can the child breathe for themselves? Do I need to support the airways? Are they oxygenated?
Okay,
Yes.
Dr. Lorraine. Dr. Lorraine, you were supposed to go as far as, helping us diagnose. Thank you very much, because you have blessed us with some management tips already. No, Dr. Angela, don't give the mic yet. We are not done. You have spoken, Dr. Angela, about this accidental medical ingestion, like medication ingestion. You're speaking about natural occurring trees and herbs and toxins from that. You have said how often it is, but would you like to elaborate more, like on the role that natural toxins have, or play in pediatric toxins, like in these regions, a little bit more?
Okay, like in our village, there are about 20 children living who are not going to school yet. So they play around, and last year, I think they were 5 to 7 years old. So last year they were just playing around the village, and then we've noticed that there were 6 of them who have been reported to go to St. Matthew's Hospital where I work. So of course I had to investigate, and I found out that these 6 children were playmates. And when we went to investigate, they were playing in the field, in the playground, and there are fruit-bearing trees. There were fruit-bearing trees, but these are not edible fruits. So these are like berries. So they had gastrointestinal symptoms. So that is how we diagnose these children. We look for symptoms, usually clumps. They come in group. So we look at these children who are having diarrhea or have been absent from school, and we trace back where they've been. For example, after this long holiday, because October 31 to November 1, we don't have schools. We don't have classes in the Philippines because of Halloween. And then naturally there will be children playing. So during these times, November 2, we look for children who are absent, and we try to trace back what happened. So that's how.
Okay, thank you very much, Dr. Angela. I do not want Dr. Lorraine to strangle me. I'm just sitting closer to her. But Dr. Lorraine, I have one last question for you. Okay, what are the strategies that can be implemented, to improve access to antidotes, okay, and other essential treatments for poisoning in children, especially in our low economic settings?
Well, if we're in charge of budgetary processes in our Ministry of Health, things will go better, but unfortunately we are not. So prevention is the best thing to do, and prevention goes with teaching, having campaigns, running campaigns, like especially when you find that the drinking of the ingestion of paraffin goes hand in hand, that this child was actually just thirsty, and it is a clear liquid bottle. So parents tend to store these things in Coke bottles. So when you have stored something in a Coke bottle that's not for consumption, it should not be kept where the child have access to it. So the child shouldn't be able to have access to it. And I understand that we do pill counts, and we don't give the whole container that is child protective to the mother to take home as a medication. So then the mother need to be educated. They must be stored somewhere where it's out of reach of the child. So we do a lot of campaign, and then we try to teach them how to storage all these things, the carbon, even the carbons that you can lock, the discharge lock that they can't open. Yeah, and then if it's 3 stories, to be on higher shelf. So most of the time it's education and campaign. And if it does happen, what to do as a parent at home.
Thank you very much, Dr. Lorraine. What you have said brought something into my mind. Imagine you in your own kitchen, eh? You have all this tinned food and you remove the labels and you put them up there. When it's time to cook, would you know exactly what is in that container? This is exactly what we do when we store, for example, paraffin in a Coke bottle. The child does not know that this is not water. It's a clear liquid. It definitely must be water. And they don't take sips, they take gulps. And by the time they are done gulping, most of that poison has gone into the body. What Dr. Lorraine is saying, prevention is better than cure. So let us take a little bit of caution in what we have around the children. Let's put it up there. Let's label it. Let's teach them this is not right. If it smells like this, it's not supposed to be. So thank you very much, Dr. Lorraine. I'll be now giving Dr. Punyam a chance. And I just want to know, Doctor, what roles can schools and local community leaders play in ensuring that the families are educated in preventing these accidental poisonings in children?
As you all know, the most common place where poisoning occurs is at home, very often without the presence of parents. And the most common is the primary cause is accidental poisoning. So the best place to educate will be school, and not only the children, but together with the parents. Like when you do annual meetings, you can call together the parents and the children. For the children, the main thing will be to explain to them the dangers of eating something unknown or inhaling something unknown, and to ask the parent every time before taking something they don't know. And for the parents, have to educate them to store the medication in proper containers, to avoid using attractive packaging to put the tablets, like, you know, in sweets package or in candies, to put it in proper package, labeled it properly. And then we have now many chronic treatment going on, like oral hypoglycemic. So all this must be stored properly. And for local community leaders, we can do campaigns using TVs or newspapers. We can create slogans, like I have one in mind, like keep it up out of sight, keep it locked up tight, out of reach when not around, to avoid hospital all around. So it's something that's going to stick to your mind. So I find it quite important, so to avoid poisoning. So slogans like this can be created on newspapers, on TVs, and then local community leaders can also do some make out some policies or laws to avoid attractive packaging. That also can be done on their level also. So both children, parents, and community leaders, they all can help together to avoid poisoning.
Okay. What you said was sort of rapping, you know, the slogans. So after this, please write it on our group, so we remember it again. But that was beautiful. Before you give away your mic, please let us know. A lot of people say children are young adults, which is very wrong. So what are the differences in clinical presentations of how poisoning occurs or presents itself with children, and what are the difference compared to adults?
So like you rightly said, children, they do respond differently to poisoning compared to adults. And this is not only limited to their comparatively smaller size. There are myriad differences in the physiology, the anatomy of children. So do not just think about size. For example, for the skin, like children, they have a higher body surface area to weight ratio. So there's increased absorption. They have increased skin perfusion. So again, increased absorption of toxin. So all these two factors can lead to an increased susceptibility to poisoning. And hence we have to take that into consideration. And for the respiration, like children, they have a higher respiratory rate, they have a higher minute ventilation. So by these two physiological change, they're going to inhale more toxin, like for example, carbon dioxide. So they're going to be more prone to poisoning. So they're going to come into a worse state. And then the cardiovascular. So for children, like you know, our cardiac output depends mainly on I mean, not mine, but children, cardiac output depends on the heart rate. So when you have ingested a very toxin, then there is an increased adrenergic drive to compensate for the BP. But then this is a deceptive BP. So children, they can come with a normal BP, but with a tachycardia as the only sign which will tell you that there's impending shock. So this is also very different from adults. And then you have children has a lesser glycogen storage, so they are more prone to hypoglycemia. We have and then when a child is born and as they grow up, there is the maturation of our neurotransmitter receptors and our channels. So they don't react the same as adults to like opioid antagonists. So they are going to have increased toxicity to opioid agonists compared to adults. So that's the main differences. So you have to be aware that then there's another one. Since the children they're more prone to hypoxia, so they're going to have increased risk of respiratory failure. So they're not going to able to respond to the acid-base disbalances. So they can come more in acidotic features compared to adults also.
Thank you very much, Dr. Punian. You can't know how to manage a condition if you really do not understand the pathophysiology behind the development of this, disease. It helps you in what to do to diagnose. It helps you in the management. That's why we are discussing this. Dr. Emmanuel, point of care diagnostics. How can point of care diagnostics help us with early detection of poisoning in pediatric patients?
So that's a difficult one. So by definition, when we talk about point of care tests, I mean, as emergency physician, we use it a lot. We are talking about tests that you can do at the bedside. You can get a result easily all at the bedside. So for example, random blood sugar, urinary pregnancy test, urine dipsticks, and all that. So as of now, there are just some few ones. I think in the US, they have some bedside tests for detecting lead poisoning, but that one usually takes time. So the common toxidrome that we have, or the toxins, we usually do not have anything like a point of care test for you to know the exact toxin you are dealing with. Indeed, in toxicology, the main focus is not rushing to, give antidotes. The main thing is to start with decontamination and do your ABC. That's a primary survey assessment. That's the principal thing. And that's what will keep the person alive. However, the point of care diagnosis test could help in the supportive care. For example, my other colleagues have elaborated on the fact that a lot of the kids have low glycogen stores. So some of them may come in with hypoglycemia. So just doing the RBS will not tell you which particular medicine or toxin that has been ingested, but you could correct that one. And at times, it's not even the drug itself that's going to kill the child, but these other complications. So you can do that one to do it. If it's something like a TCA, that the mother was taking and then she also took it. An ECG will show you a YQRS complex, and then you can have an idea. If you are thinking of carbon monoxide poisoning, we have a bedside one that you can do, the iStat machine. It's like a quick ABG. So you can use it. It will help you to know. Some of them are able to measure the hemoglobin level. So if it's above maybe 10% and the person is not a smoker, you can have, an idea. So these are some of the things that you can do on the bedside. It will help you in terms of we call it primary survey adjunct, things that you can easily do. Then a new one that is on the block is the bedside ultrasound, cardiopulmonary ultrasound. So that's the POCUS. So you can do it. It will help you a lot in kids or any patient that come in with undifferentiated shock, or people who come in with dyspnea with unknown etiology. So you can easily scan the lung, have an idea of what is going on, like the way they said that the shock may present with tachycardia. It may also be due to pain. It could be due to any other thing. But the bedside ultrasound could actually help you to know, you can measure the IVC and all that, and you'll be able to know the volume status of the patient, and it will guide your resuscitation. So their place is mainly in terms of they supporting you in what you are doing. But by and large, when you are talking about poisoning in kids, it's clinical. And that's the main thing that you should focus on.
Okay. Thank you very much, Dr. Emmanuel. Africa is going large and has been going large on agricultural products. But we have one problem, and that is pest and use of pesticides. And now it's organophosphate poisoning. What are your standard treatment protocols for pediatric patients when it comes to organophosphate poisoning?
All right. So, well, so the organophosphate poisoning is, I think they've said it's common in our country too. So I wanted to highlight something. In addition to the fact that maybe at times children may be left on their own and then they have the poisoning, which forms a majority of the cases, we are seeing increasingly some other children, usually the grown-up kids, who come in with intentional poison. That's attempted suicide. So usually the adolescent children are coming in with that one, and we shouldn't miss the fact that that also presents. So coming back to the organophosphate poisoning, the management is similar for both adults and kids because basically that inhibits acetylcholinesterase. So you are presenting with enhanced cholinergic activity. So I think the textbook presentation is the dumbbells, the diarrhea, urination, and all those things. And when you have something like that, as we said, the main thing is decontamination, because it's something that is very volatile. So it can be absorbed through the skin, they can take it, whatever. So if the person comes, you have to remove the clothes, because it may be that maybe they vomited all those ones. So you have to make sure you clean and dry the person up. Then you can do your standard ABC. If the person is symptomatic, showing all those signs that we are talking about, the dumbbells and all those things, then there will be an indication for you to start the antidote. We usually use atropine. And usually in that instance, you have to give very high doses of the atropine, not the one that we usually use in treatment of the bradycardias, because that's the main thing. Atropine competitively antagonizes the acetylcholine and displaces it. A lot of the time, there has been a talk about pralidoxime. They come in early enough in some few hours. In that instance, if you give it early, theoretically, it is being postulated that it can reverse the whole activity of the organophosphate. However, some studies have cast doubt about the actual role of the pralidoxime. So it's still something of contention. So the main thing is the supportive care, decontamination, supportive care, and then you give your atropine. And as you are giving it, you are monitoring the patient. And the key endpoint for you to know whether you've actually achieved treatment is not when the pinpoint eyes resolved, but when the lungs are dry. So when the chest is dry, the bronchuria is corrected, bradycardia is improved, and the BP is also improved, then you do it. But by and large, the respiratory complication is the main thing, because they usually die from that one, the bronchuria. They actually call them the killer bees, the bronchuria, bronchospasm, and the bradycardia.
Okay, thank you so much, Dr. Emmanuel. You're basically just giving so much strength to what Dr. Punyam has said. She said respiratory failure is number one. It's very dangerous in these children. So we really need to watch for that. Dr. Eileen, Dr. Emmanuel said something about decontamination. What is the role of gastric decontamination, like gastric lavage, charcoal, activated charcoal in children with poisoning?
Thank you very much for your question. In pediatric, actually, we don't do that one. We don't do gastric decontamination. This is because these kids are at higher risk of getting aspiration. There are two types. There are activated charcoal and the gastric lavage. but with the activated charcoal, is selected. It works in some toxins and it does not work in some toxins. In my country, the common cause is always kerosene. Kerosene ingestion is very common. So most of these kids, when they came, we do treat them empirically, symptomatically. But to parents, when they saw their kids just swallowed the kerosene, they gave milk. That's the way they are using to the decontamination. So these kids always vomit. And once they vomit, now they came with the signs of aspiration. So we admit these patients always for 24 hours. We observe for any severe symptoms, but most of them present with difficulty in breathing and desaturation. So we kept them on oxygen 24, 48 hours, then we discharge. With gastric lavage, that one is not working at all. So when you talk of toxins in pediatrics in my country, that one is more common. When you talk about medication now, it's all about what you were told us about your kid. You saw her choking, then you start thinking what went wrong. So with the medication, when symptoms start, it will be about 2-3 hours after. Now that parents will start think what could have been the cause. And when you receive that patient at the hospital, when you ask the mother about all these things, no any information. So you have to treat that patient symptomatically. What you saw there, then you treat. Otherwise, no problem. And the other thing we have herbal intoxication. The other day I talk about herbal intoxication. These mothers, they are not open. They don't want to talk if they give their children anything about these toxins. So they might brought the child unconscious. When you put in your nasogastric tube, then you saw something coming out. When you ask them, there is where they might say yes, or they might say no. Now, you don't know what type of medication was given. Now you start manage what you see. You find are the kidneys okay? Are the respiratory rate, are the heart, whatever, you manage it in that way. So that's what we have.
Okay, thank you very much. I think, should you not have clarified this, I would have given somebody milk, because that's the belief that we grew up with, that milk counteracts everything. So instead of, now you've created two problems. You have the one of poisoning, and now you have chemical pneumonitis that is developing. Thank you very much. Dr. Awanshiri, you are a proud Merck Foundation alumni. I'm sure you can tell us how the Merck Foundation training has helped improve healthcare systems' ability to respond effectively to pediatric poisoning emergencies, especially in our low-income countries.
Thank you so much. Yes, I did the emergency and resuscitation medicine course from Queen Mary University of London, and it was very eye-opening, all the things that I learned. One of the very interesting topics for me was the toxicology module. And during this module, I learned a lot of stuff, including one of the things that spoke to me specifically was the use of of tox base in the UK. So it's like it's a database of the common possible toxins and poisons and their toxicology profile, and probably the dose at which if ingested, we should be very careful already, and how to manage them. So when I was doing more research about it, I realized that there was actually also an AfriTox, but that one is based in South Africa. And you can only use it for free if you're in South Africa, but outside that, not really. So that's something that we can also all look into for our different institutions. But pediatric toxicology is also a field in my country that is not well developed yet. And like the other speakers have mentioned, given the cost of other things like the antidotes and all of that, even though they're not the first things that we look at, for me, my area of impact has been with education. So I'm part of the Emergency Critical Care Network in Cameroon, and we hold training sessions. And during these training sessions, I've been involved with educating on primary survey, the ABCD approach. And during our trainings, we usually train multidisciplinary teams like doctors, nurses, paramedics together so that we also learn how to work in teams. And during these trainings, we have successfully trained over 200 people so far from different institutions, both the public and the private sector. And during these trainings, we really, really like to lay emphasis on the ABCD approach because like the other speakers have mentioned, especially in pediatric toxicology, it's difficult to really find out what was ingested and if it was even poison. So you need to have a high index of suspicion. And you can have that when you're doing your ABCD assessment, especially let's say for disability, if the patient is unconscious, has a low level of consciousness, especially, we have to have a high index of suspicion. And the other thing that we educate, even in that, is like taking that brief history when you have a high index of suspicion is also very important. For example, you need to really find out, if you don't ask over and over again about where this child was the hours following presentation at the hospital, you may never get the information because if they were away at the neighbor's house, you know how the children are, sometimes they are just away. So when we train how to, collect, how to take targeted history in a situation where you're suspecting poisoning, it also helps. And besides the training, I've also been involved in protocol development in our institution, which is a Cameroon Baptist Convention Health Services. It's a network of several hospitals. So a group of people at the ECCN, together with the authority at our network of hospitals, they decided to come up with a 6-month crash course for emergency room nurses. Because in my setting, and I'm sure in other low and middle income countries, the emergency rooms are mostly manned by general doctors and nurses without any formal training in emergency medicine. So for Cameroon, recently we have emergency medicine residency. We are blessed with that, and they're taking 4 people every year. But then it will take a lot of time before you actually have emergency medicine physicians manning the emergency rooms, right? So we have general doctors, and emergency room nurses who are always the first contact. So the curriculum development involved, toxicology, identification, and management as well. Yeah.
Okay.
Thank you.
Thank you very much. You've spoken about education and you've spoken about in-service training, and that means, refresher courses every now and then because medicine is evolving. So we gotta deal with what is the current status quo. Please help me hand over the mic to your neighbor right there so she can give me. Yes, Dr. Ponian. May you please also just elaborate on how this training has helped, shape or improve the management of pediatric poisoning in our low-income setting countries?
For me, in Mauritius is a small developing country in the Indian Ocean. There we have emergency physicians and pediatricians. There is no pediatric emergency medicine. So I'm the first one with the help of Merck Foundation, definitely. So I was able to follow this course. And just by looking at the statistics in my country, like in 2021, the mortality rate due to poisoning and injury was 3.5 and has increased to 3.9% in 2022. So just by the statistics, there's an increase incidence of poisoning. So by doing this course, I was able to manage the medical pediatric emergencies, especially poisoning, because the PEM, the Pediatric Emergency Medicine course, has equipped me with knowledge and confidence to deal with this type of emergencies. Like last week, I got 2 cases of poisoning. One was with pyrethroid, synthetic pyrethroid. It is a pesticide, sapermethrin. It was 1-year-old with who ingested it by accident. And second one was again 1 year with diclofenac, which is NSAIDs, and the parent didn't label it, so they inserted supposedly 100 milligram into the child. So by the aid of this course, I was able to tackle my emergencies better. And then, like she said rightly, toxidromes, they help us to identify the medication. So all this was learned by the help of the course, and definitely with that additional training of our staff and sharing of the knowledge with my colleagues, this all has helped us to improve our health system.
I just want us to give it a round of applause to Merck Foundation. We can see how much impact they have done in our communities and what more they continue to do for us. I want you to please give it over to Dr. Eileen. Dr. Eileen, how can we promote public awareness and prevention strategies to reduce the risk of poisoning in children?
Now, I guess I will give experience from my facility. What we are doing now, at the OPD first, we have speakers which are giving educations about non-communicable, about communicable, but on top of that, we have added this topic about how you can store your medication. So it's a continuous talk at the OPD, but also at the pediatric clinic and at the antenatal clinic. The other strategy which we have used is we are doing outreaches. We go to different lower level facilities, into which one of our strategies is also to educate healthcare workers how to educate first their patients, but also when we are trying to manage those patients, we are giving them education about this toxicity and how should they store those chemicals, how should they store the medications. And the other thing, we have something called the AFYA check in quarterly basis. We have it in our hospital. So each department have to prepare a number of doctors and nurses to provide service to the community. So we announce in the community, and when they came for checkup and whatever, there are a section dealing with this poisoning and the safety of the children.
Okay, I guess that means creating awareness then helps improve empowerment, isn't it? I would like to ask Dr. Jalo Motubella. What role does telemedication and remote learning has to do or has to play in educating, especially for preventing pediatric poisoning in our settings?
Thank you very much, Chelma. I think just to kind of wrap up the discussion here, when it comes to telemedicine and the use of using it towards improving the children with poisoning, the partnership is usually built between low-income countries and some high-income countries, or between the private and also public partnership. Because one of the challenges we are faced with the public sector is some of these advanced lab tests are not available. And the private, there are few private entities within countries, depending on how developed the country is, they could be able to help. One typical scenario I will add to this is using my country as an example. There was an outbreak of children dying from AKI, and we couldn't know what was the problem. On the whole, it was related with one syrup, cough syrup, that was killing most of the children. We didn't have the facilities to take care of, to kind of know which of the syrup were causing the problem. But it was sent abroad, and then we realized that there was one of them that was particularly contaminated. Because of that, there was a complete withdrawal of it. So as a low-income country, we couldn't rely on any resources because they were not existing, or the ones that were existing were very minimal. So in such cases, you could use the telemedicine to first train the people, as most of us are doctors, but if you are not trained in toxicology and these facilities are not available, what tools do you have? The only thing that you can rely on is expertise in another part of the world trying to teach you through telemedicine. And on top of that, also, we also have to kind of upgrade the facilities that are within the country. The people that are working, from the discussion, you can realize most of the poisoning drug-related issues. So the people that are working in pharmacovigilance, the policies and all this, and they also need to be educated, by experts, so that they know that these are the things that could be used to prevent poisoning. We say pediatric poisoning, but indirectly it is the adult that are responsible. You never see a medicine that would say keep out of reach for adults. You see here children. The reason is the adults are responsible. So if if a child plays around and handles medication, it's because the one responsible for that medication didn't do their job. And to improve this, telemedicine can also help. You are in the rural area, somebody's in the urban area. You have this communication link between the rural hospitals and the main hospital, let's say the teaching hospital in the biggest one. We have regular quarterly, reviews of what are some of the things that we've improved on, the things that we could also, step up and continue maintaining. Because sometimes we can start things, but then what happens is just a one-off, and then the whole thing will just roll back. We start from scratch again.
Okay, thank you very much, Dr. Madubela. You said something that is very, very important. You said collaboration. And I'll tell you now, the reason why these events happen, these conferences happen, is to meet, to greet, to collaborate, to form partnerships. We are all from different countries. What you're doing in your country is not what we do in our country. So if anyone comes to those meetings and they leave without made a friend, you have wasted an opportunity, not only for you yourself, but you have also let the country down, because you don't know what the next person could do for your country and what you can also do for their country. So, Dr. Wanchiri, are there any cost-effective technologies or innovations that can be used in detecting or managing poisoning in children?
I think detecting and managing poison in children, like we've already discussed here, like everybody else has discussed, has mostly been around cost-effective things, because like we mentioned, antidotes are not often used, right? So most of the things we are doing are cost-effective, but then I think that for us to get there, we need to be able to know what we are supposed to be doing, those basic things. So, okay, before the basics, even he just spoke about telemedicine, which is something that we can really use, because we all have phones. Many people, even the people who earn below minimum wage, do have smartphones, and they can access or report anything that needs to be reported. So in telemedicine, I think collecting data, first of all, and then maybe coming up with these databases for toxicology, the toxidromes and the common things, because it's really difficult sometimes to know which particular medication, except the ones that are well known, like iron toxicity in children. That one is that, okay, this, but then there's a wide variety of medication. And also you see other things like Dr. Lorraine was talking about, is it Ombicaine? Yeah, Ombicaine. So if we can't collect this data and actually have a database of maybe the presenting signs and what the cause of the disease was in these children, it would be difficult. So collecting the data, coming up with databases would be one great cost-effective way. The other cost-effective way of detecting and managing maybe education, and the education is both ways, both for the community and for the healthcare workers. So educating the community, for example, in Cameroon, where I come from, it requires many stakeholders, right? Because, for example, if you look at pesticide poisoning, the Ministry of Agriculture in my country is doing its part by trying to regulate the pesticides that come into the country. But then, of course, that will have its own limitations, but they're doing their own part. Now, the people in the community, what's their own part? People are actually more aware now about pesticide poisoning. But then, and they keep these pesticides away from children. But now people recycle the containers that they're using to store the pesticides. They'll recycle and store food or store water, and it's still an exposure for the children. So more awareness needs to be raised. Also awareness about early presentation, because sometimes people don't know that just being exposed to something topically over a prolonged period of time can lead to toxicity. So they would present late or not even imagine that it could be that, and they will not report it. So if we educated the community more, they can maybe report these things more, and we'll stop, testing other things before actually getting to the meat of it. Now, educating healthcare workers, like I already earlier mentioned, is also key, especially in areas where there are emergency medicine physicians who already know what they should be doing. They've learned about toxicology and the toxidromes and everything. But nurses without formal training and general doctors without formal training man many of these emergency rooms. So yes, educating them about toxidromes. There's also the African Federation of Emergency Medicine Handbook on acute and emergency care. There's a chapter on toxicology, which is just a handbook with like 1 or 2 pages on quick assessment and management of certain conditions. And this and the way it's, because the African Federation Emergency Medicine book, it's more applicable to our setting. Yeah, I think, yeah.
Thank you so much. Education is an expensive investment that comes out cheaper in the long run. Yes, so I understand why we speak about education, because knowledge is power. You have said something about them storing, reusing pesticide storages. We have just had a number of 10 people from one of our northern eastern parts of the country. They were admitted after they've made a traditional brew in what they had brewed, in a bucket that they had brewed or mixed pesticides in. So you can only imagine the hazardous actions that people are involved in. You spoke something that is a bit of concern also. You said something that is a bit of concern, especially in our hospitals. And I know a professor from Nigeria said something about it. They have 100-something fertility clinics, and out of those 100-something fertility clinics, only actually 24 of them, if not less, are giving reports on an annual basis. Dr. Jallo, you are a clinical, a research clinician. Are there any research gaps with regards to pediatric poisoning? When it comes to pediatric poisoning, are there any research gaps? If there are, how can we help curb that?
So in general, I would say there is a complete, like a huge gap, both from the data that is already existing and the things that we need to do. To begin with, even us, the health workers, there are things that we could do. Simple KAP studies are some of the things that we could also start, so that we know we try to get a baseline knowledge of some of the health workers. And the other thing is also, we've mentioned patients will come in, we manage them within 2 days or within a day, they are gone. But the data usually, we don't kind of keep it, so that at the end of the day, we can tally all this information and kind of have a descriptive presentation of what is the problem. So it means because we don't have the data, or it is existing, but because we cannot kind of draw a picture from the data, we cannot even put recommendations as to the way forward. So this is one bit. I made mention of our case in our country. So we shouldn't wait for disasters to happen before we start asking questions. In medicine, always, even if we are doing the right thing, we should be asking, what more can we do to make it better? What more can we do to make it more efficient, cheap, accessible, and all that? So these are some of the things that we should be asking ourselves. And we've just mentioned the medical aspect of it, but we didn't mention the poison that are at home. The kerosene is one, but in my country, we also have these people that will make local soaps. And children will ingest these things only to end up having serious esophageal strictures and stuff. So we have a number of cases, but if we are to find out right now how many of them are have been managed before. Either the folders are lost or you won't get the information that you need. So we kind of need to, as he said, kind of keeping up the data, putting it in a database so that we could have a picture that we would say for the past 5 years, for the past 10 years, and we will now step it forward from that. To the last aspect of it also is we should also be having comparative studies, because one part of the country and another part of the country, or one part of the continent may be suffering from this kind of most common poisons, unlike the other part. So with this, we will be able to draw a global picture, or at least Africa, Sub-Saharan Africa, or regional picture of some of the things that could be expected. In the sense that if you have a child presented with poison, you think of the common things first before you start thinking of the very rare things. So I think these are some of the things I believe if we do, we should be able to get some answers and also improve on them. Thank you.
Okay, you can really see as a research clinician giving us this answer. So database is very important in our settings. Not only do they help determine your disease epidemiology, but they also help you create standard operating protocols. And very important, we all hail from low economic or low to middle income countries. Keeping data, when you have a database, then it's like keeping proof. We call it receipts nowadays for you to be able to secure funds. Ladies and gentlemen, I hope you had fun listening to the panelists share their expertise on this topic about pediatric toxicology. And for that, I thank you very much. And we close it off. If there's any question, you are welcome.
Thank you, the panelists. The discussion was very informative. I would like to ask something, and probably you can share your experience from different countries. We are talking about emergency intoxication, but do we have any number of statistical figures showing the intentional intoxication? We understand currently we have nannies who are taking care of our children. So how many numbers do we have in terms of intentionally someone gave a child a poison? Thank you.
Anyone can take this.
Okay, let me try. So it is something that is very sensitive and also critical, because nobody will just come and admit doing a crime. And sometimes they give it out of trying to help, but instead harming. One of the poisons that is very common in my country is traditional medicine. You want to treat the patient, but then the thing you are giving, the dose, you don't know. And sometimes some of these medicines are fermented, they are kept over days. You think you are giving medicine, but actually what you are giving, these herbs, some of them are already turned to poison, about to become alcoholic. You give it to them, then 2 days down the line, they start presenting with liver problems. They will never admit to you that they gave something in the past. You mentioned that when you pass an NG tube, that's when you now see the gastric contents that don't look normal like somebody who is healthy. So all this boils down to, the research which we were speaking about. We don't keep the numbers. And even if you have a high suspicion, high degree of suspicion, at the end of the day, you don't have the facility sometimes to prove which particular toxin was involved. Yep. I don't know if that answers your question.
So in my country, in the Philippines, we have a study of pediatric patients. They're aged 15 to 18 years old. So intentional poisoning, this is based on 2015. In intentional poisoning occurred in 53.9%, and unintentional would be 46%. So these are mostly depressed individuals who, I don't know what happened to them, who turn into drugs to keep themselves happy, I think, or alcohol. And then those below 15 years old, they're more unintentional poisoning. So that's accidental ingestion of water.
Thank you so much, Dr. Lorraine. You want to add quickly before we close?
Okay, so in my country, it's usually the teenager that attention-seeking behavior, and they most commonly make use of insulin injection. Yeah, if they have access to it, they will inject themselves with insulin, and then you find this person coming to you with a sugar of 0, and you're like, you did something. Eventually, they will come out and say that they've done something. Or you will have, like, last week I had a 9-year-old who drank all her anticonvulsant because she realized that she forgotten for a couple of days. And then she was scared that the family is going to shout at her for not taking her medication. So this actually, she didn't intend to harm herself. The intention was to get rid of the tablet. I don't know why she didn't flush it, but yeah, she decided to drink it. Yes, and then she came with poisoning to us.
Okay, ladies and gentlemen, just a round of applause to our panelists once again. I will be retiring and I would like to invite our other moderator, Dr. Hilary.
So welcome to our second and final portion of panel discussion today. I am Dr. Hilary Yuma. I'm an acute medicine trained doctor through the Merck Foundation program. I'm from Liberia, and I'm here as one of your moderators today. So we've had a lot of insightful presentations and lectures, and thanks to all of our panel members and our presenters today, it has been great. And we're about to go to the final section. Today's topic is going to be building capacity for early detection, community and healthcare collaboration in identifying autism spectrum disorder in Africa and Asia. So we're going to call on our panelists moving forward. And first up is Dr. Ridoy Nishal. Dr. Nishal is a pediatrician from the Ministry of Health and Wellness and the Merck Foundation alumnus from Mauritius. Welcome, sir. And next up is Dr. Lorraine Njose. She was here earlier, and she's a senior specialist, pediatric head of department and a pediatric and child health, Ministry of Health and Social Welfare, Merck's Foundation alumni from Namibia. Welcome, Doc. Third is Dr. Amida Kalumbola. Dr. Kalumbola is a specialist pediatrician as well. She's a Merck's Foundation alumni from Tanzania. Welcome. And then we'll call on Dr. Jennifer Chrisitoba Damoy, a pediatrician as well from Kisinyi Health Center in Kampala Capital City Authority, Ministry of Health, Merck's Foundation, Uganda. Welcome. We now call on Dr. Matimba Dindi, a consultant pediatrician and a pediatric intensive care unit specialist from Zambia in the Merck's Alumni Foundation. Number 6, we call on Dr. Chasel Iyashaze, and he's also from Zimbabwe and a Merck's Foundation alumna. He's a consultant specialist pediatrician, Ministry of Health. Lastly, we call on Dr. Imifa Azo Zozome. Sorry if I missed the name. She's a psychiatric resident from Accra Psychiatric Hospital and a Merck's Foundation alumna from Ghana. So I want to say karibu to all of you. I'm learning it gradually. So this presentation is going to be short in just a few questions. Again, welcome. I'll start first with Dr. Nishal. Autism spectrum disorder, we know it's one of the, should I say, underdiagnosed conditions in Africa, or maybe neglected because of so many reasons. And it's a good thing that we are here to discuss it today. Let's have an insight on it such that primary care physicians and other physicians around can understand what and what to do. So the first question is, what are some current challenges in identifying autism spectrum disorder in children in Africa and in Asia as well?
Thank you for your question. Yes, well, identifying autism spectrum disorder in Africa presents unique challenges, especially influenced by factors like limited healthcare infrastructure, cultural perceptions, scarcity of diagnostic tools, and trained personnels. Usually in Asia and Africa, we have very few specialists like developmental pediatricians, psychologists, psychiatrists who are trained to identify, to pick up all the red flags pointing toward the diagnosis of autism spectrum disorder. This definitely leads to underdiagnosed child with autism. Furthermore, across Africa and Asia, autism is usually misunderstood or even stigmatized. There's this popular belief that it's most of the symptoms of autism are attributed to supernatural powers or poor parenting, and families usually fear to address or to go to the physician or to seek advice. Moreover, there are some symptoms like avoiding eye contact or lack of social engagement, which may align with normal social cultural norms in these countries. This again renders it difficult for physicians or for these children to be diagnosed. Again,
Yeah, so basically,
yeah,
you've
and
touched on the
yes,
challenges. Basically, you mentioned the fact that infrastructure is one major
Yes.
challenge, cultural aspect, which is one that I think everyone have an idea of. We may have experienced it in our various practices. That's a major one as well. So thank you for that piece of information. Dr. Lorraine, what are some specific developmental milestones that one should look out for when they assess a patient that is suspect of having autism spectrum disorder?
A tiny disclaimer from my side. This is a neurodevelopmental specialty, which I don't think I'm well equipped in. But yeah, from a general pediatric point of view, it's usually affects anyone, any race, ethnic group, or sex, more boys than girls. And usually, like he said, it's missed because it's not one of those diagnoses that you can quickly make in a casualty. And you are dependent on a multifactorial, multidisciplinary assessment of the patient. When I say multifactorial, first of all, the parent need to pick up that there's a problem. And when the parent pick up that there's a problem in communication, social behavior, and just adjustment of the child, which is very difficult in the type of setting we practice in. Because most of the time, it's a parent of a family with a tandem children. For them to pick up that this one child is having an issue, it takes them a while. So by the time they get to us, it's a delayed diagnosis. And and mostly it's developmental delay in the child's speech, in the child behavior, where they have rigid, repetitive behavior issues, where they tend to speak like have a repetitive speech like echolalia, like they will repeat every word that the next person is saying. They don't actually have proper communication, and some of them are actually disruptive. And that's when the parent starts coming to you, when the disruptive behavior starts coming in.
Thank you. Thank you. Dr. Amida, so we've learned from Dr. Nisha one very pertinent part, which mentioned personnel not being well-trained and they might miss out on diagnosing the patients. So in your view, how can a healthcare professional be well-trained or better trained to handle such cases, especially in our setting, such low or middle income countries? How do you address these things as a healthcare professional so that they get the necessary training that they need to identify these patients in time so that there's early diagnosis and they can seek care as best as possible?
Okay, thank you for the question. So I want to echo what the other speakers have said, because we have the similar case, because we all come from the low, middle income. So what I can say, autism spectrum disorders is a disorder that has typical characteristic, which the previous speakers have said, typically present with delayed speech, poor social interactions, and behavioral disorders. So how can healthcare professions identify do early detection of children with these disorders, the most commonest presentation that the child will be brought by caregivers or parents to the health facilities is delayed speech. That's the most common presentation. Other presentation, most of the time, the parents will not take care, will not be bothered with. The child is just a stubborn child, but the delayed speech. So you find that a 4-year-old boy come to the clinic, and then the boy is not able to make a meaningful word, not even a sentence, a meaningful word. So that is something that any healthcare provider it has to click in their brain that this is not right. But it's not everyone that is able to pick that. So one thing that we have to do is we have to create awareness. And creating awareness, like I did my medical school 15 years back. I did not, there was no topic of autism spectrum disorders. So I think as we are moving ahead, we should have, like in Tanzania now, these are the interventions that are in the pipeline. So we are about to start to have these autism spectrum disorders special topics in the formal training, in the doctors, nurses, and pharmacists, because we know these are the people that will these are the people that normal will attend. Yeah, the parents will bring their children to these healthcare providers. And again, for some of us who did not have the chance to get to be taught in the undergraduates, so we have to have the short trainings in service short trainings, and this has been done, and it's something that is being, it's continuing to be done. We have, because at the moment we have like 3 pediatric neurologists. So at least we are in the good shape compared to some of the countries. So they normally do mentorship, and this can be done through the telemedicine. We have Zoom meeting, and they normally go to the remote areas where they do mentorship to the healthcare providers there. And as well that they normally go to schools and actually talk to the teachers and teaching them on the red flags of children's autism spectrum disorders. Yeah, so that is something that you have been doing so far. Yeah, so.
Good, thank you. The idea of going to school is very important because, the teachers spend most of the days with the children, so they can pick up these things faster than at times even the parents. So having the teachers involved is a good one. So I hope we can all pick it up as well in our practices such that we identify these cases as fast as possible. I'll go on to Dr. Matimba. Dr. Matimba, she mentioned issues of preparing and training other people, but it's a collaborative effort from everyone. And that is something that we should all consider and take seriously. But in your practice, how do you integrate routine screening? Do you consider integrating routine screening for autism spectrum disorder in these patients that come for regular visits, maybe when they come for their vaccinations, some growth assessments and other checkups? Do you routinely incorporate it into your screening of the patients?
Thank you. So unfortunately, that is not happening in my country because like Dr. Kalombola mentioned, it's been a neglected field. And unless a parent expresses concern, a lot of these children will go undiagnosed. I think similar to their situation, this is when we have an established program that is training neurologists in our country. So we have 2 for the whole country, pediatric neurologists. So they can only cater for children that are coming to the hospital where I work. So we do not have a regular screening program, but I think now there's a little bit more teaching to postgraduate students who are undertaking their fellowship in general pediatrics. And hopefully as this go back to their centers because they come from all over the country, they can take back the skill and the knowledge that they've gone with and go and begin some of these screening programs. Indeed, it requires collaborative efforts, and there are a lot of opportunities, I think, that we've not taken advantage of. Well child visits, for example. Excuse me. Children will just be given a jab and sent away. The way it will be taken and they'll be sent away. When there is clear recommendation, even from WHO, that right from the first year of life, children should be screened for autism within the first 24 months. And there should be deliberate screening at 18 and 24 months so that the diagnosis is made early and intervention are put in early, because early intervention improves outcomes. But I think common to all low economic resource countries, we tend not to follow what we must be doing. I'll give an example. When a baby is born, we'll have a book that has a newborn assessment, a detailed newborn assessment. All that to be entered there is with the APGAR score and the weight, and the mother is sent away. A week later, you are receiving a baby who has total circulatory collapse. Why? Because they had a critical cardiac condition that was missed. And all we needed to do is examine this baby. Is there anything unusual? Is the heart sounds unusual? Of course, that has its own challenges. It's because we have few people that are trained to actually do these things around. And it's also the huge number of patients. You'll have a children's clinic where children are getting their vaccines. It's about 100 babies. So, and you have a nurse or two in that situation. Really, they'll focus on giving the jab, because once they've opened the vaccine bottle, they must use it. Otherwise, it goes to waste. And somebody is going to make them accountable for that vaccine that went to waste. But nobody's going to ask whether they did a developmental assessment or not. So yes, there are a lot of gaps. Yes, there's need for a lot of collaboration from everybody who's coming in contact with a child, whether it's a well child visit, it's an unwell child in the hospital. We need a comprehensive assessment of patients so that problems like autism are picked early on, and hopefully there's intervention to support these children and their families. Thank you.
Thank you, Doc. Very insightful. Thanks. Dr. Jennifer, so what are some tools or guidelines that one may consider as screening tool to use in assessing these patients? Because from what I've gathered so far, there's limited information, there's limited training, there's limited experience with these cases. So most often it goes unnoticed until the diagnosis is made late. So in your experience, what are some screening tools that one may use? What are some methods that one can use to be able to assess these patients and catch these diagnoses as early as possible?
Thank you so much. First and foremost, there are many tools which are used, but I'll bring the challenges with the tools that are used. For example, most of these tools were not developed in the African or the Asian setting, but developed in other countries. I'll give an example of one of the questions in the tools. Can your child identify a bathroom sink? So if you used this question on a child in a rural setting, for example, who has never seen a bathroom sink, they'll be disadvantaged in that tool. Then secondly, some of these tools are very long. I'll mention them. Some take about 30 minutes to 90 minutes in assessing a child. So as you realize, most of our clinics can be so busy. For example, in my country, we have 4 pediatric psychiatrists, and the recent census, the population below 17 years and below is 51% of the population. So that means we have like 1 pediatric psychiatrist for 5 million people. So, so that's the other disadvantage with the tools that we have. So the tools that we have available, basically, we have the diagnostic and statistical manual. That's the 5th edition. So that helps to categorize the autism. For example, What are the neurological deficits? Are there any intellectual disabilities which are there? Then also we have the ICD-10. So these ones here, basically, you want to get the subtype of the autism. Then one of the tests which are really, some of the screening tests that we have are the M-chart. So the M-chart is the modified child checklist for autism in toddlers. So this has about 20 questions. And so it gives you either someone has a mild, has a moderate risk or a high risk. So if someone has a high risk, then they are taken on for further screening. And then the test which has been proven in Africa is the RITA-I, which is a test for, let me just get the full of it. The RITA-I is the autism test for screening the babies. So for it, it has basically, it's been shown to be applicable in the African setting, for example, because it's been shown to have a specificity of about 100%, sensitive to 100%, a specificity of 84%, and a positive predictive value of 86%. So this can actually be used as a screening test. Then you can actually go to other diagnostic tests which could be available in our setting. Thank you.
Thank you. Thanks. Dr. Chosaka, so I would like to ask you on barriers. What are the main barriers in accessing diagnostic services for these patients with suspected autism spectrum disorder?
Okay, thank you for the question. I think there's a paper, the International Association of Neurology in 2014, they had a workshop, I think in Kenya, and they invited sub-Saharan Africa countries to come for that workshop. And in that workshop, what they were essentially doing was to try and identify the barriers that are associated and the challenges that are there that are associated with making the diagnosis of autism. One of the things is in Africa or sub-Saharan Africa, where we are, is the burden of disease in terms of like infections. It's very high. And you find that you then focus on things like severe pneumonia because a child dies every 43 seconds from severe pneumonia. While in terms of the children who are autistic, they don't actually, let's say, die in a way. It's not something that will kill the child in the next 2 years or something like that. So you then find that we tend to focus on neonatal, neonatal mortality, and we want to improve those first. So we are not paying attention to not only autism, but let's say neurodevelopmental ADHD. We are not, investing into those because of the burden of disease that we have. But when they then set, one of the challenges that they discovered, as everyone was saying, in terms of they then tried to say how many specialists can make a diagnosis of autism. You find that in my country, by then, there was just one neurodevelopmental specialist. There was no neurologist. It's only now that there is a neurologist and a neurodevelopmental specialist. And it's costly to make a diagnosis of autism. I remember when we were then training, because we had one neurodevelopmental specialist, she would then say it's not possible for me to do clinics for autism at like a government institute because of the sheer numbers, because cerebral palsy is, you have a huge chunk of patients who have cerebral palsy. So you find the clinics are full of patients who have cerebral palsy. And as she said, it takes time to deliver those tools. So you probably need 90 minutes with one patient, but you have also 20 patients who have cerebral palsy who are coming in daily. So it's not possible per se to then dedicate your time towards that. So she would then invite us to say to one of her private clinics to say, come and witness how we make a diagnosis of autism. So a child would come, they would leave the child to play. She would be busy talking to the mom, and they would just be watching the child. After probably 30 minutes or so, they bring another child to see how the child interacts with the other child, because they said it's about social, social impairment. How does the child behave when there's another child? How does he share toys? Does interact well with the other child? So those are the things that they will be looking at. So it then becomes difficult, because after 2 hours, that's when a proper assessment has been met, and it's costly. Just one session would go for $250 to $500. Why? Because in those 2 hours, for a pediatrician, you'd have seen 4 or 5 patients. She has seen one. So for it to make business sense, because they're in business, of course, it then means that she needs, the charges are very high. So you find that these are some of the things that we have. And also, as you were saying, the tools were made for European kids, and so they're not tailor-made to our own patients. I think he touched on it a bit to say, for me, if in our culture, if a child looks at an adult, like you look at them like in eye contact, it's disrespectful. But it's in terms of screening for autism, it's one of the questions is, does the child maintain eye contact? And if it's no, then you are now screening towards autism. So we need to then tailor make our own developmental tools that will assess, that are culturally acceptable for our own people. So I think it's the cost, it's the time that's involved, and generally the tools, even the tools that we are talking about, you have to buy them. They're expensive. You have to purchase them online. You can't just administer it too. You have to purchase that too. So it's not possible given the resource constraints that we have. So we need to. I think their conclusion was, we need. They'd promised to say in the next few years they will come up with guidelines, but I think because of COVID and all the other things that happened, I tried to get in touch with one of them to say, where are we in terms of the things that the recommendations that you had made? Because they'd said probably they will have to come up with tools and teach general pediatricians and just nurses and doctors, because even the awareness in our health, the health systems, when I was told that we will have this discussion, I just, one of the days, I just asked my interns and the nurses to say, how do you identify someone who has autism? And the answers were interesting. So you'd find that our own interns, our own nurses have no clue what autism is all about. So we need to start there, teach them, and then we build from there. Thank you.
Thank you. Thank you. That's quite revealing, understanding the challenges, because I thought there's autism societies and other things around doing these donations and other things, but we'll get there somehow. Dr. Imefa, so how can a practitioner like you and myself and everyone navigate the challenges like language barriers, especially in our cultural setting, those kind of challenges, and cultural misunderstanding, because that's one major barrier, cultural misunderstanding. How can we navigate such challenges and relate with the families and the community so that they can get involved in the diagnosis process?
Okay, thank you very much. So when we talk about the language barriers or cultural misunderstandings, it starts from making the diagnosis. We've mentioned some of the screening tools. In our facility, we don't make a diagnosis based on a screening tool, because autism, you need to be very culturally competent to make a certain diagnosis. Like Doc mentioned, talking about eye contact, you need to understand the dynamics of that culture. So I would be very hesitant to make a diagnosis of autism if, one, I don't speak the first language that the client and their family speaks, if I don't have a good medical interpreter. And let me give you an example. Okay, so clients and their family comes in and they say the client is misbehaving. It can take 30 minutes to 40 minutes to actually understand what that symptomatology is. And sometimes, even when you are speaking the same language, what you may intend to pass across is not what the person receives. So you ask a client and the mother tells you that my child is not talking. And then you probe and you probe and you probe and you realize that you have to take a corroborative history. You don't take a history in only one setting so that in the house you say the child is not talking, child doesn't interact with people. If you don't take a history outside, it's common to see children who talk in school and talk in church or talk with only particular people in the family. And the parents are shocked that this child talks, they talk. So it's a skill. Again, do you know about transitionary objects like children who have comfort toys, so blankets, and it's very Western, at least where I come from. I have not seen a child have a favorite blanket or a favorite toy or something of that sort. So if I'm making a diagnosis of autism in another culture, I might be tempted to think that that is sensory seeking. You know, the child has issues with sensory regulations and wants that. So being culturally competent is key. There's a WHO training kit on cultural competency in the diagnosis of autism and even in the communication of the diagnosis. Again, when it comes to language barriers, sometimes we find it easier to have, in my facility, we have pre-prepared hard copy literature so that they can go home with it. Sometimes the technical terms may elude you, so you can go home with it and think about it. And then if you have questions, you come back. Sometimes you can have animations at your OPD. I know a lot of people may not have screens, but you can even have, so now we have an app because we find that internet coverage is fairly good. It shows the repetitive behaviors. So then when a mother comes and I have to ask her, are there certain things that your child has rigidity around? It can be difficult for the mothers to identify that my child has this rigidity, but if you show a video of a child lining up their toys, same colors, so all yellows, all reds, all greens, it starts to give you a clue. Again, like I said, observing it only in one setting might be challenging because traditionally in my country, children are taught to be seen and not heard. So if you're observing a child in a consulting room and you expect that that child should interact with other children, that child may have been taught that when adults are there, you don't talk, you don't play, you don't make noise. So there may be cultural competency. So when we improve our cultural competencies, we can navigate the cultural misunderstandings. When it comes to the language barrier, you might need to have a medical interpreter. And I say medical because there have been several times when a relative is interpreting and I ask a question and then the relative speaks for about 1 minute and then they report to me in 2 sentences, oh, they are fine. And I'm like, but you spoke for 2 minutes. So it means that I'm losing valuable information. And because it's such a refined, you need a lot of skill to make that diagnosis. I'm not very comfortable with that. So what we do is we train the common first languages in our facility. So what that temper tantrums, you can ask a parent, do they have temper tantrums? I mean, the first time I saw a Caucasian child have a temper tantrum, I thought that was emotional dysregulation. But they just got up after they got what they wanted and then they went their way. So if I were in that culture, I would think, no, this child has a problem. Okay, so sometimes the language, if you ask, when your child is angry, do they hurt themselves? They may or may not give you some answers, but if you are specific, do they bang their head against the wall? Do they bite their nails to the point where they are bleeding? Do they pull out their hair? Then you can tell that, okay, so this is not a normal temper tantrum. This is now self-injury behavior. So I think that Autism Speaks it's an NGO in the various countries, and they have cultural competence toolkits for each of the countries. Yeah.
Thank you. Thank you. So understanding that is very important because, you know, most times speaking or communicating in medicine is very important to the relatives, to the patients. Any misinformation, it goes across negatively. Even if you speak in English and the person speaks English, when you say one thing and they ask them to repeat, they'll say completely different things. So it happens. But then I would like to ask Dr. Nisha a question because I'm a person, she mentioned something about developing an app and thing because I think incorporating these digital things into medicine now is another way of going about easing our diagnostic process. So also with that, telemedicine, digital medicine, and other form of technologies, how can we leverage it to expand our care given to patients of autism spectrum disorder?
Thank you for your question. Well, I think telemedicine hold a substantial role in expanding the access to these children. First of all, we can come to video consultation in remote areas. You can have like Zoom or Teams, where the autism specialists will observe the child behavior and interact with the family, and then make a provisional diagnosis, and then can give advice how to for local healthcare providers to make further assessment, and then come back again after a few weeks, and then just give feedback about all the assessment they made. Again, how my all other colleagues say, like there are many apps where teachers, parents are made aware of all the red flags we need to pick up to refer the child to be specialist. I think this is the most important things, because before the child reaches the autism specialist, it's a very long way before picking up the red flags is most important. And teachers who are with these children every day, they all lack training to just find these signs, these like avoiding eye contact, lack of social interaction. So I think
Thank you. I was saying that with the telemedicine, you can do consultation, because we find ourselves in a setting from obvious fact that we don't have many trained pediatric neurologists. So a pediatric neurologist could sit in Tanzania and consult in Ghana, in Cameroon, and other things. That way you can, it's another way to reach out to persons in those faraway places. But I would like, time is much spent, and I would like to just ask a final question to Dr. Emefa. And this is just in relation to what you spoke about earlier, is how is it that we navigate difficult situations wherein some parents are unwilling to seek further care or even accept the diagnosis? How do we navigate such difficult situations? Because
Okay, for psychiatry, we say that your relationship with the client is a therapeutic relationship. So what that means is the relationship is a part of the treatment. It's a part of the management. So many clients and their families respond or engage with mental health services or health services in general, sometimes because of a single practitioner and how that practitioner related with them. When you think about the stages of grief, right, the first stage is denial. So if you're speaking or you break a diagnosis to a family, I think your child has autism and they are unwilling to continue seeking treatment, it does not mean that you don't disengage. The key thing is to maintain the therapeutic relationship. One way of doing that is to focus on the symptoms. So if the parents or the family is not willing to accept the diagnosis of autism, you can have them come back in for the self-injurious behaviors. You can have them come back in for speech therapy. It's just to maintain a link until they get to the point of acceptance. Again, sometimes you need to, in our setting, there are people whose voices carry more weight than others in families. So if I'm making a diagnosis with a mother, half the time she would say, don't even tell me. Next week, I'll bring my husband. And you have to accommodate these things. So it may take several meetings to get to the place where the client is willing to engage. But if you are patient enough, half of the time, and the more information you give them, the calmer they become. The more information you give, sometimes they can, transference, where the client affects your emotional state. So you're telling them and they're saying, no, it's a curse, it's something I stole. And then they can sense you getting angry. sometimes we are not cognizant of that, but they can sense that there's a barrier going up. So it's important to match their tone to understand that not everybody will accept a diagnosis initially, but if you're patient enough, they will move from denial to acceptance, and then we can engage.
Thank you, thank you. What you're saying make a whole lot of sense. I've had patients, not pediatrics, but adults that way. They relate to you based on how you relate to them. So when they come in and you see they have this flight of ideas at times, some of them you see that they're actually anxious because of their condition. But when you take your time and listen to them, the fact that you've taken extra time to listen to all of their complaints and then you try to offer solutions and ease their tension, it gives them more trust in you and they get comfortable with you. And that's another way to work. So thanks for the insight. So far, I think we've touched on the basics, and from what we've gotten, it's obvious that there's limitation in manpower. It's obvious that education is limited, but what is good is, from what Dr. Amida mentioned, that the education sector from the schools wherein the teachers get involved, the teachers are in the know of these things, it helps. I think we should spread that across such that our schools in every region gets to know. Maybe the teacher do these refresher trainings when school is off, as in vacation, they do refresher trainings and give them an insight of what autism is, and then they have an eye out for patients or possible candidates that they can be able to pick out and report. So it helps reduce the prevalence and also help us to be able to identify these cases and know how we actually have in Africa and Asia as well. So we'll now open the floor for about 3 questions.
Thank you, the panelists. The discussion was very enlightening concerning autism. I have one question. I think the other one will be some sort of an input, or you can share the experience if you ever used this method to diagnose autism. The first question, in my culture, most of the children behave different when they encounter a person for the first time. So probably you might think she or he has some sort of behavior, but probably because the first time they encounter a person, so they are learning. So I'd like to ask, from your experience, how many times should you have a consultation to diagnose a child with autism? Because sometimes you need 3 or 4 so that you can understand a child behavior. The other question or input, you discussed about telemedicine. I was thinking now most of mothers, they have smartphones where they can take a video or some sort of the short scene on how their child behave at home to supplement the diagnosis. But also on top of that, most of us mothers currently, we are having cameras in our houses where you can just follow the behavior of a child. Have we ever used this method to diagnose autism, or we can just add in one of the supplementation in Telegram to diagnose autism? Thank you.
You can take it up. I think the first question about the number of contacts to diagnose autism. First of all, as we mentioned earlier, you need time with that child. So sometimes you need to get what the concern of the caretaker or the mother is. Sometimes it's not talking, not interacting. So you don't go straight out to the tools. You try to ask more questions to get the why behind the reason. Sometimes it's cultural, sometimes it's fear, sometimes it's a new person. So in my experience, basically, you need to have given, let's say, about 30 minutes to 1 hour, but also if you haven't gotten exactly what they're looking for, then you could get another appointment to get to try to ask about, let's say, repetitive behavior or intellectual disability, something that she could be looking for. That would point me back to the next question that you asked concerning a video a video coverage of what they are doing to describe what they have come for. Because sometimes when they come to the clinical room, that exact description of the symptom may not be visible at that time. But if there's a video, it really helps to play back and see how the child has been reacting. This has helped a lot in neurology, in getting the kind of seizure, for example. So I think it can also be used like in autism. Then the other thing also, maybe I'd like to just add is we have digital technologies in autism. So yeah, that's one of them, but also we have things like mobile phones. So these ones here, there are some apps which can actually help with the screening, for example, mHealth, which can help with the screening of a particular of autism, for example. And then also there are other programs on the computers which help with the teaching. If there's a concern of a parent or a caretaker, you get a computer app, for example, a PowerPoint or a teaching. And then also you realize that the COVID-19 era taught us a lot that, you can actually do too much. You can help so many patients with just a computer program. Yeah, so I think these are some of the things that can be applied. Then maybe the only disadvantage with these other apps I've mentioned, either a computer or a phone or a video or a smartwatch. A smartwatch is very good because it gets to repetitive behavior, it can get speech. So this is also very important. So the only snag about this will basically be, for example, let's say internet, electricity, and all that. Yeah, thank you.
Thank you, thank you. So
the disadvantage with the phones also is that parents tend to self-diagnose, and sometimes that causes fear. They will make the diagnosis at home and stay away because they're afraid it's going to be confirmed. And it's not unusual that they walk in and they'll just blurt it out. Does my child have autism? So how to try and help them through sometimes becomes a challenge. So indeed, technology is a good tool, but then it also leads people to having too much information sometimes, and then it can also be self-destructive. So we need a balance. Yeah, thank you.
thank you, thank you. So once a big asante sana to our panelists. You can now head back to your seat. We're about to close for the day. On another note, a big thanks also to Merck's Foundation for having us here and making this a success. To every one of you, thanks for coming. Thanks for your attendance. It's been a great experience meeting all of us. We hope that the knowledge we've acquired, we can use it in our various practices so that we can be impactful for Africa and Asia and have a safe and healthy world. Now, bear in mind that Merck's Foundation still has 44 scholarships available. And these fields are in acute medicine, emergency medicine, respiratory medicine, advanced practicing in neonatology, critical care, care of the older person, dermatology in clinical practice, gastroenterology, internal medicine, infectious diseases, neuroimaging, neurosurgery, neurology, pediatric and child health, pediatric emergency medicine, primary care ophthalmology, rheumatology, stroke medicine, trauma and orthopedic medicine with general surgery. All of these are in partnership with the University of South Wales, the University of Buckingham, the University of Edinburgh and Cardiff, and the University of Queen Mary. So you can now find these informations at the website of Merck's Foundation at mercs-foundation.com. And application is open until the 15th of December 2024. We're also excited to announce that the new version of the Merck's Foundation app is now available on all platforms, Google Play and App Store. With this app, you can receive timely updates on all of the Merck's Foundation programs and initiatives. We encourage you to download it at your earliest convenience. Again, we say asante sana and thanks for coming.